I'm quite sure it's going to be as lively, as interesting as yesterday. So let's start.
Yes. Over to our wonderful master of the ceremony, Shom. Come, please take over.
A warm welcome and good morning from the faculties and to the faculties of ERS and Indian Chess Society and all our delegates here. We'll start the symposium. Our next symposium is on emerging concepts in airway disease, and our subject experts I would like to call upon stage Professor Ioana Chorostka. She's a professor of medicine and consultant in the respiratory medicine, head Department of Genetics and Clinical Immunology at National Institute of TB and Lung Disease, Poland. And co-chairing with her will be our Indian faculty, our Dr. Shyamal Sarkar.
So we are going to start our first session on emerging concepts in the airway diseases. There will be 3 lectures by 3 eminent speakers, followed by a panel discussion on paradigm in the management of airway diseases. For the first lecture, I would like to invite Professor Paola Rogliani. Professor Paola Rogliani is Professor of Respiratory Medicine in University of Rome, Tor Vergata, Italy. She is going to speak on COPD, not just a smoker's disease.
Thank you very much. These are my conflict of interest. And we are going to touch in these next 15 minutes COPD beyond smoking exposure, integrated early life and non-tobacco determinant into COPD pathogenesis, the advancement in COPD detection beyond spirometry, and position COPD as a preventable and also environmental-driven disease. So this is what we know. This is the projection in 2050, and that it will account more than 600 million individuals that will suffer of COPD. And unlike many other non-communicable disease, or even in oncology, they did very well in reverse the trend in terms of mortality and morbidity. We didn't do a very good job in COPD. As a matter of fact, we are still increasing morbidity and mortality. And it is right now the 3rd leading cause of mortality, 56% of total cause for respiratory diseases, and 35% of patients are readmitted in a hospital after an exacerbation within 90 days. So it means that we clearly need to do something, and that we can observe from this map in low and middle income countries, highlighting the fact that the COPD distribution perhaps is not solely attributable to tobacco smoking, but this distribution suggests that there are differences in population, in aging, environmental, occupational exposure, infection, and last but not least, health system capacity. So this is what historically has And in 2022, the Lancet Commission launched this alarm, I would say alarm, which is we need to do something toward the elimination of COPD because we can do something. And so they were highlighting the fact that the diagnosis right now, it is reached between 50 and 60 years old. So when the irreversible damage in lung function is already there, and that is the key element in the diagnosis criteria for COPD. So they were highlighting the fact that we need to intercept those patients earlier in their journey, and we need to intercept them when the irreversible damage it is not really in place. But so they were launching this signal that we need early diagnosis rather than a late diagnosis. But one of the things that I would like to put your attention, it is the fact that the assumption and the observation and the current narrative that we have in COPD, it is gained by large study, mainly phase 3 study, because our study with a large number of individuals that has been enrolled in the study, but those studies has a major bias because to be enrolled in those studies, you have to have a smoking history. So we create a narrative in COPD with a fundamental bias, which is the smoking history, and so we are missing a big part of the narrative that we need to write today and in the next future. And as a matter of fact, in the Lancet Commission, they tried to capture this very key important aspect, defining a sort of classification in a different kind of COPD, the genetic, the early life event, the infection, the smoking, and it is very much highlighted that among the noxious particle, the one that we always call just noxious particle, they need to be actually defined in this different domain that shape the new evolving concept of COPD. And also the GOLD recommendation, they came along with this concept, trying to do this classification and take into account the environmental COPD, the smoking, biomasses, pollution, trying to sort of initiate this redefinition of COPD, not only smoke-related. This is a very nice paper, and one of the leading authors is right here, Sandeep, and thank you for doing this, because we need to write the new evolving concept of COPD. And as you can see here, globally, it is represented the risk factor associated with COPD, and in here it is according to the social demographic index. And as you can see, from the high social demographic index to the low social demographic index, in the high one, we have that smoking played a major role, 74%, compared to other parts of the world where it is 45, 36, 29%, it represented by smoking history. And if we consider the world as global as it is, well, you can see that only 45% it is accountable to smoking-related COPD. There are many other causes that need to be clarified in the next future, as well as the 6 known risk factors for COPD death. And you can tell that it is represented by smoking mainly in some part of the world, but in some other part of the world it's just a little percentage. So we need to understand that there is something more than smoking that need to be defined and need to be clarified in the next future. So there is a little piece of evidence that now is coming along in trying to define this, the pattern of this new narrative that we need to write. So who are those people? Who are those COPD patients that never smoke? Here are the clinical characteristic, and we can tell that the prevalence, it is pretty wide range because it is between 4 and 16% right now based on this initial longitudinal study, but also the never smoke, the prevalence in account for a substantial proportion of all COPD cases between 20 and 50%, challenging the traditional view of COPD as a smoke-related condition. But the clinical characteristic from those studies, it comes that some of the characteristic in terms of lung function in never smoker, they have a milder airflow limitation compared to the smoking one, and they have less emphysema but more air trapping with a normal DLCO and similar exacerbation rate. But also, again, but also for the mechanism in terms of pollution and biomasses, they are characterized by airway inflammation, oxidative stress, and airway remodeling, but also the impaired lung function, it plays a major role, and we need to also focus on that very key aspect, take into account the work that has been done on the trajectory, where early life event have a role in this context. And this is from the Lancet Commission paper. So low peak lung function in early life increase the risk of COPD, childhood disadvantage, infection, asthma, malnutrition, impairs lung growth and peak lung function. So COPD may develop from low baseline FEV1 rather than accelerated decline later in life. The trajectory-based risk identification enable early preventive strategies before clinical disease is evident. This is a very interesting paper by Surya Bhatt that has been published a few months ago, where they try using two big populations, the COPD gene population and the CAN-COLD population, in trying to have a multidimensional approach to the COPD. And in this paper, they use a major and minor criteria using lung function and also imaging in trying to detect with this new approach to diagnosis, the multidimensional one. And you can see here that on top one is the PRISM pattern, the early phase patient, and among them there are also the non-smoker, highlighting the fact that smoking is an important risk factor, but not a prerequisite for clinical meaningful COPD. And I tried to update this presentation just yesterday, but apparently it went through because there is a new paper that just came out a couple of weeks ago that confirmed this multidimensional approach. And there were very nice data regarding the non-smoker population because with this new criteria, so with this new reclassification in non-smoker, tell us that the non-smoker are not defined by air obstruction per se, but rather than a combination of symptoms and structural abnormalities that we can detect at the CT. So we need to rewrite what we call COPD, because as in the gold recommendation it is stated, it is not a disease solely defined by smoking. There are many other mechanisms and major cause of COPD. And as a matter of fact, the proposal of this new taxonomy, the new classification, right now is just a proposal, because we need studies that really can be designed and conducted to really explore this new chapter or chapters that will redefine COPD. So COPD is preventable, also environmental-driven disease. Non-smoking COPD is common and central. Prevention requires public health and policy action. Early detection is key to reduce disease burden. Reframing is essential for elimination of COPD. Thank you very much.
Thank you, Paola. So now it's my great pleasure to invite Professor Omar Usmani. I don't believe Omar needs an introduction. Let me just say that he is the current ERS Science Director and well-known clinician and researcher in respiratory medicine. And Omar is going to speak about small airways involvement in asthma.
So thank you very much, Joanna. It's my absolute delight here to be in Delhi, and today I'm going to talk about an area that you've heard me talk about before. I was in India, in Delhi in August, and I'm very passionate about it, and here I talked about it at ERS. There is new data that I'm going to be presenting to you today. So in medical school, we were always taught that asthma is a disease of large airways. This is incorrect. Asthma is a disease of the whole airway tree. You have to think of 3 compartments. We forget the nose, the top part. We always focus on the large airways, and we forget the silent zone, the bottom part. And asthma is a mucosal carpet of inflammation that starts at the tip of your nose and ends in the small airways. So why are we as pulmonologists ignoring the 2 key areas, the silent zone and the nose? No wonder our patients in 2026 in the UK, in Europe, and in India are uncontrolled with asthma. Yes, there are many comorbidities. Yes, there are cofactors. It's because fundamentally we are ignoring the small airways. Qutaiba Hamid, who was in Canada, went to Sharjah and passed away as a pioneer in biopsy. We talked about remodeling in asthma. No study has truly shown that biologics remodel. No study has shown biologics remodel in COPD. This study, transbronchial, endobronchial biopsy, we were talking about interventional. Look at the x-axis, choose your cell. Look at the red bar, transbronchial, small. Look at the blue bar, endobronchial. You can see that they are equal. So the disease is the whole airway tree. Why, as pulmonologists, are we ignoring the small airways? And now COPD. Jim Hogg for 50 years has published data on COPD, seminal paper from the New England Journal. Look at the x-axis, choose your cell. Look at the graded bars. Look how they increase from mild to severe. First point, even in your patient with mild COPD, mild asthma, they will have small airways inflammation, full stop. Second point, this worsens with worsening disease severity. And third point, look at the third bullet point. 20 years ago, there was eosinophilic inflammation in about 20% of patients, not in all patients with COPD, only in 20. Biopsy data, proper science, not blood. So there are biomarkers that we can do, imaging, biology, physiology. Time today doesn't permit me. I've come to India on many occasions. We've talked about all of these modalities. But what I am going to talk to you about is the importance of us recognizing small airways. So look at the red dotted line. 50% of your patients will have small airways disease. What does that mean? Every second patient you see in the clinic. What do? We poison our patients. What do I mean? We use devices and therapies that target the large airways. Very good. But they miss the small airways. Then what do? We increase the delivery of the drug to the same region. A step 1 asthma becomes step 4, and the next thing they'll be given an expensive biologic, which is just a very expensive form of targeting the whole airways. So people say, tell us that small airways link into patients' outcome, and they do. Look at these 2 graphs. Look at the first one, green dots, red dots. Uncontrolled asthma is directly related to small airways inflammation, alveolar nitric oxide. And we can talk about alveolar nitric oxide. There are 2 commercial machines now. One has come out from China, validated, and has a global kite mark. Look at the right-hand slide. Worsening x-axis of small airways inflammation, worsening ACT. This is a really nice study done by Brian Lipworth. And really he looked at moderate to severe asthma. Look at the blue squares and look at the red circle. The blue squares are markers of oscillometry. Oscillometry now has been validated. Population data you have in India, global data, it's clear it gives you an added value in terms of assessing your patient's lung mechanics. Look at this. The red circle spirometry, absolutely no difference. Look at the blue. The oscillometry measures showed that they were significantly related to worsening asthma control. So the studies are there and they have been accumulating now, because I'm always asked, tell us that small airways actually make an effect on patients. Well, they do, and the data is clear, and again, time doesn't permit me to show you all the slides. Move to COPD, Crisafulli study. Small airway measurements. Look at the 4 boxes of the old GOLD classification. Look at GOLD A. 50% of your COPD patients will have small airways disease. And this rises to nearly 100%. Look at the second box, and we've spoken about CAT yesterday, and you'll see it again. Direct relationship to small airways disease is related to health status. And you can clearly see that in the gray bar when you have a CAT more than 10. So the Atlantis study was a great study, and then it looked at understanding the phenotypic classification of small airways. So what I want to say before I show you this slide is small airways now we should think of as a treatable trait, as a phenotype, as a comorbidity. In the same way, when an uncontrolled asthma patient comes to your clinic, you think about allergic rhinitis, you think about pollution, you think about the bedding, you think about the pets, the cats, the dogs. You need to think about the small airways firing with inflammation, yet not controlled or cooled down with any form of medication. So look at the x-axis, RVTLC, the gold standard in small airways, and look at R5 minus R20. And in this study, which was the second study of the Atlantis group, Monica Kraft showed that a change in small airways was significantly linked to predicting exacerbations in the first year in patients with asthma. I actually went back to the study by Meilan Han from 2017, and that also showed small airways is linked to COPD exacerbations. So COPD Gene, who have used the imaging of parametric response mapping to get an index called FSAD, functional small airways disease, you can clearly see PRM, parametric response mapping, in the blue circle. Functional small airways disease was able to actually show that abnormality on imaging of the small airways was linked to acute exacerbations in COPD. So let's now move on to the treatment. Ciclesonide is a great steroid, probably one of the best steroids out of the 7 that we have. And you can see that it has an MMAD of 1.1. Eric Bateman, who unfortunately passed away a few months ago, was a leader in the field in understanding asthma and the global burden of asthma, and did some fabulous studies in the 1980s on ciclesonide. And you can clearly see that this reaches the large and small airways when using PET scan slices in the first slide. In the middle slide, you see now BDP formoterol, beclomethasone, has a small particle size and can achieve large and small airways distribution. The third slide, you see triple therapy, particle size 1.1, can achieve large and small airways. So the device formulations are there to allow us to treat as mono, dual, and triple therapy. We are in the UK now a license for triple therapy in asthma. I'm sure it'll be coming. So the GOLD directive now in 2019 clearly stated that the particle size in extra fine is able to target distal airways. This is the updated GOLD 2026. So it's very clear that you can target and modulate this mucosal carpet of inflammation by using 3 things. 1, particle size. 2, the aerosol particle fraction. And 3, the rate of inhalation of the aerosol device and the way that the patient inhales. So now I want to show you some new data, a real-world data, and I think this is very relevant to to us in Europe and you in India and the Far East is understanding what happens in real world. So this is the MASCOT study that Kostas Kostikas from UANA led on, and really what it did was take patients who had COPD and they were on dual bronchodilator, and there was a need then for a certain group to step up to triple therapy with beclomethasone, formoterol, glycopyrronium. You see that in the elongated long bar on the top of that diagram on the right. Visit 1 baseline, visit 2 after 4 weeks, and the primary endpoint here now was a small airways marker, because I've always been challenged. Show us that a primary endpoint of small airways is responsive, not as a secondary endpoint. So a priori, this study was powered for the primary endpoint of small airways. And what did they find? They found really nicely, and I was so excited by this data, that R5 minus R20 improved, and then you can clearly see that AX improved, and you can see X5. We had a discussion yesterday and also in Hyderabad about the 3 indices. We've talked about these indices before, so for those that are unfamiliar with them, then speak to colleagues in India, or there's many publications now showing the oscillogram and pattern recognition of the oscillogram. But AX and X5 are also good markers of small airways. And this is the key. Those changes in small airways were linked to quality of life and lung function improvement. I also need to say this now. Small airways is a treatable, or is a phenotype in ILD, in sarcoid, in bronchiectasis, in HIV, non-infective lung disease, in lung transplantation. We need to think about this as cross-cutting across all respiratory disease. And I say this because we recently published data in sarcoid, in chest, 5 months ago, looking in a large cohort, where in sarcoid we get spirometry. Some is obstructive, some is restrictive, some is mixed. We look at the X-ray, then we categorize on the X-ray. And what we found clearly is oscillometry. Small airways measure was linked to symptom burden and quality of life in sarcoid more strongly than spirometry and other indices, indeed more strongly than DLCO. So finally, actually ahead of time, I want to present this study that's just been published in the European Respiratory Journal, which has an impact factor of 21. This is the first study in the world ever to compare the same drug at the same bioequivalent clinical prescribed dose, testing the hypothesis: does targeting different regions of the lung change physiology, and is it beneficial for patients? We used HandiHaler. You see this on the left-hand side. The device is a powder. It targets the large airways very effectively at 18 micrograms. We then used a soft mist inhaler on the right that targets the large and small airways. It has a high fine particle fraction and a slow inhalation that allows the aerosol to gently and smoothly cover the large and small airways. And then we looked in this real-world study in these patients who were enriched for small airways disease themselves, and they had oscillometric assessment. So what did we find? Look on the y-axis, and this is the FEV1. So what would we expect? A large airway delivery of a LAMA should improve the FEV1, and it did. So we had an improvement in FEV1, but this improvement tailed off over time with the DPI. We then switched after 2 weeks to the SMI, the improvement on the day in front of us in clinic, and you can see it was reasonably static. So what does that mean? That means both are good at targeting the large airways, both make an improvement in the FEV1. Interestingly, the soft mist was slightly better at the end of 2 weeks than the dry powder, showing that the way the aerosol gently goes to the airways is interacting with the receptors at the molecular level. This is what we hypothesized. But most importantly, this is the key, the crux of this study. The y-axis R5 minus R20, the DPI, so if you go down, you make an improvement, made an improvement, but this was lost almost back to baseline at day 14. The SMI that targets the large and small airways went down, improvement on day 14, and then continued a trend down. So this is the first study to clearly show that actually targeting the small airways improves lung physiology when you have precise measures of lung mechanics. And the CAT, you see that as the third bullet point in the black box, the COPD assessment test, a measure of patient outcomes, showed a trend to improvement. The study was not powered on this, but I'm just really pleased now that this data is accumulating to show that gut instinct of that hypothesis that we had 10, 15 years ago, that the pathologists and physiologists clearly tell us every single time we've got to think about the small airways. Well, we need to really see. Why? Because it makes a difference to our patients. Param Nair and his group have recently, I was asked to write the editorial on this, have recently looked at extra fine in T2 severe asthma and have clearly shown that fine particles are able to extend beyond the mucus plugging, the inflammation. So, in summary, very much, this was a study that said if you don't have any technique, what should you do in your mild asthma patients? It was an independent study, and what you should do, 86% consensus, think about treating the whole airways trees. This is what the Spanish leading experts said. And this is something that I wrote with my fellow, who's now a consultant in Greece, who came on an ERS fellowship, a short-term fellowship, and you can see now that this concept of small airways disease must be ingrained in our everyday practice. So I've talked about pathophysiology, talked about the prevalence, talked about targeting the airways trees, the patient trials, and on that note, thank you very much for your attention.
Thank you, Dr. Usmani, for highlighting the importance of small airway disease, its functional and clinical importance. The third lecture is on, is home nebulization an option in severe but stable COPD? And this lecture was supposed to be given by Dr. Agrawal, but because of some reason, he could not come. But thanks to Dr. Neil Thakkar, he agreed to present this presentation. Neil Thakkar. Neil Thakkar is consultant pulmonary and critical care physician, Zydus Hospital, Vadodara.
A very good morning to all the respected colleagues, friends, and seniors and colleagues from the Indian Chest Society and the European Respiratory Society. Thank you to the organizing committee for this opportunity. So again, as sir has already mentioned, that I have tried to do justice to this topic since last night from today, but whatever best I could involve. So what I want to do is we want to cover various case scenarios. I made it in such a way that the take-home messages are very clear. So when we talk about COPD is a disease where there is significant chronic airway inflammation, there is loss of the alveolar attachment, there is small airway dysfunction, and because of all of this, there will be a lot of air trapping. And when this also affects significantly the smaller airways. So the GOLD guidelines definitely tell us that when do we consider a patient with a diagnosis of COPD? If there is breathlessness which is progressing over time, worse with exercise, chronic cough, recurrent wheezing, a history of risk factors such as smoking, exposure to air pollution, vapes, gases, host factors such as genetic or birth weight, prematurity, other risk factors are there. When a clinical diagnosis is established, we go for a lung function test which shows that the FEV1 by FVC ratio, if it is less than 0.7, we see again the ratio and we confirm that there is significant airflow limitation in such cases, and we can confirm that this patient has a chronic obstructive pulmonary disease. After that, the GOLD grading identifies mild, moderate, severe and very severe according to the airflow limitation with the FEV1. And the GOLD 2025 guidelines have the ABE assessment tool where based on the clinical features, after that the lung function test and the exacerbation history, the CAT score and the MMRC, we are able to identify which stage the patient is in. This is important because of the case scenarios I'll discuss now. So nebulization therapy is probably the easiest to use. It needs minimum cognitive abilities, no actuation or inhalation coordination. There is patients with dexterity problems, hand strength is not required. A wide variety of drugs can be used. The disadvantages, it is time taking, costly, and there are maintenance and cleaning issues. What is maintenance nebulization? Chronic nebulization for more than 3 weeks at home. Home nebulization is an umbrella term which refers to usage of short term of this nebulizer at home. So who are the right candidates? We'll go by different case scenarios. This is the first case scenario. 72-year-old male with severe COPD, FEV1 of 32%, CAT score of 26, MMRC 3 on LAMA-LABA DPI. The patient had around 0 to 1 exacerbations, one exacerbation in the previous year, stable for months, is frail, sarcopenic, and has still saying that I'm using the inhaler regularly. But patient has morning dyspnea and no benefit from using the DPI. And patient keeps repeating the inhaler. So whenever we all face such case scenarios in our clinic, so what would we think in such cases? We check that the inhaler steps are correct, but the patient's peak inspiratory flow is very low. So then in such cases, it is not a problem with the drug, it is a problem with the delivery failure. So suboptimal peak inspiratory flow rate, this is one scenario where there is a role of home nebulization. Decrease in lung function affects the patient's ability to generate adequate inspiratory capacity, and that causes that in such cases using a nebulizer would help in reducing the readmission rates as compared to patients on DPIs. This was published in the American Thoracic Society in 2017. So specifically rapid decliners and frequent exacerbators with a low peak inspiratory flow rate. This is one population where there is a role of home nebulization. Second case scenario, 68-year-old female with severe COPD, FEV1 38%, CAT score of 22, MMRC 3, 2 exacerbations in the last year, and again is now stable. But this patient had rheumatoid arthritis and hand deformities, has mild cognitive impairment. So patient started using MDI and spacer but was having a lot of repeated errors. Cannot coordinate reliably, frequent critical errors were there. So here the limitation is physical, not the motivation. So again, this case cognitive impairment. If there is an impairment in the memory, attention, or in such cases, this leads to lower adherence to treatment, increased rates of hospitalization, as well as increased mortality. So second case scenario where cognitive impairment is there is a role of home nebulization. This study was published in Pneumologia in 2015, which evaluated cognitive impairment in COPD, and significant relationship was there even with the primary disease itself, with memory and attention, verbal memory and learning, and the prevalence of impairment in visuospatial memory was significant in this study. Third scenario, in this same case, we had muscle weakness and impaired dexterity. So there is a strong association between hand grip strength and the peak inspiratory flow rate and the functional capacity and fatigue seen in COPD. Third case scenario, so 60-year-old male with severe COPD, chronic bronchitis, CAT score of 28, MMRC 3 to 4, currently optimized with LABA-LAMA therapy, pulmonary rehab measures are done properly, no exacerbation in the last 6 months, but still patient says, I feel very breathless every day and there is significant limitation of activity. This patient does not have any cardiac illness, no ILD or anemia. Patient switches the inhaler multiple times, still no relief. Still severe symptoms despite optimizing all bronchodilators. So again, this is one more case scenario where despite optimizing all comorbidities, checking the inhaler technique, adherence, and still patient has got severe symptoms at a baseline, there is a role of home nebulization as well as some novel therapies. This was a study published in the Indian Journal of Chronic Obstructive Pulmonary Disease in 2020, which evaluated the deposition of various aerosol particles through nebulized form on the various caliber of the airways. So as and when the smallest airways are there, the deposition to the smallest airways is much lesser with the DPIs compared to the nebulization particles. Various nebulization devices were studied in this study, breath activated, breath enhanced, and mesh nebulizers. We'll come to the advantages and disadvantages in later slide. So basically, nebulized bronchodilators are maintenance therapies, not just for rescue, appropriate for patients which are inadequately controlled by DPIs or PMDIs. And this treatment with COPD is an alternative route to avoid need for inspiratory flow, manual dexterity, or complex hand-breath coordination. In severe COPD, a higher dose often means higher effective lung deposition, and not normally only in terms of the dose of the inhaler in micrograms. Nebulization allows consistent delivery during quiet tidal breathing also. In this case, this was published in this particular review. When I talked about novel therapies, ensifentrine is the new novel phosphodiesterase 3 and 4 inhibitor, which is mentioned in the GOLD 2025 guidelines. This was a study in the Blue Journal in 2023, where it showed that this selective PDE3, PDE4 inhibitor had anti-inflammatory effects. This studied patients from the age of 40 to 80 with moderate to severe COPD, and almost 17 countries, various centers, 250 research centers were involved. What this showed is that in both the ENHANCE 1 and ENHANCE 2, patients were randomized to receive LABA/LAMA as well as both these inhalers, and post-bronchodilator FEV1 predictive values were 52% and 51% of normal. The drug ensifentrine significantly improved the FEV1, the symptoms, the rate of moderate to severe exacerbations, and the time to first exacerbation. It improved the lung function in both these trials, with results supporting that there is significant effect in the exacerbation risk reduction in COPD population. It is also now recommended in the 2025 GOLD guidelines as an add-on therapy with moderate to severe COPD, where already optimized with LABA/LAMA and ICS where eosinophilia is there. And this drug is administered through a nebulized form only right now. So there the novel nebulization therapy, again there is a role of home nebulization. Case 4, 64-year-old male, severe COPD, chronic bronchitis, CAT27, MMRC3, stable for the last 3 months, daily productive, thick, tenacious cough with sputum, morning congestion, significant mucus plugging is there. Patient is optimized with appropriate inhaler therapy, but repeated doses of oral mucolytics have minimum benefit. So this is the 4th case scenario where there is a role because the symptoms are mucus driven and not driven by bronchospasm. So nebulized mucolytics have a role here with high local airway penetration, mucus hydration, and enhanced sputum clearance. And it is hypertonic saline or N-acetylcysteine can be used. And in persistent symptoms are driven by mucus hypersecretion, they target the airway pathology to cause significant bronchodilation. The 5th case scenario is a 70-year-old female with severe COPD, more than 3 exacerbations per year, predominantly infective. Currently, this patient is stable. Repeated cultures show Pseudomonas. Colonization was documented during stable state. This patient was optimized with appropriate inhaler therapy. With rehab completed, still recurrent oral antibiotics gave only a transient benefit. So this is the 5th case scenario where there is a role of home antibiotic, nebulized antibiotic, because they have a higher airway concentration, minimal systemic exposure, and target the specific colonizing pathogens. So long-term nebulized antibiotic like tobramycin or colistin, depending on the sensitivity as well as the local protocols. In selective COPD patients with chronic bacterial colonization, nebulized antibiotics will reduce the exacerbations by addressing this infective endotype. This was published in 2012 in the Journal of COPD, Nebulized Antibiotic Management Evidence and Recommendation. So this specifically gave us case scenarios where maintenance nebulization therapy is useful for COPD. So we have discussed all these case scenarios in the various case scenarios that we discussed right now. Cognitive impairment, manual dexterity problems, patient with severe pain and muscle weakness due to neuromuscular disease, patients who are unable to use MDI due to some errors or some neuromuscular or muscle weakness, patient with inadequate symptom relief using these inhalers, patient who do not comply properly and who prefer to use nebulizers, patient who still need any mucolytic or antibiotic nebulization as per their indication or the case at that time. So sometimes it is the patient's perception also that nebulization is the preferred choice. It could be because of the comfort and confidence at home. It could be because of better symptom relief, greater adoption in severe symptoms, and enhancing the overall relief in the real world COPD management. So this was in COPD 2013 and RESMED 2002, where patient satisfaction scores were studied, and they found that it had better control of symptoms, better working than inhalers, increasing self-confidence and lesser probability of going to the hospital. So various drugs we have discussed in all the case scenarios, bronchodilators, inhaled steroids, antibiotics, mucoactive agents can be used. This was published in European Society of Medicine by Dr. Rajadhar sir, who's not here today, but he was leading this, where nebulization optimization for management of obstructive airway disease. This was an expert review, NOVA ER, where they identify specific clusters in COPD, in asthma, in recurrent Pseudomonas exacerbations, so specifically with COPD treatment, 3 clusters were there. One is with intermittent symptoms, where the dyspnea and MMRC score was 0 to 1, and moderate exacerbation requiring hospitalization. Here, LAMA as well as LABA-LAMA both were used for home nebulization. If a patient has an acute exacerbation, SABA-SAMA and LAMA, and prevention of exacerbation, LABA plus ICS, where a patient has significant eosinophilia in his history or significant exacerbation history. So this also studied why in these particular cases there were various errors in the use of inhalers, which was studied right from the pharmacists to the nursing staff to the doctors, and all these numbers were significant when the patient were prescribed inhalational devices or inhalational specific inhalers. Asthma, considering the topic today is related to COPD, I'll skip asthma for now. But nebulization in obstructive airway disease, again with tobramycin or colistin, after doing proper rehabilitation, after vaccination, after optimizing rehabilitation, if still patient has significant number of exacerbations and recurrent Pseudomonas or Enterobacter infections, in such cases nebulized tobramycin or colistin can be considered, as well as long-term macrolide therapy in selected cases. Patient with frequent admissions, we check for Pseudomonas, start nebulized tobramycin. If negative, macrolides can be given. And so there could be, which is the best nebulizer is the device. So basically there are jet, ultrasonic and mesh nebulizers which can be given. There is different modalities, output rate, cleaning, cost, and as per the patient's utility, we can decide which is the best nebulizer for our particular patient. The mouthpiece or face mask both can be used, but again we have to look at the dentition, the patient's cooperation, also whether the patient has any significant allergic, any paranasal, nasal etiology, any other, based on individualized specific case we can decide. The guidelines recommend specifically inhalation wise in cases where if patient is unable to use PMDI, or this is as per the gold guidelines, or DPI, nebulizer should be used. This is treatable traits as per, again, a meta-analysis which was even discussed in my previous session, but now the ATS and ERS both focus on treatable traits. So again, nebulized specifically in these case scenarios I discussed where there are treatable traits, nebulization can be used. I'll conclude by saying nebulization does not require, it should be used where the patient, because it does not require patient coordination. Specific case scenarios in the elderly who are unable to hold the inhaler, physical or cognitive impairment or poor lung condition, and benefits are optimized by proper case selection, proper type of nebulizer, proper drug regime, and counseling the patient and caregivers. Thank you so much for your patient listening. Thank you. And again, I've made this in a short time, but I tried to cover most of the case scenarios. Thank you so much.
Thank you so much. It's highly appreciated. After 3 excellent presentations, it's time for discussion. So it's my pleasure to invite the panel discussion moderator, the Dr. Vivek Nangia. But I think this is for the moderators. So as you can see, the panel is going to discuss the changing paradigms in airways disease management.
Good morning, ladies and gentlemen. It's indeed an honor for me to be here and discussing on a very important topic that we face in our daily practice. And we have a galaxy of panelists today, this morning, for this very important panel discussion. And let me start with inviting Professor Omar Usmani, Professor Paula Rogliani, Dr. Anshum Aneja, Dr. Amina, Dr. Neil Thakkar, and Dr. Mahesh. Dr. Neil Thakkar is not just a good orator, but also the speaker for the spokesperson for ICS, I realize, and has very kindly offered to fill in the shoes of Dr. Gyanendra Agarwal, who's due to some urgencies at home couldn't make it this morning. So I won't take much time as we're already running short of time and running a little late. So we all know that chronic respiratory diseases are among the leading causes of morbidity and mortality, and we experience that in our daily practice. COPD, asthma being the leading diseases amongst them, and the numbers are only rising with the rising levels of air pollution in our country. Over 35 million people are affected by asthma in India, and if you look at the global figures for COPD, 212 million cases in 2021, and in India alone there were about 37.8 million cases. So a huge, humongous number that we're looking at. So Professor Osmani, let me start with you by asking you the question that how has the concept of airway diseases evolved in the last decade? Of course, we did hear you about speaking about the small airway disease, but we would like you to give an elaborate description on this as well.
I think it's been an amazing, fascinating time over the last decade. You've seen it yourself in India with the rich data that you've been producing, with your guidelines that you've just shown us. So globally, I think airways disease has really evolved in terms of new agents, new treatments, new modalities of assessing them, not just small airways, the importance of the nasal compartment. There's a lot of work going on nasal airways and nasal drug delivery as well. So it's a very rich time.
Right. Dr. Rogliani, now, we know very well that there are these phenotypes, endotypes. So how do you think they're clinically important? Or is it like, the first time when the patient is coming, should we just be looking at them, or maybe we could come to that later, but what are the phenotypes and the endotypes that you should be seeing clinically?
Based on the presentation and that COPD is not just a smoking-related condition, we need to focus also on this never smoker population. And I think that comes in hands very much the novel approach, with the multidimensional approach that has been proposed by Surya Bhatt and has been confirmed recently by other two different populations, in Japanese population and in Chinese population, this multidimensional approach that highlight the fact that the never smoker is a population with a specific characterization, with a less impacted airflow limitation, but with a more impacted lung abnormalities that we can detect actually with the imaging, and they are inclined as the smoker one to the exacerbation. So we need to focus also on that specific population, and especially in the early detection. The early detection is something that we need to aim to.
Right. So, Anshu, sorry? You have a question? Tell me.
Is it on? Hello, it's excellent presentation by everyone. I have two questions. My first question is for Dr. Paula. You have mentioned about never smoker COPD. My question is, what about the treatment and management? Are they same or they different? I know there is not much literature about it, but from India, we have a multi-center paper where we have shown that never smoker COPDs have more exacerbations. So what is your take on it? And
this is a very good question. It is an entire chapter that we need to write because we do not have evidence how we should treat them, if they need a different approach or the similar approach. So right now we consider the COPD as an all world altogether, and so the noxious particle altogether, the smoking and non-smoking related one. So I think we need to stick with that indication so far, but we need to create new evidence. But the longitudinal study, the large population study, although they are small evidence right now, indicated that the rate of exacerbation they are similar, so they are inclined to have exacerbation and to be frequent exacerbator, but they do not have emphysema as much as the smoker one. They do not have reduced DLCO, but they tend to have air trapping. So based on that, definitely the bronchodilators are the key strategic therapeutical approach that we need to pursue in those those individuals.
Thank you, ma'am. My next question is for Dr. Osmani. You have mentioned about the improvement in RFA 5 to 19. And when we do statistics, we can show significant improvement. So what about the cutoff values? In a patient, when I see, how do I determine that they have improved?
Yeah, so we've just published on cutoff values, and I commented yesterday. So for our 5 minus R20 AX and X5, I mean, it didn't reach the Delphi consensus, but we should now use Z scores of 1.64, yeah? For bronchodilator response, we've shown that for X5, it's 80%. X5A, 40%, anyway, we've just published this 3 months ago, yeah? So there are different percentages so we've listed that for, do not use absolute values now. So I think 1 or 2 of the studies have used absolute values as a cutoff. So now use Z scores or percentage for the bronchodilator response.
Thank you.
Right. So we come back to our discussion. So we'll take the questions later. I guess let's just finish our panel discussion first, and then we'll take your questions. So if you could just give us 15 more minutes.
Well, I think we need to do both. We should take them both.
So our question may just get left behind then. The question that we have with us. Okay. Sir, go ahead, sir. Please, you can ask your question.
My question is to Dr. Usmani. Sir, when we do bronchodilation test, particularly in lung oscillometry, we get exactly the reverse response as if I have done bronchoprovocation test. How you report this?
Yeah, so actually there's data from India on this, and it was a great paper. I can't remember, the name totally escapes me now. So there is actually a paradoxical change even when in FEV1 when you give albuterol or salbutamol in about 9% of our patients. Just like as if you'd done a bronchial challenge. And in oscillometry, about 15 to 18% of patients show this paradoxical response. So paradoxical, what does that mean physiologically? And I think this is our concept that you have one tube, one pipe. If you perturb one area, the other area will be affected. And this is part of the explanation of why that happens, and also aspects related to flow. The oscillometer needs a minimal amount of flow and volume in order to achieve a response, and that may not be achieved in some severe patients. But there's a paper, it was just published a year ago by, I can't remember, it's a paper in India, I think it was in Respiratory Research.
And the second one is in lung oscillometry. If we look at small airway, R5 minus R19, if it is normal, say 1, and you get bronchodilation, see 0.6. So should we report this as a good reversible?
Yeah, in the same way we would with FEV1.
No,
Sometimes you see patients who have got to 95% predicted and then they go up to 115% predicted. So there is a bronchodilatory response. It's information to the physician to decide on whether they act upon it or not, linked to symptoms. So physiology mustn't be taken out of sync with the patient's symptoms.
Thank you.
Any more questions from the audience before we go on? No? Okay. So Anshum, coming back to our panel discussion, it was asking, you have patients who walk into your OPD, you diagnose them to be having asthma, you start them on therapy, and then they remain in a mild kind of a phase and do not develop severe symptoms. And there are others who come to you with severe symptoms and, or who are already at GINA 5. When would you like to phenotype them, early on or later once they've developed the severe symptoms?
Yeah, so sir, I think how I see it is, when you're dealing with a severe asthma patient or a GINA 5, phenotyping, endotyping becomes absolutely essential, because here is where we're going to make tangible changes in terms of, thinking of biologics and all. But even when we are seeing patients at the early onset, maybe at the first visit of asthma, a low level of or a tiered approach of phenotyping should start right away. So when we are seeing that this patient is atopic or this patient does have eosinophilia as a background, mentioning it on the patient's prescription that he's an eosinophilic type would make a difference later on. So absolutely doing advanced phenotyping, going for further testing could be done at a later stage, but yes, it should begin right away is what I take it as.
So what you wanted to say is that the thought process should begin on day one itself.
Absolutely.
And, you should streamlining the process so that subsequently once the patient does go into a stage 5, you know what you have to do with this patient.
Exactly.
So Amina, a very simple question again to you, that there is quite a bit of overlap between COPD, OSA, bronchiectasis, ILD. So when you have all these coexisting diseases and comorbidities, the overall morbidity mortality can vary, the overall course of the illness can vary. So would you want to identify all these things right in the beginning, or just treat the patient as simple asthma, oblique obstructive airway disease?
Right, sir. So in continuation with what Dr. Anshul just said, GOLD 2026 has in fact, changed HRCT thorax from a rule-out tool to a tool that should be used for early on phenotyping to identify the emphysema phenotype as well as the chronic bronchitis phenotype, because the management in both the situations is a little different in terms of identification of the patients who might require LVRS or patients who would require more mucolytic therapy. So one is that. Second is that, of course, as far as the comorbidities are concerned, I think sooner than later should be the approach. If you have a patient who has signs and symptoms pointing towards an underlying cardiac disorder like an orthopnea or a disproportionate dyspnea or features of pulmonary hypertension on clinical examination or history, then an echo would be worthwhile. Somebody who has features of obstructive sleep apnea, when they present to your clinic, then a sleep study would be worthwhile. So in a sense, basically, I don't think there is a point waiting for the patient to come back to you with worsened symptoms. If you feel that at the onset only there are certain signs and symptoms and clinical presentation that may point towards other comorbidities, I guess hit hard, hit fast is what we should look at.
In fact, the earlier the better, because you're able to identify the other illnesses also and treat them concomitantly rather than waiting for them to flare up one day and then land up in a difficult situation. So Dr. Neil, is spirometry still the core in diagnosis, or does it have some limitations also?
So thank you so much, sir. So again, when we talk about spirometry, I'll take one comment with the previous audience question with this. So she mentioned a paper with never smoker COPD where there were increased exacerbations. So again, in today's time, we have data from India as well as international data which shows that now with the poor air quality index, the pollution itself is also indirectly, you're still having smoking. So that also confounds a lot of times that even though the patient is actually a never smoker, but that can cause effect in the changes which can mimic patients with smoking related COPD. So in this particular question, suppose I'm talking about chronic obstructive pulmonary disease, spirometry a lot of times may not be able to, if we go strictly by the COPD diagnostic criteria, even the GOLD now mentions that there are cases which are very early which can, like pre-COPD or the segment of PRISM where there is a preserved ratio but impaired. So again, that particular with the preserved ratio but still a low FEV1, you know that this patient is still, could be a candidate which can progress to COPD. Similarly, COPD patient with significant small airway dysfunction only. If you find a patient with symptoms, clinical history of COPD, but has significant small airway abnormality, that can also be important in the prognostication. Similarly, for other airway diseases, like for asthma, we say that, okay, asthma has specific spirometry criteria, but in the between asthma attacks, when the patient is absolutely asymptomatic, there is a possibility that the PFT can be normal. So in such cases, the other clinical criteria, the variable airflow limitation and the clinical history as well as allergy, atopy profile, all that also tells you. So we should take spirometry, but with the clinical correlation There are even radiological COPD cases where the spirometry early on can be normal. So spirometry is definitely one of the main parameters, but we should take it with the clinical as well as the overall other parameters.
So Dr. Mahesh, there's a lot of discussion about oscillometry now, and oscillometry is becoming more common, more popular than spirometry, usual conventional spirometry. What would you think about it? Where would you want to do it in your patients?
Sir, we are listening oscillometry since yesterday. Since we are the chest patient, we has grown with the looking at flow volume time graph. But still there are some limitations with the spirometry. Biggest limitation is trained operator and trained patient. Second part is most difficult. Trained patient. Those subset of patients who cannot be taught how to perform spirometry, like elderly kids, patients with the cognitive deficiency, or even though those who cannot understand how to perform the test, those subset of patients, we should perform the oscillometry. Second part is there is subset of the patient which cannot be picked by the spirometry. As Dr. Neil said, small airway function cannot be picked by the spirometry. So this can easily pick by the oscillometry. And second, there is a difference between the concept of spirometry and oscillometry. Oscillometry measures directly impedance of the airways, while spirometry measures flow volume changes. So oscillometry gives better idea about the lung mechanics.
Right, thank you. So Professor Usmani, you spoke just in your previous lecture also about the small airway disease. Would you just like to elaborate a little more about this? With the, the coexistence of small airway disease in asthma and COPD and the use of extra fine formulation in these group of patients?
So, a lot of the work has been driven by pathology and physiology, and the hallmark of respiratory disease has been pathology and physiology, which I think we've just forgotten and we forget, certainly in the UK, to teach our medical students in respiratory. So the evidence is overwhelmingly clear now of small airways in COPD, small airways in asthma. So the question is, what would you want if you were a patient who had small airways disease? And I think you would want something that can treat the whole airway tree. So the way of treating the whole airway tree is by these three methods, by the particle size, the flow, and the aerosol. So it isn't about a particular pharmaceutical company's product. It is about using the science to be able to logically target the scientific disease in order to achieve a change in the patient. And that data is now accumulating over the last 5 years. There's a wealth of data. And you take away the pharmaceutical company and you read the paper for the science, and you can actually collectively now confidently say that this is translating to a patient benefit. And we will see studies now that will be powered to look at exacerbation endpoints, probably better than the current studies that only show an 80 ml difference, even with our biologics, or show that the exacerbation rate went from 0.8 down to 0.799. So, and I'm not being cynical there. I mean, we have to really look at the data that we see at the moment. So yeah, I mean, and this has been around for 30 years. I mean, one of the first studies was in 1980 by Hoshino, who looked at ciclesonide on alveolar nitric oxide, linked it to sputum, late phase sputum eosinophils invented by Freddie Hargreaves, the late Freddie Hargreaves, and looks biologically, physiologically, and the ACT improved. And that was there in 1980. So yes, we should treat the whole airway tree.
So is there also difference in different drugs which can actually be delivered in the extra fine particle size?
So there are different formulations that allow you to whatever steroid you prefer, you can probably find at least 50% of them that can do that. Again, the other thing is we think it's really easy to make these formulations, and maybe we don't give a lot of respect to the science and engineering behind these devices, but it's very, very difficult. So we have to hand it, on this occasion, to the pharmaceutical company, to their scientists, to their formulation scientists, to their device mechanical engineers, to give us the technology to be able to treat our patients better.
Professor Osmani, just one question here, that with extra fine formulations, a lot of times even in India we have now Aerosphere inhalers. So, or inhalers which say that they have Aerosphere technology which they are using. So as per your experience and local data in your part of the world, what do you feel that is it very significantly helpful in small airway diseases specifically?
Yeah, so there is FRI, functional respiratory imaging data on Aerosphere, comparing the Ellipta device, comparing the Aerosphere device, and comparing the extra-fine MDI device. I would caution the latest study that looked at FRI between these three devices that showed that the Aerosphere was better able to target the small airways. And the devil is always in the detail. When you go to the tables, you realize the computational factors were revealed for the Aerosphere device, but were not revealed for the extra-fine MDI device. So yes, Aerosphere, through its MMAD of 2.9 to 3.1, can achieve delivery of the drug to the large and the small airway. The data shows it's more effective with an extra-fine particle. And remember, when we talk about small airways, it's not the Asana compartment. It's not generation 18 to 23 we're trying to reach. Certainly for COPD it isn't. And indeed for asthma, it's generation 7 to 16 to the terminal bronchioles. And that's the region that certain devices that we use in the clinic do not target. They target only the proximal airways. They're very good at the large airways, but they're not good at targeting the conducting small airways.
Thank you, sir.
We have a question.
This is for Dr. Usmani. Sir, if I do lung function test in asthma, 80% of the tests are normal. The same person's lung oscillometry shows significant improvement.
Yeah. Significant improvement.
Improvement.
Yeah.
And that's why, is GINA or GOLD incorporating or advising lung oscillometry? If yes, when?
Yeah, no, I get often asked this. I mean, GINA only recently sort of decided on FeNO, and that's because of access issues, yeah? So you are so lucky in India, so lucky that you have oscillometry almost established. Therefore, you are in a rich situation to teach the rest of the world on good hardcore physiology related to different lung diseases. China is doing it, and you can do it, and are doing it. So that paradoxical response was actually from an Indian paper. I think the surname was Das. I'm just trying to remember at the moment. I can't remember. So the point is you can look for the anomalies, and then mathematically and computational approaches can be looked to disentangle the physiology. Because an anomaly doesn't mean something is, you've got to understand the anomaly, and there may be some value in that anomaly that actually tells us more about the pathophysiology of the disease.
Thank you.
So, Professor Ogliani, there was this recent study which spoke about the CARE study, which spoke about the use of formoterol budesonide as a rescue inhaler in the pediatric population as well. So, do you think we should move away from using salbutamol SOS to formoterol budesonide as we do in adults only?
I'm not an expert in pediatric pulmonology, but I think GINA recommend also in population above 12 years old, if I recall, help me in that, Omar, the use of the combination of formoterol and ICS. And formoterol, it's a great molecule because it captures two key aspects pharmacologically speaking, because it has a rapid early onset of action as salbutamol,
but it lasts much longer, up to 12 hours. So it really gives the patient what he or she need, the rapid relief of the symptoms and longer efficacy of the molecule, along with the ICS, which respond ultimately to the need of the disease, which is the reduction of the inflammatory state in the airway. So it is key, the combination of ICS formoterol for asthmatic patient, and this is not only what it has been achieved in the GINA document for adult population as well as for the pediatric one, but data, especially in the adulthood, it is captured in the real-world evidence. And not recently, a couple of years ago, we published a meta-analysis from real-world evidence in using the MART-SMART strategy, using formoterol ICS in a MART-SMART strategy, and it is the most effective treatment, also in a real-world evidence, and not only in clinical recommendation.
Right. So moving on to COPD patients, Anshum, sorry, is there another question? Time's up, okay. So shall we close it here? Okay, good. Thank you.
Thank you
so much, ladies and
Thank you.
gentlemen.
So at this point, we conclude this session, and big thanks to all the speakers and moderator, Dr. Vipek Nangia, and all the expert panelists. Thank you very much.
With that session coming to an end, we move on with our next session, which is session 8, Turning the Coronary Interstitial Lung Diseases Diagnostic Assessment and Therapeutics. And for this session, I would like to call upon stage our subject experts, Professor James Chalmers, Chief Editor, European Respiratory Journal, Respiratory Physician at University of Dundee, UK, and Professor Dr. Pramod Dadich, who is a consultant pulmonologist and sleep specialist, Dadich Asthma Allergy Sleep and Chest Center at Ajmer.
Thank you very much. Really excited to now get stuck into the topic of interstitial lung disease. So we're going to kick off with the ILD Clinical Year in Review. And for this presentation, can I now invite to the stage Dr. Vikas Marwah. He's Professor and Head of Department, Pulmonary Medicine, Army Hospital in New Delhi, so close to home. Looking forward to hearing your talk on ILD Clinical Year in Review.
Very good morning to all of you. At the outset, I'd like to thank the organizing team of this ERS India to give me this opportunity to be speaking in front of you on a topic very close to my heart, which is on ILD. So I'll be discussing the clinical year in review and what has changed over the year. I think it's been a very fascinating year because we had a new classification which came up. Also a lot of data regarding ILAs, which is interstitial lung anomalies, abnormalities. We have gone beyond cold ice in using the transbronchial lung cryobiopsy in the diagnosis. And also AI has made big inroads and a bit about the new therapeutics. And after a decade, we have a new drug, nerandomilast, which was, again, the data was published last year. So what has changed in the ILD classification? As we all know, the 2002 classification, which was the ERS-ITS classification, looked at 7 entities, and there was a lot of emphasis on IPF. And we moved over to the 2013 classification, where the emphasis was on, the non-IPF IIPs as well. And we had a new entity called PPFE, and there was greater recognition of disease behavior and the mixed patterns as well. What has happened in the recent classification is that we have gone beyond IIPs, and there are new subcategories now which I'll be coming to, and also a subclassification as interstitial and alveolar filling pattern. So this was a very interesting paper which was published last year, and basically giving the guidelines, and this is how it has shown the change over the years. If you look at the 2025 guidelines, we have moved on to the secondary causes of ILD, in addition to the idiopathic varieties, and also there's better understanding of prevalence and disease behavior and differentiation of these into the interstitial and alveolar filling patterns. And so you basically start with the radiology now and get a better understanding of the diagnosis based upon that. So it includes the secondary causes. In addition, to the idiopathic IAPs. And also there's addition of this interesting term called the BIP, which was quite controversial as well in terms of the various authors coming to it, and especially the idiopathic BIP. So this is an airway-centered inflammation which is seen in patients more commonly in HP. And also the term, the AIP, the acute interstitial pneumonia, it has been changed to idiopathic DAD because all of this may not actually be acute. You may also have a chronic patient with interstitial lung disease who comes with acute exacerbation. And also the DIP is now called the alveolar macrophage pneumonia because there's no desquamation actually which you see on pathology. And what we actually have is a lot of alveolar macrophage in these patients. And apart from the idiopathic, you also have a connective tissue disease related AMPs which we see nowadays. So the BIP is actually an overarching term to define the histologic and the radiologic pattern of airway-centered interstitial pneumonia. And apart from hypersensitivity pneumonitis, we now know that we see this kind of pattern also in connective tissues related ILDs, aspiration, inhalation, and also drug-induced exposures. So if you look at it, so they have divided into interstitial and the alveolar filling patterns, which gives us a better understanding and better, diagnosis in these patients. And also what has been added in this classification is the diagnostic confidence in the patient evaluation when it comes to the MDD. So highly confident diagnosis and also a probabilistic approach has been added. So this is the morphological pattern. If you see on the left, we have the interstitial, on the right we have the alveolar pattern. Interstitial, we have the UIP, NSIP, BIP, the DAD, PPFE which was there previously, and the LIP. And there is a cranocordial distribution which is seen in certain diseases, and low predominance is seen in UIP, NSIP, and LIP. Similarly, axial distribution is seen more in the periphery in UIP and NSIP, and some amount of subpleural sparing seen in NSIP as well. So this gives you a better understanding on the CT as to what kind of sub-classification you are dealing with. And also in the alveolar filling patterns, you have, based upon distribution, diffuse, multifocal, and local, and also you can have combined patterns in this disease. So based upon this, we also have an interstitial disease which has got a predominant pattern, and the slide is not changing there, so probably. It's not moving forward. It's moving here, but not there. Can I have the next slide, please? It's not moving on the screen. So we also have the dominant and the coexisting pattern. So you may have a dominant UIP with associated NSIP, BIP, and you may have a combination, and you may look at the secondary causes in these patients. Similarly, you may have an NSIP with a UIP pattern to top it up. So what has also changed in the last year is that we had 2 interesting papers on ILAs, and we got some guidance regarding the advances in the diagnosis and the monitoring of the disease. So these are the interstitial lung abnormalities which have not yet become interstitial lung disease. So HRCT remains the cornerstone for diagnosis of ILD, and the aim is to diagnose these entities much earlier before they've evolved to ILD, because if you diagnose it at the stage of abnormality, probably you can institute the therapy early and we may have a better diagnosis. Can this move, please? I think there's some issues with the screen not moving. Some technical snag. This is moving, that's not moving.
नेक्स्ट में आऊँगा हाँ हाँ
So apologies for the technical snag. So this is basically looking at the interstitial lung anomalies much earlier in the CT scan, because if you institute therapy early, probably the outcome is going to be better. So what this new paper published in the Blue Journal told us is that the understanding of ILA has to change, and this is much different than the previous Fleshner Society position paper in 2020 looked at. It only mentioned the incidentally detected non-dependent bilateral parenchymal opacities as ILAs, and they excluded the high-risk population. But what has changed in this, the newer classification is that you can include the incidentally detected interstitial abnormalities and also the high-risk populations, because we know that more than 50% of ILAs experience radiologic progression over 5 years, and approximately 10% of ILAs will become ILD annually. So it is recommended that we look for interstitial lung abnormalities in patients who have undergone CT scan for lung cancer screening, and also we must screen all patients with connective tissue disease, especially those with, say, systemic sclerosis or MCTDs and RAILD who are known to develop ILAs and which are likely to progress over a period of time, and also somebody who is more than 50 years of age and has a relative with familial pulmonary fibrosis. And also we have some recommendation regarding what to do, which is you have to screen with spirometry, look for symptoms, and what not to do, which is you should not do a biopsy in an ILA, and also should not be checking for mucin 5B and also the telomere length in these patients. So this is the recommended guideline which says that we need to include the patients who are incidental and also who are at a high risk. And which are the opacities which can classify for ILA? These are the ground glass opacities, reticulations, traction bronchiectasis and bronchioliectasis, honeycombing, and also some amount of non-emphyematosis if they are not the predominant abnormality. What you should not include is aspiration pneumonia, heart failure, infection-related anomalies, and the total volume, it should be on eye scan. If you see it's less than 5%, it's not an ILA. If it is more than 5% or in a lung zone, it is likely to be a ILA. We have another paper which was published in CHEST, which gave a narrative review of the approach to diagnosis and also management in these patients. So if you have a patient who's got abnormal and who's asymptomatic and got a normal pulmonary physiology, he is less likely to progress compared to somebody who's symptomatic and has got a DLCO impairment. And you must also see the symptoms attributable if the symptoms are because of COPD or aesthetic cardiac issues. So if you have symptoms, you have abnormal spirometry, and you have high risk factors in terms of familial pulmonary fibrosis, smoking exposure, you're more likely to develop a ILD in the near future. So that is why in these patients, based upon the risk, the screening has been added, and also how frequently you need to do the spirometry and CT scan in these patients. So if there's high likelihood of progression, you have to do a proactive monitoring in these patients and repeat spirometry in 12 months time, and probably repeat a CT scan in 2 years time. And if the risk is not high, it may be a reactive where you might like to do a CT scan much later. But what is also important is that avoidance of exposure. So if he's a smoker, there's environmental exposure, you recommend reduction in the exposure to prevent these ILAs becoming ILDs. So the aim is to catch it early so that you can intervene early with the therapies, because the outcome is going to be much better. Last year we also had publications in which we looked beyond TBLC. We know that the cold ice study has already established that the cryo TBLB is probably as good as a surgical lung biopsy, especially if the MDD is added to it, and it has emerged as a major tool in ILD diagnosis in our armamentarium. And the other guidelines have also recommended the cryo TBLB in the diagnosis of ILDs. So this is an interesting paper which came from Spain, which looked at a center who's not experienced in doing cryo TBLB. So they published their center's first 117 cases of TBLC, and the diagnostics was reached in 2/3 of the patients. So what is important is that even if you're not experienced and you're starting doing TBLC, 2/3 of the patients you might not need a surgical lung biopsy, and you'll be able to classify them better based upon your biopsy and the MDD. What is important in this study is that they looked at the severe complications as well, and the complication rate was not higher than what has been reported in literature. So we can start doing more transbronchial trial lung biopsy and reduce the surgical lung biopsies. Also, which has been seen from this paper from China last year, is that the smaller cryo probes do not essentially have a lower yield. So we've been using the 1.7 mm cryo probe. So they did this study with a 1.1 mm cryo probe, and what they found that it was much easier to position it in the upper lobes, which are basically difficult because these probes are much more flexible, and the diagnostic yield as well as the complication was not much different. So probably we can try doing biopsies with the smaller probes, but taking all the precautions for bleeding as well as pneumothorax, and we get a good yield with similar complications like the previous TBLB. The AI has made big inroads last year, not only ChatGPT and AI in our day-to-day life, but also in the early diagnosis of interstitial lung disease. So this was this lung fibrosis, a FibroResolve AI, which has been published, which looks at a special VIT, or the vision transformer algorithm, and this has been reported in this paper from US, where it breaks the original image into a split image, which it makes, embeds, and then with the help of a vector, it is positioned, and there's a good spatial reintroduction, and they have used this technology to read a lot of CT scans from their database, and it has become smarter over a period of time to essentially look at factors earlier in the course of the illness to look for progression. So they trained it on multiple IPF data sets to learn from a broad spectrum of patients from US, and with each iteration, the system became smarter in recognizing the mortality risk. So the Fibrozolve was a predictor of mortality at not only initial visit with a HR of 2.79 in moderate and 5.82 in high-risk patients, but also similar predictive performance was seen on follow-up visits. So what we essentially know is that instead of following these patients up with repeated CTs, if you put up in an AI algorithm, you know who are the patients who are likely to progress, and probably you're going to use the therapies much faster. This is similar kind of AI which has come from the UK, which is the Brainomix 360 E-Lung. So this again uses an AI-powered software with automated quantification of fibrotic changes, and it also embeds the age, the sex, and the risk of progression in these patients. So what is essentially used is a reticulovascular score, and they have decided a threshold of the weighted reticulovascular score, WRVS, as 3%. So if it changes more than 3%, it is equivalent to a reduction of FVC over 1 year of 10%, which we normally use. So you need not wait for 1 year to look for a reduction. So with this software, probably you can identify these patients early, which they did, and they put the data of all these patients of inbuild into this, Brainomix, and they found that early diagnosis of progressive pulmonary fibrosis was seen in 62% of the patients and up to 21 months earlier. So this is what we want. We want to know which patients are likely to progress so that we can treat them more aggressively. Similarly, CT progression in 77% of these patients was seen. So last year, we also had a lot of improvement in therapeutics, and after a lot of negative trials, we finally had a drug which was approved after the FibroNear study, and this was published in the New England Journal of Medicine, which is Nerandomilast, which is a PDE4B inhibitor with both anti-fibrotic and immunomodulatory effects. And there were 2 FibroNear trials, which is the FibroNear IPF and the FibroNear ILD trial, which was approved. So basically, they looked at patients who already had ILD and who were already on antifibrotics, which is nintedanib and pirfenidone, and adding the 2 doses of nerandomilast, which is 9 mg twice a day versus 18 mg twice a day and versus placebo. So these were the patients who were well matched for age, men, usually the white, and mean FVC was 78%. And what they found that these patients who were already on background antifibrotics, if you add nerandomilast to these patients, there is a 28% relative reduction in FVC decline, which was a major risk factor, and 38% relative reduction in the FVC decline with the higher dose, which is 80 mg twice a day. So these patients were able to meet the primary, basically target outcome, which is the prevention of FVC reduction. So, but what they didn't look at was probably the other secondary endpoints, which was the all-cause mortality and the composite endpoint of reduction in IPF exacerbation, hospitalization, or respiratory cause. So what is important is that these patients did not meet the secondary outcomes, which are also as important. So this was the second trial, which is the FibroNear ILD trial, which looked at the non-IPF patients, which is other fibrosing ILDs, and 28% of them had autoimmune connective tissues related ILDs and 18% had HP. So what we are aware from the studies on nintedanib, initially the approval was only for IPF, and later after inbuild, this was approved for all fibrosing ILDs. So similarly, nerandomilast after this study has been approved for, I'll take 1 minute extra for the snack, if you permit. So what it has shown is that the lumpers model is important. So irrespective of the underlying etiology, be it hypersensitivity pneumonitis, IPF, or CTD ILD, if they are to progress, then treating them with nerandomilast will have similar effects. As you can see in this study, in patients with progressive pulmonary fibrosis, which had a lot of HP, here also there was significant improvement in the prevention of decline in these patients. But what I want to bring to your notice is that this kind of improvement or prevention of reduction of FVC may not translate into better outcomes, which are important to the patient, which is quality of life, prevention of hospitalization and exacerbation. And this letter from Dr. Sheetu Singh also mentioned the same, that we need to look what is more patient-centric rather than just spirometry. The last paper I'm looking at is the role of corticosteroid therapy for treating acute exacerbation of interstitial lung disease, and this was a systematic review. We all have been treating ILDs with steroids with variable results. So this paper looks at which kind of ILD is likely to respond to what dose of steroids and for what duration. So they included all patients with acute exacerbation ILD, and there were around 12,454 articles, out of which they chose 447 articles for full text review, and 9 studies were finally included. And it looked at high dose versus low dose corticosteroids. High dose is more than 1 milligram per kg per day, and anything less than 1 milligram per kg per day is low dose. And the key outcomes were in hospital and long-term mortality in these patients, as well as the acute exacerbation recurrence. So the result of these studies is that basically it divided into 2 types, whether you're dealing with IPF or you're dealing with non-IPF ILDs. So the non-IPF ILDs are likely to have a much better response to steroids if you're using high dose, which is more than 1 milligram per kg per day, compared to the IPF ILD, where the data is less and probably there is some data of harm as well. So what you need to do is, when a patient comes to you with acute exacerbation, you need to look at the kind of ILD, which is, if it is IPF, don't give high dose steroids. If it is non-IPF ILD, probably you can give high dose steroids and have an early response on these patients. This is my last slide. So what is most important from all of these studies is that what remains numero uno is still MDD. Whether you do a cryobiopsy, whether you want to take a biopsy from a particular segment, or you want to put these in a diagnostic algorithm, MDD is a must, and this is what the 2025 classification and all the cryo-TBLB papers also show. So 4 minds are better than 1 mind. Thank you, ladies and gentlemen.
Thank you, Dr. Vikas, for a wonderful presentation. And you have rightly summed up all the updates in the ILD in 2026. Because it is a growing branch, still no one is expert in this. It's a depressive and distressing for patient and challenging for clinicians. So thank you so much for your wonderful presentation.
Thank you.
And now I'll invite Dr. Pilar Rivera Ortega. She will deliver her lecture on early ILD, concept to evidence to practice. Since last one day, we are discussing about the early detection of all the disease, right from lung cancer, COPD, and ILD. Though early detection is must to prevent the disease in future course, but it's a challenging in our country. So there are issues in many terms, because there are no insurance policies, there are no government policies where you can detect and screen the lung patients. Because nowadays in UG also, the respiratory medicine is now overlooked in our undergraduate teaching also. So what is your take about early ILD?
Thank you very much for the kind introductions, and thank you all of you to be today, Sunday in the morning. And we will discuss in the next 15 minutes about the early interstitial lung disease, from the concept to the evidence and practice. And I don't have any conflict of interest for this presentation. And part of the objectives will be to have a very quick look about genetics, to understand how we can use genetics, and of course the concept of interstitial lung disease that very elegant has been described from the previous speaker, Dr. Bighas. And also, I think, how we can identify these progressive cases of early ILA or early ILD in order to provide maybe some type of a screening program or monitoring of these cases. And also, once we establish the diagnosis of pulmonary fibrosis, whatever is the type of ILD that they will have, to be able to see if these cases really are early, or when we will call early these cases, and above and beyond just the FVC or the lung function. And finally, to have some strategies about how we can collaborate, hopefully, with primary care to establish an early circuit for the early diagnosis of these cases. So first, about genetics, I think all of you hopefully are familiarized with these papers, and I will start with the one that is at the right, that is about genetics of ILD, the state-of-the-art review that was published at the ERJ last year. And it's just to put the long story short, we have the patient in front with an interstitial lung disease, but of course, if the patient inherited something that could be from the father's side or from the mother's side, that definitely can produce that the patient has a genetic predisposition. And that genetic predisposition alongside some environmental factors, including as well occupational exposures or any other exposure to maybe feathers or maybe mold or so on, biomass, and alongside all of these, or across to their life, all the exposures that they will have, this interaction between the environmental factors and genetic predisposition is that what we call epigenetic phenomenon. And this sometimes could be the trigger for an individual to develop a disease. But if we were born already with a genetic predisposition, that could be maybe that we inherited a variant that in the past we used to call mutation, but nowadays we call pathogenic variant. If we inherited already a variant, particularly at the caps of the chromosomes, that is what we call these areas telomere. If we inherited any type of mutation there, that can produce that maybe we are more vulnerable. Vulnerable for what? So maybe to have some damage in our genome information. And if we have damage there, we can have impact in several organs. One of the organs could be the lung, and of course we can have pulmonary fibrosis. Other organs could be the bone marrow, other organ could be the liver, and so on. So that is what is really important to know what is, I think, is now explained in the graph on the left, all of these interactions, and that is above and beyond just idiopathic pulmonary fibrosis. Could be the same type of pathogenic variant or mutation that can be present in different type of interstitial lung diseases. And of course, one concept is about the variant that we inherited. A different one is about the length of the cap of the chromosomes, that is the telomere. If we maybe inherited already a short telomere, or maybe we acquire a telomere that can become shorter and shorter, that is called a telomere attrition, that could be as a consequence of the exposures that we have, that as well can be the trigger to develop many diseases. So, and this, I think, is, of course, you will be very well familiarized with what is on the right, that is the ERS statement for familial pulmonary fibrosis. And of course, after the previous explanations that I said a few seconds ago, will not be, I think, a surprise for you that part of the features are not only related to a patient with family history with pulmonary fibrosis, as well that include other type of conditions related with any problems with the blood or with the liver or early gray hair, that can be considered a sign of premature aging. And in the UK, we have a gene panel that is 25 gene panel, and the genes are the ones that are showing there that include the telomere-related genes, surfactant-related genes, and one polymorphism that means is a common variant, that is the MUC5E that has been mentioned for several speakers across these 2 days. And we can talk more during the Q&A session. Then, coming back to the guidelines that has been published, I think, in September last year. In the guidelines, we have the table 5, that is one of my favorite ones, because you can see on the table 5, and I put in this red square, that one of the only biomarkers that are very helpful for diagnosis, prognosis, and possible use in therapeutics are the telomere-related genes and the leukocyte telomere length. All the others are just with a possible impact or no impact. So that is not anymore desirable, is not anymore experimental, is in our guidelines. So that is just to let you know why this is important to think about precision medicine in ILD. And once we have the result, it's not only to request the test and to have the result. We need to discuss in our MDT, but it's not in our standard MDT. We need a multidisciplinary MDT now with hepatologists, hematologists, immunologists, psychologists, transplant consultants, of course, ILD consultants, and the real experts that are the geneticians. once we have this discussion, of course, we will be able to provide an advice for the patients that is called proband, and also for the first-degree relative. And if you want more information about that, I strongly recommend that you will access the book that is an ATS book that was published last year that is called Precision Medicine in ILD. Moving on now to the ILAS, because Dr. Vick has presented very, very well this chapter. I will not repeat that. Just I think is to emphasize for these guidelines about the ILAS that the table 4 show the features associated with increased risk of ILA progression. And you can see that the first line of these high-risk ILA features is family history of pulmonary fibrosis. And then you can see that just in the middle, we have one of the polymorphism, there is the MUC5B, and also we have the leukocyte telomere length. That is important to take into account. Now, hopefully, you are now combining the information from the genetic predisposition with the concept about the ILA. And you already saw this review that was published in the CHEST, so I will not repeat that because it has been described very, very well. Then we have related to the ILAS as well to emphasize what will be the high-risk cohort. And we already described several times that patients, in that case, not patients, that will be individuals, that they have family history of ILD, any type of ILD, is not necessarily IPF, any type of ILD, they are individuals that are considered a high-risk cohort, but they are not the only ones. How about individuals that they have a connective tissue disease or a SART? If they have a systemic and autoimmune rheumatic disease, they are considered a high-risk cohort, and that was, I think, described in one paper published in CHEST in 2022 by my colleague Matt Hanningham. Then, ILAs are associated with a decrease in the telomere length, and of course we need to put in the context that doesn't mean, as my colleague said, that we need to perform the telomere length for all the ILAs. That means that if we have a patient, in that case an individual with ILA, but this individual has family history, this is an individual with high risk, it's not just an individual with ILA. And we have a paper now related with this progressive early ILD in relative of patients with pulmonary fibrosis. Interestingly, we need to go above and beyond just the standard FVC because there are other parameters on the lung function that we need to look at, and also the changes in the CT scan are very subtle, and we can use some algorithms, AI, quantitative CT to try to help us. But this paper describes just in 2 years what could be the changes on that. So this is really interesting. And remember, one more time, these cases are considered under the umbrella of high-risk cohort. But what about this other paper that, one more time, these cases are relative of patients with pulmonary fibrosis. In this cohort, the good point is in this table they describe what we should looking at on a CT scan. Within the umbrella of early ILD, or a bit more when will be a fibrotic ILA and when will be an early fibrotic ILD, that is difficult to differentiate sometimes. This could be interesting to looking at, and also how long we need to follow up. As you can see, sometimes we need to wait 8 years or 13 years. If our health system, I think, is ready, or actually if it's affordable for our patients, that is something that for sure that could be, I think, really interesting to debate during the Q&A session. And why we need to understand that? Because if we have this family tree that I'm pretty sure that all of you are very well familiarized, if we will see the family tree that is on the left, that is a big family where we can identify who is our patient, is the only one that has the arrow. And that could be a female patient with pulmonary fibrosis, big family, with a lot of relatives, siblings that already sadly passed away. How I can see that? Because they have a diagonal there, and all other relatives that they don't have the disease and they are alive. They are the one that we should target. And we already published a possible or proposal that what should be maybe the program or the type of a screening that we can offer to the first-degree relative. However, we don't have a global consensus yet about what to do it, but it's working in progress. And in terms of moving on now with once we have a very well-established interstitial lung disease or pulmonary fibrosis, but they have a forced vital capacity above 80%. Should we label these cases as early? And that is a really interesting publication from our Spanish cohort. It's a national cohort. All of these patients, it's a large cohort, all of them had FVC of 80% or above. Interestingly, these patients, the ones that actually have better survivors are the ones that, of course, they had as well better DLCO, they have, I think it's a lower rate of smoking consumption, and so, and of course, the one that they have less rate of UIP. So just as a reflection that everything is not only around FVC, that is not only in terms of when we're thinking about clinical trials and primary endpoint, that as well for real world evidence. Please don't label as an early ILD only based on the FVC. We should reflect on other parameters. And the last point about some strategies, how we can maybe work with primary care. That is a very nice paper that was for my colleague Paolo Spagnolo, published in 2021. And I think it's some type of, it's interaction with the specialized ILD centers and general practitioners. And that, I think, is the recent paper that was published, I think, is a month and a half ago from that has been a summarize of over 10 years' work from my previous center in Barcelona with my mentor, Professor Maria Molina. And that is part of my work when I used to be a fellow, as you can imagine, a while ago. What we did is we trained 2 primary care physicians and 2 primary care radiologists. We trained everything about ILD, we provide some information, and that was more or less 15 years ago, and we facilitate for them a rapid circuit. They said every time that you will identify any patient with suspicion of ILD, rather than to refer to a secondary care or to request just some investigations, just refer directly to us as an ILD specialist center. And we're monitoring these patients for over 7 years. What happened, as you can see on the curves, these patients, compared to the standard of care, the patients that we receive routinely, they have better survival, more access to antifibrotics early in timely manner, better access to transplant, and also I think it's overall the quality of life was better. So this is feasible, and I think it's if you are interested to collaborate, and I think it is very easy to replicate maybe as well in India. So happy to discuss maybe in the coffee break. So the last slide, take-home message. Clearly, we are living in the precision medicine era, and we need this holistic approach and teamwork. Please, one more time, think about genetics embedded in clinical practice. It's not the future, it's the present, and it's in our guidelines. And of course, I think it's be careful what we will label our patients as an early disease based on the FVC. I'm pretty sure that we can work with primary care physicians and radiologists to be able to diagnose early these cases. And this is where my site is. It's just in the peninsula of England. Thank you so much.
Great, thank you very much. 2 fantastic talks on ILD, and we're going to move very quickly now into a panel discussion. Can I please invite now Dr. Dhuria from PGR Chandigarh, who is going to, I think, chair this panel discussion on ILD. The topic is ILD in India, how similar, how different? So I think a really interesting topic to dive into after those 2 presentations.
Dr. Dhuria is a great academician and a great spokesperson. Very efficiently, he will moderate the session. And in India, ILD is a big challenge. It is distressing and depressive disease for patients. So how judicious one should be to detect the ILD early and to change the course of illness of ILD patients. Because incorporation of MDT is also must and it is mandatory in ILD diagnosis and management. And along with that, we have a rich panel of rich faculties, Dr. Pilar Rivera Ortega, Dr. Amita Nene, Dr. Anil Kumar Singh, Dr. BP Singh, Dr. Kumar Utsav, and Dr. Manoj Goyal. I'll invite all the eminent panelists to join and share your experience. In a country like India, we have many constraints, not in terms of diagnostic facilities, but also in terms of economics and availability of newer modalities of treatment. How to help our patients and help our clinical judgment also to better diagnose the disease and to manage the disease efficiently. Over to Dr. Sajal Dhuria.
So I'll start immediately. I think we have all the panelists. They don't require any introduction. So we are going to discuss ILD in India, how it is different and how it is similar to ILDs all over the world, because we have this ICS-ERS collaboration. So we have people coming from Europe and other places, so that we can really discuss it out, how peculiar is the ILD scene in India, how it is different. So I have a few slides just to support this panel discussion, and we'll just go with the flow. We'll not restrict ourselves, but we'll address a few points in diagnosis, a few points in monitoring, and a few points in treatment. First of all, we'll consider the profile of ILD types, which has been the core discussion for so many years in India, that which are the common ILD types. And I'll start every time with Dr. Pilar Ortega, so that we have a view of her center, and then we discuss what is peculiar in India. So Dr. Ortega, what are the common ILD types? What is the top frequent ILD type that you see at your center or overall in the UK? And then we'll consider that what happens in India.
Thank you very much. The most common type of ILD in the UK is idiopathic pulmonary fibrosis. That is the number one, following closely every year, more closely for fibrotic hypersensitivity pneumonitis. And the number three is any type of CTD or SART ILD.
So this is actually news to me, because most of the registries from the West say that IPF is number one, number two is sarcoid, number three is CTD, and HP comes maybe at number 4, number 5. But you have the experience that it is now number 2. It's changing.
It's changing.
So what do you think are the reasons for this change?
That's a very important question. I think it is just our ability and capability to diagnose a bit more, at least deeply, because in the past, I think we try to establish a pragmatic approach sometimes just to be able to offer the treatment for the patients, because we have an equal access system that is the NICE, so the government is able to pay for the treatment for the patient. So we need to be very careful how we label the disease to be able that the patient will receive the treatment. So if we label as
it
an
is more
IPF,
of a practical concern. So the diagnosis is based on the practical concern.
Exactly. So I think it's a diagnosis, and then we have the working diagnosis. And I think it's in the past, and that is just a personal reflection, maybe we used to, as a collective ILD community, we used to abuse a bit of this working diagnosis of IPF, and now that we have other type of options of antifibrotic for PPF, now we are more careful to try to categorize a phenotype, the type of ILDs.
Dr. Goel, your experience of common ILDs that you see in Delhi, in your practice, what will be the top 2 or 3 common ILDs?
Yeah, so Sajal, we have got the Indian registries, and it shows that HP is the commonest, and we do find that HP is a very common ILD in our pattern. But the thing which is emerging is the drug-induced ILD, which is coming up very fast. I think I'm working in a tertiary care hospital. I do see these cases quite frequently as they are on anti-neoplastic regimen. So that is one thing I think will percolate over a period of time, maybe the future, we may see more of these patients. But apart from that, we do see the CTD ILD coming up, and then the IPF also remains a very core finding, and of course, sarcoidosis.
Yeah. So in a systematic data collection that we saw in the Indian registry and the PGI registry, we saw sarcoid and HP coming up as the most common ILDs. And now this ICMR registry is going on where AIIMS Delhi is leading. And we have about 20 centers all over India wherein CTD ILD is the most common. It is about 30% of all ILDs. And possibly it's a lot to do with the referral biases and with the kind of diagnostic workup that we're doing for the patients. So we are picking up more and more HPs and CTD ILDs, which we previously used to label as IPF and idiopathic NSIP. Do you think, Dr. P.P. Singh, do you think that our patients are coming in an advanced stage? What we read in literature, and I'll tell you about some of our data, that is there any difference in the
Yes,
diagnosis?
we do get patient in very advanced stage, and as the data has also shown in the registry that around 4 years lag is there from the symptom presentation to the diagnosis. So most of these patients are very, very advanced stage, and at times you feel that you are not able to do much to your patients in spite of the treatment.
Yeah, so in our data also, we saw that in amongst the HP patients, only 10% are coming at a stage of non-fibrotic HP. Most of the others, that is 90%, are fibrotic HPs. So that is one peculiarity in India, which has treatment implications also. When we'll come to treatment, we'll discuss this out. And even patients coming with poor lung function. So it is something to do with the advanced stage of the disease, and also maybe it is congenital effects which make people to have poorer lung functions in their childhoods, and which continues. And so ILDs, when they occur, they already come up with a poor lung function. Dr. Nene, you want to speak?
So it's kind of really unfortunate that even in big cities like Bombay, where you have access to every care, by the time an HP patient comes to us, they've taken at least one round of AKT. It's actually very, very sad because the thing is that HP also involves upper lobes. So basically, people kind of, get AKT and time is wasted. And if the patient is from a third tier city, then very often they are referred to us. HP patients, not even one CT scan, or they could be having a CT scan, but the patient is referred to us as MDR TB or XDR TB when not even one AFB smear is positive. Okay. So not only 1 or 2 rounds of normal AKT, they are already on second line AKT when they come to us. And because there's no access to bedaquiline, the patients come to us, and there was never TB. So this is where the disease is advancing and the lung function is getting poor. But people who are addressed and people who come to us early, they do fantastically well.
So Dr. Nene makes a very important point, Dr. Ortega. I'll address you because it's India and versus the entire world, how ILDs are different. So she has made a very right point that in our setup, we see a lot of sarcoid and HP patients who present with upper lobe fibrosis. They have been treated for TB, sometimes more than one times, So they come really late because they get misdiagnosed as having tuberculosis. I'll move to diagnostic testing. So, Dr. Utsav, how much do you test your ILD patients serologically? So what all autoantibody tests do you do in your practice? And then we'll ask Dr. Ortega.
So we do that all ANA panels, all HP panel. We do CTD ILD.
So do you do it for all your patients, or do you
for all
do
ILD
it selectively?
All ILD patients.
Okay.
We do it now. We have made it part of our treatment protocol that we go for ILD panel in all CT positive ILD patients, because we cannot know just by CT presentation which patient is going to be ANA positive, which patient is not going to be ANA positive.
So the guidelines, the IPF guidelines say that ANA by immunofluorescence, anti-CCP and rheumatoid factor. These are the mandatory tests. The rest should be done according to your clinical suspicion or radiologic suspicion. And from the panel in the ATS guidelines, only a minority of panelists said that you have to do the entire ILD antibody panel for all your patients. So I have come across a lot of false positive tests when you start doing it for all your patients without a suspicion based on clinical and radiological grounds.
So honestly speaking, it is well-known fact that in IPF, ANA could be falsely positive, RA could be falsely positive. I kind of feel that, just doing these tests unnecessarily often gets us biased, where people don't have anything and it's come positive because of inflammation. And unfortunately, many people, unnecessary tests are done, and it could be clearly HP or clearly IPF, and then they are labeled as CTD, ILD, and then they go to rheumatologists, and then just anything happens. I personally feel that there's no need to do a test which is not going to help you in the treatment.
It's true. So specifically, Specifically, I'll ask you whether you do, say, myositis antibody panel, in all your patients with ILD, or you select them according to the radiologic phenotype and the clinical information.
Thank you. We just selected. Yes, you selected. We don't consider that this cost effective to do for everyone. I fully agree with Dr. Nene. I think it's we selected because all the tests should be to support your diagnosis and to support your management plan. Just to do the test, and after that, waiting that the test will actually give you the answer to go through. I don't think that is good medicine that we are
so
practicing.
there are a lot of, not unlike. So there are a lot of false positivity and non-specific positivity, because when you do these tests and something comes up positive, sometimes pulmonologists will not interpret it and they'll send to the rheumatologist. And the rheumatologist will get back to you that why in the first place did you do this test? Because I cannot interpret it, then why are you sending it to me? Because rheumatologists are not in the habit of doing all the antibody panels. They are very selective. They go only by the clinical profile of the patients to test their patients for serology.
So there is two catch points here. Just a comment that ANA might be negative in, ANA by IFA might be negative in those idiopathic inflammatory myopathies. And then the second is that you need to do it in all those patients who are young, right? And if they are young and they don't have even the symptomatology which is very clear towards CTD, still you need to do it because the classical IPF is more than 60. So if you find somebody who has an ILD whose age is less than 50, whatever kind it will be good to do a CTD workup. And especially UIP patients, young patients, antisynthetase is something which is very important to rule out. So those are those patients, though age is something that where I will do a CTD panel, right? Even if they don't have a classical presentation.
So maybe a middle-aged female or a patient with an organizing pneumonia pattern on the CT, there it is generally suggested to do a myositis panel because other signs of myositis might be missing in an antisynthetase syndrome. So that is the profile, but not in all patients where you are suspecting H. pylori.
We have 5 patients we will be sending the series soon that they were all antisynthetase with classical UIP pattern and they were all young. 1 was male and 4 were female.
So young age is very important because sometimes
I completely agree. Like,
Yeah,
a patient who's a non-smoker, less than 60 years of age,
We'll take
has
an audience
UIP
question, yes.
pattern. Just I want to say one thing, sorry. So like we spoke about the ANA panel, I recommend that we should not even do HP panel blindly because we know so many factors come positive
We'll come
and
to
they
that.
are just
I'm
false
coming to that.
positives.
Yeah, I'm coming to the HP panel. Yes, we have a question.
Excellent presentations as always. Just a quick question. So we used to rely so much on the radiology previously, right? UIP, probable UIP. For, NSIP pattern means this disease, that disease. So what's the current role of radiology? Because the way it's moving forward, I think it's more like fibrotic versus inflammatory or non-fibrotic pattern, and that's how your medication changes. So what's the current role of classifying really into UIP, non-UIP, and NSIP, and then saying maybe UIP is equivalent to IPF? That's the first question. Second question is, what's the current status of KL6 and telomere shortening in
We are coming to
phenotyping
that.
patients?
We are coming to that. Just keep your questions to the point of discussion
Sure,
right now.
yeah.
We'll come to that.
Sure.
We'll take up your question towards the end, maybe.
Sure, thank you.
So the role of exposure questionnaires. So I'll ask the audience, how many of you are using structured questionnaires for assessment of exposures for hypersensitivity and pneumonitis? Just a show of hands. So very few. In my practice also, I'm not using a structured questionnaire as yet. It is mostly based on history taking. So any of the panelists who is using a structured questionnaire, you're using a structured questionnaire, a published one, you have yourself prepared it. So a
No, so
tailored...
we've gone through all the textbooks and every possible thing. There's actually a chart. And the thing is that before the patient comes to me, my assistant basically takes the history, tick marks everything, and it comes out to be easy because when you have small amount of time, you can't ask 80 kind of antigens.
So there are about
it's a very
5
well-managed list, which I think helps. I would have probably missed an HP and we picked up from vague reasons, you know.
So there are about 4 to 5 published questionnaires which are available, and we can tailor it according to our own needs. There is a questionnaire that Shitu's group, there's one study in which Shitu has derived this questionnaire by a Delphi and then validated it in a multi-center study. So this is specific for South Asian population. You are using a questionnaire, a published one, or a self? Okay, so
Thank you. It's not a published one. It was published in the UK, and that is a BMJ, about what are the most common antigens in the UK, because that is important, and that is the reason the publication from Shitu is amazing, because we cannot use questionnaires based on other regions. It needs to be what is suitable and what are the more common in our region. So we are using the questionnaire based on the most common in the UK. We are in progress to validate it in a multi-centric way, and it has been approved by governance about internal research and development, but it's in progress the national publication.
So it has to be tailored according to the exposures prevalent in the region. That is the learning point from this. What about doing HP panels? So that was the question.
Before we move on, just there's a question at the front.
Yeah.
So, in my opinion, the issue regarding myositis and an extended panel should be done, especially when initial testing ANA and RA factor comes out negative, and we have a strong suspicion of a CTD as well as a ILD, because many times, as correctly pointed out, RA factors and ANA may be negative. Age doesn't matter. We've seen so many times that patients have non-specific muscle-related symptoms, and we found that RA factor was negative, basic ANA was negative, but then if we did an extended panel testing, we found that strongly positive myositis markers were there. And especially in those patients, we should definitely do it, because then the treatment options definitely changed. And that gives a lot of relief and lot of relief to the patient. That's what I think.
So whether to test myositis in most of these patients who are negative for other CTD markers is a contentious issue. You are for testing most of these patients, some people are not because of false positivity and the extra cost burden. Yeah. So it is definitely a debatable topic. Yeah, so we'll move on to the HP panel thing. So how frequently are you using routinely HP antibody assessment in your ILD patients? Are you using it when you are suspecting HP as a way to find out the exposure? Or are you using it for diagnosing HP out of all ILDs, regardless of other features, whether they are there or not?
Our experience with HP panel is very poor, actually. We have used it, but most of the time does not correlate well. In spite of getting the classical HRCT pattern of the HP, you don't get correlation with the HP panel reports.
True.
So most of the time, it is not helpful.
Right. Dr. Ortega, are you testing for specific IgG antibodies? Can we have a mic? I may interject.
Thank you. We are, but fully agree with my colleague. Most of the time they are negative, and we go ahead based on the clinical suspicion. What we have is the avian precipitins, that is basically AGG, and also with ELISA, they for pigeon, for Budgie, and in terms of the fungal, is with Aspergillus, Penicillium, and some for farmer precipitins. What we don't have in the UK, what we used to have when I used to be in Barcelona, and of course in Valdebron with Dr. Ferran Morel, they have the bronchoprovocation of that is completely different, and that should be the gold standard, but it's not accessible for everybody.
Your experience?
I agree with everybody. And the thing is that, normally, very often if the money is a problem, we don't even get the panel done because the panels are expensive. One of my patients had a parrot at home and she had HP and she just was not ready to get rid of the parrot. And then she was not just ready to agree that her HP was because of parrot. She had no other exposures. For her in particular, we did the thing and it came positive and we just tried to prove to her and only then she got rid of her parrot.
So it becomes a way of to counsel patients also,
so
apart from the diagnosis.
And also there was this Gujarati family, I'm a Gujarati also, so we actually feed pigeons. And we had told you feed pigeons, you go to heaven. So then we had to do this to an old auntie who used to be feeding pigeons and she thought she was like collecting all good blessings from the world.
We can keep the answers short now because we are running out of time. So we don't have good cutoffs. There are manufacturer recommended cutoffs which we use in India, but they have not been derived scientifically. We did this study recently, which is under review, where we have tried to derive certain cutoffs for our Indian population. And we have found that the sensitivity and specificity are not up to the mark. Specificity is just 80%, and sensitivity again is just 40 to 50%. So,
and also follow-up is very poor. We must tell people that if you do the baseline one, then don't use it to follow up your patient.
Yes. The good thing that we have in India is the fluorescent enzyme immunoassay, which is more, it is more reliable. It gives more reproducible results and more comparable results as compared to ELISAs. The next issue is whether we are doing bronchoalveolar lavages to diagnose HP over other diseases and whether we are using it for prognostication. So do you do it in your practice for most of your patients? And how do you interpret it? Are you doing it only for diagnosis, for prognosis?
Thank you. We always do, as far as the patient is suitable to undergo a bronchoscopy and BAL, we always do. We try to do before the patient starts with any treatment because otherwise that would be difficult, it's not feasible, and actually it will be difficult to interpret. So we always do, and the proper differential cell count, what is proper as all of you know, I think is with no more than 5% of other cells. I think is we tailor the treatment based on that. If we don't have an increased lymphocytosis there or increased, I think it's eosinophils there, we use that, particularly for fibrotic HP, that is most of our cases. We don't have non-fibrotic HP, that could be no more than 15%. I agree with your statistics as well. In that case, if we have this patient and have to discuss further and with a patient with multiple comorbidities and maybe with a patient with family history or suspected telomere majority disorder, we don't treat with immunosuppressive therapy these patients.
Hello.
Yeah.
Do you also look for the CD4, CD8 count in the bronchial lavage?
Do you do it, Dr. Ortega? CD4, CD8 ratio?
It's not available in my current lab in Exeter. It used to be available in my previous institution in Manchester, but it's not considered in the UK as a routine practice for this type of condition.
So the CD4, CD8 ratio is mostly used to differentiate sarcoidosis from HP, and in most of our sarcoid patients, we are biopsying them. So anyways, we don't need a specific ball.
Many times they are there, in case of sarcoidosis, very difficult to differentiate for the tuberculosis. Because both have granulomatous lung disease. Granulomatous disease, both tuberculosis and sarcoidosis. Sometimes we may found no necrotic granuloma in the tuberculosis also.
No, but CD4, CD8 practically is never used for differentiating tuberculosis in my experience. Anybody in the audience is doing CD4, CD8 to diagnose tuberculosis? Nobody.
No. Sometimes you will end up in the situation what to give.
I understand. It may be your experience. That's good to know. But generally, it is not the practice.
I am doing a practice regularly CD4.
That's good. That's good. So between HP and sarcoid, the ATS guidelines say that HP has much more lymphocytosis than sarcoid. This is our experience that our HP patients, at least in our setup, are coming so late to us. They are mostly fibrotic. So we found just 30% of them having lymphocytosis, more than 20% of the bile cell count. While in sarcoidosis, it was 45%. So it is not very diagnostic in our setup. So we go ahead with more and more biopsies, especially cryobiopsies in our practice.
So Sejal, what I want to say is that the cutoff is for non-fibrotic HP of 30%. Yeah. Fibrotic HP will never have 30% lymphocytes. Yeah. And therefore we must know, from the scan whether we are dealing with fibrotic or non-fibrotic. And as a dictum, if we do a BAL, we always do a biopsy. We don't do a TBLC, we do a TBLB. Our yield is very, very good. We took at least 6 biopsies.
Okay. Dr. Goel, any word on this?
Sajal, I may do, bronchial lavage in certain cases just to rule out tuberculosis. That is one.
That is true.
That is true.
Very well
sometimes
used,
we do that.
So but not be doing it is with the expert, right?
Yes.
Gene expert and other things, not
yes.
CD4, CD8.
No, not for CD4, CD8. So that we do.
Yeah.
Now coming to the biopsies, it's a very tricky question, and I think the most difficult question. And I think many times, we go by logic, but we execute up decision on intuition, as a matter of fact. So if somebody who has got a ILD where the diagnosis is not confirmed, where is the diagnosis doubtful, or somebody who is coming to us with atypical features, maybe probable UIP and probable or atypical HP, then somebody presenting with, again, unexplained symptoms of high-grade fever, weight loss, hemoptysis with ILD, then possibly I'll go for doing, biopsy in these patients. Again, rapidly progressive ILDs, where I would like to establish what could the diagnosis be. And then if my biopsy is going to impact the management of this patient, right, whether I would use more of the immunosuppressive therapy, right?
We keep the statement short now. We have just run out of time.
These were the indications that I'll be going ahead with the transbronchial cryobiopsy.
So I can skip this because BIP has been discussed. I just wanted to bring it up here because are you using it as a clinical diagnosis in your practice? It's a question to Dr. Ortega.
Thank you. I think this is helpful. We use for the MDT, but that is not changing the management plan if at some point the clinical, if we don't have a BIP typical, but we believe that the patient maybe, I think, is having fibrotic HP,
But are you using the idiopathic BIP as a clinical diagnosis right now?
No.
After the guidelines?
No.
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 So that is a point I wanted to make.
But I just want to make a point.
In our
that
clinical practice, at least we have not started using it as a term.
Correct. No,
We
but I
still
just
believe
wanna
that
say
a
one
lot of
thing.
it is HP and CDD ILD, which needs to be diagnosed rather than just calling it idiopathic BIP and moving on, right?
So just a minute.
Yeah.
BIP is more for pathologists and radiologists to report. but clinicians are supposed to give it a label, BIP pattern because of so and so. So the thing is that unless it's idiopathic BIP, which I don't
agree.
think exists,
I agree.
we will never write BIP. We will
Yes.
write hypersensitive pneumonitis,
Yes,
drug
so as a
induced.
pattern on radiology and histology, it is a good method to classify radiology and histology. But I do not think it is a good way of classifying a disease clinically. That is, calling a patient to be having idiopathic BIP and not going ahead to really work up for CDDs and HP as of now, because there is no data, no evidence on how idiopathic BIP behaves. Just
Or
a
if
word
it
about
exists.
just a word about genetic testing. I think we'll have to skip treatment. So genetic
Can I just
testing.
answer Shom's question because he asked a question which we didn't address?
Yeah.
Dr. Shom basically had asked that with these new classification, do we give away the HRCT? So I want to say that HRCT even today is the standard only when, so basically the thing is that still even with the new classification, you basically from the HRCT patterns only you're calling it something and then you're deciding if a biopsy is required or not. So basically the patterns are radiologically plus minus pathologically, and of course clinical acumen is required to describe the pattern and fit it into the etiology and give the diagnosis.
I'll just take up only one question in treatment. Nerandomylast. So in the UK, is it available right now? When is
yet.
it expected? And how do you see it in your treatment algorithm for IPF and PPF?
Thank you. The first answer is not yet available. We expect that will be available this year, and depending on what will be the criteria for the NICE, hopefully will be with the criteria as first line monotherapy or in combination therapy, or for patients that couldn't tolerate before nintedanib or pirfenidone for IPF or couldn't tolerate nintedanib for PPF.
We'll just have one statement, pointed questions. Would you use nerandomylast whenever it becomes available as your first choice antifibrotic drug?
Yes.
Why? Because the kind of effectiveness that we have seen from trials, there is no head-to-head trials, there might never be, but from the trial, we can draw conclusions that the pirfenidone and nintedanib trials show a much better effect on FVC decline than nerandomylast. Then why should nerandomylast be your first choice?
Safety profile. So I think it's not for everybody, but for safety profile and also the monitoring for the liver function test, particularly how, because it's important the patient preference and the patient voice.
So, yeah.
Thank you very much. I think we need to stop there. We
Right.
could keep on going with this discussion, but we've run out of time.
Sure. Thank you so much.
Thank you everyone for a wonderful discussion.
Due to the late start in the morning, we will have to skip the official tea break. There's tea and coffee available outside. If you want to grab a cup of coffee and come inside, you're most welcome. We'll move on with our next session, which is the session 9. It's an interesting session where our presenters will be presenting interesting cases, and we have a case discussion. We'll be discussing the cases. For this session, I would like to call upon stage the subject expert, Professor Omar Usmani. Professor Usmani is an MD at King's College London and PhD in Aerosol Science and Inhalation and Medicine, and currently at the Imperial College London. I would also like to call upon stage Dr. Surya Kant, Professor and Head Department of Respiratory Medicine at KGMU, Lucknow. Over to you, Professor.
Great, so thank you very much, and really it'll be great to call upon our moderator for the session, Dr. Madhukar. We're going to change this session a little bit. We're going to make it like a Lungs on Fire session at the ERS. So I'm going to ask 3 of the ERS panel to come up. So Dr. Badawi, Professor Korosowska, and also Dr. Rivera Ortega, if you can come. They haven't seen these cases. None of us have seen the cases. And then what I'm going to ask is our moderator to take over and utilize the panel, but also utilize the audience involvement in terms of these cases. So thank you very much.
Thank you so much, Professor Usmani. It's my absolute pleasure, privilege, and honor to be here with all of you. And as Professor Usmani said, there will be 2 case discussions. And for the first case, I would like to invite Dr. Vidhi Sugirathi. So she is here and she's quite popular, everyone knows her. So Dr. Vidhi Sugirathi, for your first case, please. Thank you.
Dr. Vidushi, you have 10 minutes, okay?
Thank you, sir.
So if you want more interactive, finish in 7-8 minutes. So you will have 2 minutes for interaction, okay?
Sure, sir. Good afternoon, everyone. And I'm Dr. Vidushi, and let's start with the case straight away. So we have a 65-year-old male, ex-smoker, quit 2 years back with the 30 years of smoking, who had complained of exertional dyspnea, which was grade 1, and minimal cuff with sputum for the last 5 years, which is more in winters, and he was diagnosed as COPD and started on LABA/LAMA therapy 2 years back, with which he had significant symptomatic relief and he was comfortable. But for the last 6 months, he has had worsening dyspnea, which has progressed to grade 3 MMRC, but there has not been any significant worsening in cough, no fever, no chest pain, pedal edema, orthopnea, or any other constitutional symptoms that he had.
So, Dr. Vidushi, you have a case of COPD. In your follow-up, the patient has worsened over the last 6 months. It's a dyspnea phenotype. So how do you go ahead to see these kind of patients in your follow-up?
So we have a COPD patient. The diagnosis has been clear. He was improving. Now the worsening has been there. So you have to evaluate the causes of this 6 months of worsening. So an examination of the patient found he was relatively stable with normal pulse, BP, heart rate. Saturation appears to be normal at 95. However, on examination, minimal pedal edema is there. JVP is not raised. No rhonchi. Heart sounds are normal. So such a case, what would be our differential diagnosis in a case of COPD, elderly male? So we have to realize that any COPD could be progressive at this age. He could have poor compliance to inhalers. Maybe he has restarted his smoking. These could have led, or he could have developed some new comorbidities. Could be comorbid pulmonary hypertension, could be heart failure, could be CPFE, or he may, with his significant smoking index, have also developed a cancer.
Yeah. Dr. Vidushi, we have our esteemed panelists with us. So do you all agree with this, or do you want to add something else to this chart or this differential diagnosis?
I think that's a very reasonable differential so far. Kind of keen to hear what you found.
So, Dr. Vidushi, keeping this differential diagnosis in mind, what investigations would you like to do for these patients?
So in general, when we come to these patients, an initial investigation of a chest X-ray and a PFT would be well done. So we did a chest X-ray which only showed a mild hyperinflation, no opacity, no features, other features. A PFT showed obstruction with FEV1 by FVC of 0.67, post-bronchodilator 0.64, but quite preserved lung functions with FEV1 of 74%, FVC of 86%. However, a complete lung function test was done and the DLCO was reduced significantly at 38%.
So a clear-cut great dissociation between the diffusion and the patient's lung function. So one of the panelists, what do you think, keeping those differentials in mind, what do you come to your mind now?
Thank you. So first of all, I think it's because within the differential diagnosis was as well about the possibility of pulmonary hypertension. So it's important we use one of the ratio that is FVC DLCO, and we can see that this ratio at the moment, I have not calculated, but for sure is above 0.95. That is what I think could be, I think it's immediately ring the bell that maybe something could be from the vascular point of view. And plus, it would be really helpful to know the KCO, because if you see that the DLCO and the KCO both are very low, and we can see that actually the spirometry is not too bad, it's not normal, but it's not too bad, that could be another, I think, sign that definitely we will need an echocardiogram and we will need a CT scan, because we need to rule out as well that this patient had not had emphysema in view of the mild hyperinflation.
So I guess the House would agree on this, that the DLCO is a window to look into the pulmonary vascular resistance. And this is what I would summarize at this point of time. You had one differential diagnosis of CPFE.
Yes, sir.
So have you done anything to rule out that?
So a complete lung function test also included the lung volumes and RV by TLC ratio. That was turned out to be normal. KCO was also proportionately reduced as to DLCO. It was also at 40%. So this leads to the confirmation of that. It seems to be more like a impermeability.
Okay.
And
so imaging, you had the one differential diagnosis.
Yeah. So further, we also had, apart from imaging, we'll come to the CT chest, we have 6-minute walk test, which had shown a reduced 6-minute walk distance of 240 meter with a significant desaturation from 95% to 80 and a very sudden increase in heart rate to 148 per minute. And an ECG showed an RAD pattern with RV strain. And further investigations, we also had a CT chest, which the lung parameters were normal. However, there was a grossly dilated pulmonary artery, some bit of mild paraseptal and central lobular emphysema of the upper lobes was seen. An echocardiography showed a dilated RARV, IVS was flattened, TR jet velocity was 3.8 meter per second, which is significantly high, leading to a PASP of 64. The left ventricular function was normal, LVEF was around 60%, and NT-proBNP was 1064 nanogram per liter, which is raised.
So we have excluded CPFE.
Yes,
right.
based on the CT chest,
So
there was
then
no ILD.
Do you find any LV diastolic dysfunction and echo?
No.
No?
No LV diastolic dysfunction. LV function was normal, no grade 1 diastolic dysfunction.
So now I'm coming to one of my panelists. There is a dissociation between PO2 and SPO2. The resting oxygen saturation is 95%. PO2 is 62. How do you interpret this?
I can say that I cannot see any obvious problem from the left side of the heart. In my opinion, it's everything on the right side of the heart, and we can see, I think, it's for any type of pulmonary hypertension, not only the group 2. We can see as well increase on the proBNP, and that is in the new guidelines that was published in 2024. So therefore, I think it's, for me, this, I think, is hypoxia that the patient is having, and everything could be all related with the pulmonary hypertension. What we will need is a right heart catheterism, to rather than just to put the label as the group 3, is actually we are missing something else.
So in this patient, when the echocardiographic probability of pulmonary hypertension is high, would you like to do a VQ scan?
I don't think that is necessary. And I think we don't have the suspicion of our group 3 that that will be the thromboembolic. And if the CTPA rule out any PE, I don't think that is necessary
So
at
Dr.
this
Vidushi,
time.
have you done the VQ scan for this patient?
Yes, sir.
Sorry, ma'am. Ma'am, the PFT was,
95%
95%.
at room air, but on desaturation.
Please have the mic. You come to the near to the mic.
You can just move on the slides. Those slides first, Rachel. So by then, can we continue the discussion? So the differential diagnosis is narrowed now.
Okay, but
So
just a minute. Can I just say what I have
Yeah,
to
yeah,
say?
sure, ma'am.
So I basically feel that a person whose FVCs and FV given are not bad, but diffusion is so out of proportionately low. Patient saturation is 95 on room air. Patient is not hypoxic. And because saturation is 95 on room air, we also know carbon dioxide will be normal. And the patient doesn't have polycythemia. So there has to be another reason for pulmonary hypertension. And this cannot be explained by COPD.
Absolutely.
Absolutely not. We have to look for another cause. Do a sleep
Absolutely
study, do a
agree, ma'am.
CT pulmonary angio, a sleep study.
Yes.
Is mandatory over here.
So I do absolutely agree with this. So we have the two differentials. So we'll come to the ma'am's point when we'll have the discussion going on. So now we have the two differentials in mind. So one is pulmonary hypertension, which is probably in order of frequency, the first. The second is the heart failure with preserved ejection fraction. Do you still
We have a
consider
question
this?
over here as
We
well.
have the question from the audience.
So I just want to make a point. I mean, we have this left heart which is normal, Dr. Ortega said, but it could be HFpEF PH, heart failure with a preserved EF also. So it could be a group 2 PH, or as you rightly said, I mean, it could be a CTEF also, along with the COPD patient. There could be an embolism and then a PH, so it could be like a group 4 also. And I feel it could be a multiple phenotype, not necessarily just
So
group 3.
absolutely.
Yeah.
So VQ scan has been done. It has excluded the possibility of CTAF.
But
No,
VQ, I still feel that it can miss the distal disease, the peripheral disease.
VQ
So
scan
was a
has yes, is the
CTPA done?
100% sensitivity for detecting the CTAF, even if it's distal.
But I agree with my colleague that sometimes you can have, I think it's a negative, but it is a false negative. So I agree, sometimes it's inconclusive. So you cannot rely only on that one.
That's good.
So
Thank
did
you
we
so
do
much.
CTPA?
Yeah, sure.
So-
So we have, We have done CTPA.
So we did a VQ scan. We did have so VQ scan has a 96% sensitivity to detect CTEPH, better than CTPA. So already a CT chest was done. So a VQ scan was done to rule out pulmonary embolism or CTEPH, which turned out to be negative. CTD history and CTD panel was done, which turned out to be negative.
Sure. So what she has deliberately done is here, keeping the differential diagnosis of the group 1, she has excluded the CTD, has excluded the portal hypertension. Have you done the HIV testing for this
Yes,
patient?
sir. HIV test was done, schistosomy acid
So there is
evaluation.
no congenital
baselines.
heart disease. The problem now is, what would you like to do at this point of time? Because we have only two differential in our mind now, idiopathic PAH, and the second seems to be the heart failure with preserved ejection fraction. So what would you like to do at this point of time?
Right heart catheterism, because
Right.
I think otherwise you will not know what is the group. And based on that, if it's a group 1, you have completely different treatments for that, so we have to do it.
She has not included the right heart catheterization picture here, but it came out to be the pre-capillary, I believe.
Yes, sir.
Yeah.
So,
So
until we do the right heart catheterization, we cannot completely rule out group 2 PH, but the right heart catheterization eventually turned out to be pre-capillary
So
pulmonary
it's a
hypertension.
pre-capillary PH. What's your diagnosis now?
In that case, I think it's still, I think with that, I think it looks more like, although it could be, I think it's a group 3 that looks more that, but I think it's one more, I think it's, if you exclude all of this about group 1, will be more about the group 3, and then 4, I think is, I don't know if you have available, but if you have available, for example, treprostinil inhaler, that will be, I think, is what we will prescribe for this patient.
So the only dilemma we had at this point of time is idiopathic PH. If we consider the diagnosis of idiopathic PH with group 1, the patient had hypoxia and DLCO less than 45%.
Well, but the thing is, even from the first day that you met the patient, the oxygen assessment for L-Total and Bob need to be done regardless what is the diagnosis. That is, I think, you don't need to do all of these tests to prescribe oxygen because the patient was hypoxic in front of you. So that, I think, is I was assuming that that has been done.
Can it be?
Madhukar, we have to be faster because time's up
Yes,
for
just
this
2
case.
seconds, we are finishing
Yeah.
it with the diagnosis, sir. Can it be idiopathic PH lung phenotype?
But that, I think, could be ultra. I never heard about that. What you definitely can do is you have more than one group on the same patient. But it's not an idiopathic with lung phenotype. But when you talk phenotype, it's the interaction with the genotype and the clinical picture. That is a different
Correct.
concept.
So we should have a genetic test, Dr. Vidushi, for this
So
patient.
we do
Madam,
not
quick
have a
question.
genetic
Yeah,
testing
madam,
for the
just one
patient.
quick question.
Sure,
One
sure,
quick.
sure. So as we know that, I mean, we ruled out the heart failure with the preserved EF, but did we do a fluid challenge? Because if we do a fluid challenge, we can pick up the heart failure with preserved EF. So it could still be group 2 and group 3. And then the prognosis improves, you know. I mean,
So
if we
totally agree, but we had the pulmonary
we did a right
waist
heart
pressure.
catheterization.
So
once
it was
a right heart catheterization.
It was 11, I guess.
It was
So it was
pre-capillary.
11, so we didn't had any fluid challenge. Had it been 13 to 15, totally agree, would have
Yeah.
definitely been there.
Yeah,
Thank you
Vidushi,
so
continue.
much.
Vidushi, continue.
Yep.
So eventually, sir, we came out to be, it's as a group 1 PH with respiratory comorbidity. So in such a case, because right heart catheterization confirmed that there was severe PH, PVR was more than 5, and vasoreactivity test was negative, the patient was started, which could be started on monotherapy with PDE5 inhibitor or an ERA, a PDE5 inhibitor was started in this patient. Subsequent.
So, you have to conclude the last remark. Are we going right in this direction? Idiopathic PH, lung phenotype, we give the single vasodilator?
No, I think what I think is to point out, I think is that this patient, if we will attribute that is purely with COPD and about the treatment, I fully agree that at the moment we don't have too many options. I think but the patient had emphysema as well. Okay. So what I think is we had it about the negative study with the treprostinil inhaler and COPD was completely negative. But if the patient, if the pH will be related to the emphysema, we have not had any study. And for treprostinil inhaler with pH and ILD was positive. So now I think just as a reflection, if we are assuming that that is purely for the COPD, yes, there is no room for treprostinil inhaler because it was completely negative. Sildenafil could be used, but we don't have any strong evidence for the use.
True.
I think it's unfortunately we don't have too many options for these patients at this time. unless there will be any further clinical trial, and of course, oxygen treatment.
Yeah. Thank you, Dr. Vidushi.
Thank you so much.
Have
Thank
a
you.
grand round of applause for Dr. Vidushi and all our esteemed panelists, and wonderful moderation by Dr. Madhukar. Can we have the second speaker, Dr. Aba Mahashur?
And we
Dr.
will
Aba.
now give the panelist a rest. So the audience, you must now be at the microphone and be the panelists for the next case. So please go to the microphone quickly to ask your question. The interaction will be now with the audience to give the panelists a rest.
Thank you, sir.
Good afternoon, everyone. Without wasting any time, let's start. So we have a 45-year-old female who came to us with a low-grade fever for 2 months. Recurrent, every 2 to 3 months, she had this relapsing trend. With dry cough for 2 months and recently started with breathlessness for last 2 months, amounting to an MMRC of grade 2. There was no history of any allergy, weight loss, night sweats, or joint pain. No family history of any connective tissue disorders, being a young female having coming to us with such a complaint, and no past history of tuberculosis. However, 6 months ago, she had a crop of erythematous lesions in the shin of the tibia, and they went to a dermatologist who labeled it as erythema nodosum. It was self-limiting. She did not take any treatment for it per se. Now, on evaluation, the chest X-ray, as you can see, showed some hilar prominence with some reticulonodular opacities as well in the mid-zone of the lung. And this was the profile done, as she was at that age where we also suspect a connective tissue disorder. So ANA was done, RA factor, anti-CCP all negative. ACE levels came as 66, vitamin D 11, and calcium levels were slightly raised, that is 14.
So Dr. Abba, to begin with, what was your clinical differential diagnosis? And with this sort of investigations basic, what differential diagnosis now you have?
So, sir, at a middle-aged female who comes to us with a progressive breathlessness and has been having this relapsing trend, we definitely are looking either at a connective tissue disorder with which she's come, although she did not give any history of multiple joint pains or anything. If you see the chest X-ray, it shows me reticular opacities at the mid-zone of the lung and the ACE levels being positive. My mind directly goes towards the possibility of sarcoidosis in her case.
So how do you go ahead now?
So
and
we
also
went
hypercalcemia.
Yep.
Hypercalcemia also.
and
Yes,
along
yes,
with
yes.
hypercalcemia, absolutely.
Do you have a question? Okay, fine.
So, and then we did an HRCT test for the patient because in our domain, a patient who comes to us with fever, we still have tuberculosis in our mind. We still want to rule out an infective pathology at this point in time. I've kept some representative cuts where we could see a subcarinal lymph node enlargement and hilar lymph node prominence. Along with that, we could see phygital nodules. We could see some interstitial opacities predominantly in the mid-zone of the lung. So this made our thought process even more consolidative towards the possibility of sarcoid, but yes, the mind still keeps on in the direction of ruling out tuberculosis for her.
So does this house believe that this is sarcoidosis more than anything else? Yeah? Do the house believe that this is conglomeration of the nodules? Okay. So Abha, how is it different from the Lofgren syndrome that we see in the sarcoidosis?
So Lofgren syndrome will have bilateral hilar node prominence. It will have an acute presentation. You're going to have erythema nodosum in this episode and arthritis, severe arthralgia. So that's an acute presentation. So this lady could fit into the first two, but she was not fitting with the third one. She did not have any small joint involvement, no arthralgia.
And also the parenchymal lesion.
Lesions
Had
were
it been the pure Lofgren syndrome, we wouldn't have done anything.
Nothing. So Lofgren syndrome, Hereford syndrome, and lupus pernio. In these three situations, we
Yes,
don't have to
ma'am.
do anything. It's a clinical diagnosis.
Yes, sir.
Sir, let him discuss his way, sir.
Yeah.
Sure, sir.
Correct.
So this is what I feel you should take the discussion forward, involve basics and everyone along rather than going straight on the lines
Sure, sir.
of the sarcoid. And then what is your discussion point?
Fine.
I would like to say that the CT scan is showing classical fissural nodularity. There is beaded septum sign which is positive. We have perilymphatic nodules which is only seen in sarcoidosis or lymphangitis carcinomatosis. So I kind of feel that you are absolutely justified in taking discussion the way you're taking. It's quite, I completely support this.
So,
So this was, so because the patient was breathless, we could not do a PFT right away, but we did have an access to a PFT which was done a month ago for this patient. And she categorically told us she could not complete the study. But we did have an FVC which was less than a liter. We did have a restrictive pattern, but she could not go ahead with the diffusion capacity performance. And the 6-minute walk test which she could perform, walk distance was very less. She was very dyspneic at the end of it. Beginning was comfortable. So she started with 95% of saturation, went down to 85%, could hardly walk for 200 meters, so the test was abandoned beyond that. At this point in time, so what next should we do would be the question.
So let's ask the audience, what next? Come to the microphone, put your hand up or shout.
Dr. Usmani?
Yes?
Yeah. So basically, this patient had hypercalcemia. So did you do anything, I mean, before we did the 6-minute and PFT?
So we have not done the PFT in this admission. It was an information for us from the previous admission. Because of these things, we could not perform that study at this point in time, but we immediately started hydrating. The moment we get hypercalcemia as an entity in a clinical zone, we start treatment immediately. But then we still have to rule out other differentials.
I think she has...
yeah, we have another question point here. What next?
Yeah, can this be a sarcoid tubercular overlap?
It can be. So
yes,
in
because
Indian...
with the advent of the EBUS facility,
Correct.
especially in
Correct.
India, we see typical sarcoid patients, but once you do a EBUS, the gene express positive. And that somehow puts the question in the mind, is sarcoidosis nothing but the hypersensitive response to tubercular antigen? We have seen many patients where we clinically it is sarcoidosis, ACE negative, everything like that. But the gene expert is...
So I believe
pointing
you want
towards
to
the
have the
process.
investigation in the form of...
Just one
Yes.
thing.
sure.
Did we do a creatinine in this patient?
Sorry? Yes, we'll come to that. We'll come to that. So
So
we,
that-
like completely synchronizing with our fellow colleagues' opinion, being in India, having TB as an endemic problem over here, we cannot rule that out. So we still have to go in with an invasive procedure. So we went ahead with a bronchoscopy with BAL, EBUS and TBLB. These were the results of the investigation. We did not find any endobronchial findings in terms of inflammation, nodules, salt or pepper appearance. We did not find that. However, the BAL showed lymphocytosis. We could manage to get the ratio, which you can see is right at the border. Now, gene expert in BAL was negative for MTB. We did a TBLB, non-caginating granulomatous inflammation. We did an EBUS as well. And there we again got the similar finding. In this context, always done, Mantoux is something which we always do because like Sir has in mind or even you have in mind, TB cannot be ruled out only with the eyes seeing certain findings. We always have to rule that out. Now at this point in time, we went ahead with further evaluation. Like we said that now we're thinking of it going towards the sarcoidosis. We have to establish, like how Dr. Bubna rightly pointed out, that are we dealing only with the pulmonary domain of issues or are we dealing with the systemic domain? Because this is a systemic disease. It can present, 90% presentation is thoracic, but there are other organ involvements which are known. So we did an eye examination as per the recommendation, which was normal. Serum creatinine was normal. Alkaline phosphatase transaminases were also normal. Complete blood count normal. Remember that whenever you have, like Sir said, a bilateral hilar lymph node with hypercalcemia, lymphoma still continues to be a very, very important differential. So we need to rule that out. Electrocardiogram was done, which was normal, and 2D echo was done, which was also normal. We know that patient was breathless. So his PASPs were borderline. They were not very high. They could not fulfill the cutoff of high pulmonary.
So, Dr. Abba, just interrupt you from. So you find no alternative explanation for the presence of non-necrotizing granuloma in the tissue biopsy?
Correct.
So the sarcoidosis diagnosis is something the house agrees on? Yeah, so great. So,
There's a question over here.
Yeah, please.
Before proceeding for any invasive workup, I thought Mantoux test should have been done prior in the initial workup itself.
It has been done.
We had run the test.
It has been done.
Yeah,
It is
we
negative.
had run the test when the patient came, but it takes 72 hours of reading. So all this so I'm just running like a normal case, like how a patient comes to us and what we start thinking, what we do. So Mantoux was done. The day we got the biopsy, we got the results of Mantoux.
So
which was
Dr.
also
Abba, the house agrees that it's sarcoidosis. Can we move ahead?
Yes. One point, just like Sir said, that other differentials, even when you get a biopsy proven, we need to know there are other granulomatous things which can exist. So infective, we have TB, we have fungal infections, we have brucellosis. Non-infective also, we can have HP presenting this similar situation. So all these things also have to be put in correct clinical diagnosis. Now, so I believe that the house agrees that we are dealing with...
Just a comment.
Sorry.
Endobronchial biopsy and transbronchial biopsy could have been done in this case because
totally
They were done.
We've done that.
endobronchial biopsy.
So because endobronchially, we did not find much of inflammation.
He's asking about TBLB.
30% of the cases, even with the mucosa normal, you may find something in the sarcoidosis.
Correct. Because there were nodes which were large, so we went ahead with EBUS.
If I may just add, many times immunoglobulin profile is something which has not been discussed, should be done. Because we get hypogammaglobulinemia presenting just like this. So if you have hypogammaglobulinemia in this picture, it would not be sarcoidosis. It should be hypergammaglobulinemia in sarcoid.
So now we had,
Dr. Abha, very nice case actually. Did we do a parathyroid hormone? That way we can rule out the primary hyperparathyroidism also.
So the clinical picture completely had fit into sarcoid, so we did not go ahead with parathyroid hormone at that point in time. But yes, that's a good input that we could have done that in addition.
Yeah, I think I completely agree because it could have been a parathyroid adenoma, which is by the way there.
Yeah.
So PTH is a must for any
Yes.
high calcium.
And that too with such degree of hypercalcemia.
So
we need
can
to
we-
have
can we go ahead with treatment?
So I think we need to wrap up now.
Yeah.
So you have 30 seconds.
Perfect, thanks a lot. So we had these options to treat our patient with. Like Dr. Indu rightly pointed out that we did hydration as a priority because patient was symptomatic, breathless. So corticosteroid came as a right mainstay for us. We are short of time, otherwise I would have loved to discuss.
I'll just take a minute. So the house head has to raise their hands. Can you go back? Yes. So option 1, how many hands are there for the option 1?
Only observation and hydration, nothing more
So
to be done.
just 3 or 4 people for the observation and hydration?
I think we should just move on. We've seen the answers on the next slide, so the House knows. So you have 20 seconds.
True. So we went ahead with this option, but unfortunately, in clinical science, things evolve. Patient showed good clinical improvement with 0.6 mg per kg of corticosteroids being started, but on follow-up, he had a huge swing in sugars. And so on personal request, we had to replace the steroids with methotrexate, which again definitely helped the patient. And then we have a data coming up from the recent PredMeth trial also, but there is still a lot to discuss because the trial only talks about 6-month follow-up for us. But it's a good alternative for those patients who are not acutely symptomatic to start methotrexate as a primary prerequisite. So just summing up, as a treatment plan, we have anti-inflammatory, we need to have anti-fibrotic or no, would depend upon whether patient has a progressive pulmonary fibrosis component or no, otherwise answer is no. We have inbuilt trial with nintedanib which proves that if sarcoid has fibrosing element which is worsening, you can start nintedanib. Antacid routine, pulmonary rehabilitation, regular vaccination, and do not forget to screen for other organ involvement. So in the end, sarcoid is a multisystemic progressive relapsing disease. Please identify the clusters correctly. Other granulomatous diseases must be ruled out, and treatment plan is very important in terms of timing, choice of drug, dose, and duration. Everything needs attention. Thank you.
Thank you. Thank you, Dr. Rao. Very nice. Nice.
Abha, just a point, fantastic case, but if a patient has hypercalcemia, you need to give steroids. Even if the patient gets diabetes, you cannot replace these patients with methotrexate because the study did not see the effect of methotrexate on hypercalcemia. So in this case, we cannot use methotrexate.
Great, excellent. Thank you very much. Thank you to our moderator. And now we will ask the other members of the panel to come up, please, now for the rare lung diseases in India. So the other members of the panel are Dr. Naveen Dutt and Dr. Balamurugan. And then I asked Dr. Thoma to come up with respect to being the moderator.
Dr.
And
Viren
thank
Tomar,
you.
Dr. Viren Tomar and his team, please join.
And thank you, Dr. Kant, for being the co-chair.
Can I ask one question? Excuse me. Can I ask one question?
We're out of time now. For the last case?
Okay.
Yeah, go to and we can have a chat.
Regarding the choice of antifibrotic in sarcoidosis, we have now nintedanib, we have pirfenidone, we have a new drug. What is your take regarding the selection of antifibrotic in fibrotic sarcoid? Because now we have 3 drugs available. Whether it will go for combination or in isolation.
Thank you. I think it's definitely, if we have a case of fibrotic sarcoid, and of course if this patient, despite the timely treatment, that in this case, for example, would be with the steroids and maybe alongside methotrexate, and although I think we will be tapering the dose of steroids and maybe reducing a bit the steroids with methotrexate, if that is not enough, now we have the next treatment line will be infliximab. If we don't have, I think, any response from the pulmonary point of view. I'm not talking about the hyperglycemia, the hyper, I think it's calcemia. If after the infliximab we're still not having the response that we expected, then I think it's the fibrotic point of view will be with nintedanib. What we don't have, because sarcoidosis, we have a strong inflammatory driven. So if you started nintedanib up front, you are not tackling the mechanism of action. Therefore, I think we need definitely the first line will be a steroid plus minus methotrexate, and then for the pulmonary aspect, we have infliximab for these cases of refractory aspect. If it's purely more fibrotic rather than inflammatory, and all the other extra pulmonary aspects are under control, you can just jump in, and rather than to go for infliximab, you can go directly to nintedanib if the patient meets the criteria of PPF.
Thank you. Sorry to interrupt. May I ask a question? What is the experience with infliximab in your practice for sarcoidosis?
Thank you. We don't have too much experience in the UK because just has been granted last year as a standard of care. The previous experience was purely as per research. So we are collecting data national-wise for the first cases with infliximab. In our center, we don't have not more than 10, I will say, with infliximab. But we have, I think, expert centers in the UK for complex sarcoid, like at the Bronton Hospital in London, or in Birmingham, or we have in Coventry. So all of these, we have complex sarcoid, we are referring for these centers that are more multi-organ sarcoidosis, and we will have the data for sure will be available for publication. But at the moment, I don't think that I will be in the position to provide an expert opinion. We have only no more than 10 cases. But overall, the response is quite good. I would say why we didn't manage to achieve with steroids and methotrexate in combination, they respond quite good to infliximab, but we need a multidisciplinary approach to be able to achieve that.
Thank you. Yes, Dr. Tomar, please start your panel discussion as a moderator. So have a grand round of applause for a new panel discussion that is on perspective on rare lung diseases in India. Dr. Tomar is moderator, and Dr. Naveen Dutt from left side, and Dr. Bala Murugan and our international colleagues. They are panelists along with our co-chair, Dr. Usmani. Yeah, please.
Thank you, Dr. Surikant sir, Dr. Usmani. And good afternoon, everybody. I want to extend my heartfelt thanks for ERS and ICS for this panel discussion. To start, we are having eminent panelists. So, in previous panel, you have discussed what are the common ILDs. Now, we roll on like, how do we define the rare lung disease? I want to ask the panelists, like Dr. Johanna, if you answer. What is the definition by, it's like similar to orphan disease, or is it a little bit different?
So it's incidence of the disease. This is the defining factor. Incidence, the prevalence. And although we have a, let's say, worldwide definition, I would like to say that it also very much depends on the regional situation, because there are differences, there are diseases that are more prevalent in specific regions. Even coming from my experience with alpha-1 antitrypsin deficiency, we would see completely different situation in terms of the genetic background in Spain, for example, and then quite different in UK and Scandinavia. So while prevalence is a decisive factor, there are also other factors that need to be taken into account. So having said that, I am quite strongly opinionated on the fact that the national society or national experts need to come to agreement how to approach this issue at the national level.
Dr. Rivera, is there any different in the other part of world, like in India, we are having other diseases? Is there any difference between the different part of world, different diseases are rare?
Maybe I can answer this. Do you want? Thank you. This just to complement that I fully agree with Joanna. And in terms of the numbers, in the UK, for example, a rare disease is defined if we have less than 1 case per 2,000 people. But that is in the UK. But as Joanna said, maybe that will be different. It will go to Latin America, it will go to Asia, Africa, or in Europe overall, or even here. So just to say that we need to be cautious, I think, is which region and country and continent we are talking about. I'm sorry.
So rare lung diseases depends upon diseases affecting the lungs which are rare in which part of the world, how it presents and how it is being diagnosed. For example, bronchiectasis, even though classified as a rare lung disease, I think in India it is quite common. I'm talking about non-cystic fibrosis bronchiectasis. Obviously, cystic fibrosis bronchiectasis might be a rare disease in India, but having said that, I've seen about 1 to 2 cases in the last couple of years. Same point of time, sarcoidosis is keeping on picking up. It all depends upon the awareness and the availability of the facilities.
Thank you, Dr. Bala. So, in India, we are having the tuberculosis rampant. So, there is a quite mimicry with the other cystic lung diseases. So, in next 15-20 minutes, I am having few cases. On that basis, we can interact. So, what the mind doesn't know, the eyes can't see. So, is it skull or is it popcorns? So, the same way, the different ILDs look like different patterns, different cystic lung diseases show different pattern, but definitely with the history, clinical examination and few tests, we can make the proper diagnosis. So in India, like this is all the long list, which Dr. Bal already mentioned, that NTM is nocardia, and especially the ILD, specifically is the MDA5 ILD, this is a very rare disease we come across. And in bronchiectasis, the PCD, primary ciliary dyskinesia, cystic fibrosis is rare. Some pleural tumors and genetic disease, definitely we are having lacking of the different investigating tools, so we can say that India we are having this type of rare lung disease. So, like we start with cystic lung disease, how we discuss. How many cases of cystic lung disease do you see or manage in your practice per year? Any panelists, Dr. Naveen? 1, 5 per year, 10 per year, 20 per year?
So, we see around 10 to 15 cases in a year.
Good number.
But most of them, they are ultimately turned out to be hypersensitive pneumonitis. So, we see some other cystic lung disease, but in India, if we talk about cystic lung disease, the first differential to be ruled out is hypersensitive pneumonitis.
Dr. Yahab, do you have how many cases per year?
So obviously in the context of pleural disease, particularly with patients presenting with pneumothorax, we screen quite actively for cystic lung disease. So I'd say probably in the region of maybe 20 to 40.
Okay. So let's start with one case. A 32-year-old premenopausal woman, progressive dyspnea on exertion for last 2 years, history of recurrent pneumothoraxis and recent episode of hemoptysis. She reports dry cough and fatigue, but no wheezing or fever, no family history of lung disease, and patient is tachypneic, saturation is 88% room air, reduced breath sound bilaterally, and with basal crackles. So how do you mention, any from audience want to interact? Anyone? Yes. On the X-ray, just comment brief, just.
This may be a case of LAM. Lymphangiomyomatosis.
An X-ray, what is this?
There is a fluid level.
Pardon?
A fluid level right on the right side.
Okay. So,
and
see, this is her picture, facial expression, you see. This is exactly that. Diagnosis is quite true, but in X-ray you can see the pneumothorax on the right side, and this is the cystic bilateral symmetrical
can you
cystic.
show me the
Dr. Tomar,
X-ray?
Question from Dr. Nautiyal.
Can you show me the X-ray again?
Previous X-ray?
X-ray, yeah.
Yeah, this one.
This air fluid level was there, but the lung marking is not visible. Okay, fine, there is, that one is there. So there is hydropneumothorax is there.
The pleural line is here going up straight, like this. Okay. So, CT you can see the different renal angiolipomas. So the diagnosis is obvious as a LAM, definitely. So it's a very progressive cystic lung disease, more in women, childbearing age group, and two types, sporadic and the tuberous sclerosis complex like this. And we all know the mutations and how the LAM cells infiltrates, just to give the audience how it presents like clinical manifestation, we all know. So regarding this treatment part, so do you prefer this, the sirolimus, the panelist, I want to ask Dr. Bala, do you want to treat these patients with this sirolimus, or what your approach when treating these patients like this?
Even though we are justified in starting the patient with sirolimus, it all depends upon various factors like the availability, the cost factor, because in this part of the world where I practice, most of the patients are not being covered by insurance. So if the cost factor is high, even though I would like to put the patient on sirolimus, they might not be able to afford for the medication.
Right. So what are the challenges in collecting data, advancing research and patient support programs in India? So what are the problems what we are having? It is a very important issue because in this forum, like in Europe and Western part, we are having good registry numbers, clinics. So anybody from Dr. Bala, Dr. Naveen?
So especially in the case of rare lung disease, the number of patients, they are too less in a single center. The issue is to, for different institutes, different people working in the field of rare lung disease to come together and collect the data. Unless we do a collective record keeping, it's difficult to have any meaningful data on the rare lung disease.
Like for ILD registry, we have Dr. Shitu has done wonderful work. Then the same way for rare lung disease like LAM and all that, we require some registry like this. So why are cystic lung disease missed? We already mentioned by Dr. Bala, it's due to the TB mimicry and lack of these investigating tools. But the important thing is when we are not, the TB is not responding, then we have to look other cystic lung diseases that we are mentioned here. So advice from the European experts, Madam Joanna, regarding this like LAM and all these cystic lung disease.
I have two comments because I could fully relate to what you just described. India is it's a huge country, so the solutions that might be effective in at least some European countries with one referral centers where all the patients could be, properly diagnosed and treated, is definitely not the solution. However, creating a network of centers that have expertise and then having the discussion between those centers, the proper protocol that centers follow, standardization of the testing, and specifically, that would be my second strong advice in terms of genetic testing. This is quite important. This is what we have experienced back home, but not only in Poland. This is also true for the European diagnostic centers in terms of genetic. We're just about to publish the report from the European validation project on addressing the quality of genetic testing for alpha-1 antitrypsin deficiency. And for the simpler tests, for monogenic diagnostics, it was fine, but we really have seen a quite unsettling diversity in terms of more complex NGS-driven diagnostics. So my very, very strong suggestion would be to come to a certain agreement and identify high-quality labs that would provide you with very reliable genetic testing.
Thank you.
Thank you.
So the next is 27-year-old female, fever off and on since early childhood, cough, mucopurulent expectoration, breathlessness since childhood, recurrent sneezing, headache, and she has taken empirically ATT and no evident past history of diabetes, hypertension, etc. The bilateral course crepes and bronchi. Sir, any comment from audience?
This looks like an early onset disease. I mean, he's 27 years. He or she, I didn't see that. Can you please go back to the earlier slide, sir? I mean, with recurrent cough with mucopurulent expectoration and fever. So this looks like an early onset, 15 years of breathlessness with upper respiratory chronic rhinosinusitis probably. So it looks like a case of bronchiectasis. And we should go ahead and get an X-ray and
you are right,
then an
Dr.
HRCT.
Yeah, perfect.
Yeah.
So what about the comment on this?
Yeah, so this looks like a bilateral lower zone, probably tubular bronchiectasis kind of a thing.
So the important thing, we have to look the marker. You see, this is the marker is on the wrong side, and now the diagnosis is very clear. This is a Carter-Jenner syndrome. So,
Primary ciliary dyskinesia.
yeah, this is primary. So in CT scan, you can see this is cystic changes and situs inverters, bilateral maxillary sinusitis. So these type of cases, when we came in our OPD practice, and there's a lots of number, India having lots of cystic lung diseases, and the important thing we have to look and which investigations we have to do, that's important. So just to mention here, what is this? The abnormality in the Dynein arms. And so important thing is the nitric oxide test. I will go ask later on. This is the newer guideline I am mentioning here, the European Respiratory Society and American Thoracic Society for the diagnosis of primary ciliary dyskinesias. So you can go through, this is a very important, recently published in 2025, algorithm of diagnosis of PCDs. I'm not going to discuss in detail here, and you can go like this. So the prevalence is not very much here, and it's again in coming to rare lung disease, but definitely the such type of patients we have in our practice. So the question is, what tests do you have access at your center from the panelists? Anyone, the nasal nitric oxide test you are doing in your clinic practice routinely, Dr. Bala?
Not on a routine basis. One thing is availability of centers. We do have a nasal NO assessment, but once again, amongst all the things, the 5 choices what I had given, I think the least sensitive would be the A, nasal NO assessment, because lots of confounders in that. Say for example, that value would be very low if the patient is having a concomitant rhinitis or a nasal polyposis, or sometimes even patients with primary ciliary dyskinesia would be having a normal nasal NO also. So I cannot go only by that. Okay. All other things are okay. But only thing is the expertise and the technicality in doing the other tests. And
Yeah, I want to ask that in a few seconds. Can you tell me what is the little bit, how the procedure you perform for the nasal?
I don't go for any of the other things in my center.
No, not for nitric oxide. How to perform you, this is the nasal canal, how to put the nasal canal. You ask to patient breathing from nose only or from mouth also?
No, only through the nose we do that.
Okay. Thank you. So regarding the transmission electron microscopy and other tests like HSVM, genetic testing and the immunofluorescence testing, anybody from audience, do you have any center? Dr. Indu?
So we don't have the center, but I mean, it's done under a microscope. It's very easy, and you check the ciliary movement.
So anywhere in India, in like in audience, Dr. Yeah, boss. Do you have in Jammu? Yeah. Kashmir, yeah, is excellent. We are having one center, we are doing this nitric oxide test.
Yeah, one more doctor. Yes, please. Ask your question or comments.
I had one question actually to the European panelists as well as I think Professor Chalmers is also with here. So both. So I had a similar case like the one described. Besides dextrocardia, normal bronchiectasis, but facing a lot of gynec problems, infertility and other issues. Diagnosed with the genetic test with primary ciliary dyskinesia is there. Now in such cases, I think we had a session also yesterday on the newer therapies or newer options. Now they did go to the gynecologist, they went through all the problems, but fertility solutions are not possible in her case. So with the respiratory and in such a case scenario when we have problems, so are any of these newer modalities or newer drugs which are being developed for specifically bronchiectasis, can they be utilized in such cases and like specifically in such a case scenario?
Definitely. Dr. Parvez, so you are doing only nitric oxide tests, other tests also? Pardon, sir?
High-speed video
microscopy. Oh, great, sir. Great, thank you. So the problem is lack of awareness regarding these type of diseases, especially PCDs, lack of referral from the doctors, lack of diagnostic tools, and what can be done is we have to discuss here. Will establishing center of excellence like Dr. Parvez already doing and hub and spoke model will help. These are great questions.
Yeah.
So,
can I ask a question?
Yeah.
The thing is that exhaled nitric oxide has an inherent problem that patients with allergy and sinusitis, and these also patients due to as they present, this exhaled nitric oxide cannot give a confirmed diagnosis of this condition at all. That is one. The second thing is that the genetic testing, which is the primary, we'll do an exome testing basically.
Yeah.
That is the best test, but unfortunately it's costly and the results come in late. Because I recently had a patient, I had to put on her on BiPAP and we couldn't save her, unfortunately. The results came in too late. So as far as the microscopy that we're talking about, Dr. Kaur is talking about, how sensitive and specific do you think is it? Because in my opinion, that also is not too sensitive and
You
specific.
are right. The panelist, the expert panelist, can you answer this? How sensitivity is the nitric oxide test? Is it always positive or you can...
I didn't hear the question, sorry. Did you hear the question?
Nasal
If
nitric
the
oxide
question-
test. They are asking
if the
about the
question is-
sensitivity of the nasal nitric oxide test.
Okay, can we reroute the question for James? But actually, he's the expert about PCD. Thank you, James.
Okay.
So, like any diagnostic test, the sensitivity and specificity depends on the population that you use it in. So if you test people who are highly likely to have PCD, it will have about a 90% sensitivity and a 90% specificity. So it's low in most people, but there are PCD genotypes that give you a normal nasal nitric oxide. You need to not do it within 6 weeks after a respiratory tract infection because, as has been discussed, that will give you a false low nasal nitric oxide. But in the right patients, meaning you've taken a good history and they've got features consistent with PCD, it's a good test, but not a 100% confirmatory test. Genetics would be ideal, but obviously difficult to access. You get a lot of variants of unknown significance, which means that even the genetics can be quite difficult to interpret. So this is where the other tests, particularly electron microscopy, comes in. It's a difficult one, but the message I would give to the room is the key bit of the diagnostic process is the history. Most patients, you can get a very strong suspicion just by doing a good history.
Dr. James, can you, in the same way, which genomic analysis like whole exome analysis, whole genomic analysis, clinical genomic analysis, and single gene testing, anyone from audience or panelist? Which genomic analysis you want to order, sir?
Yeah, we do the whole...
Particularly, all genomic sequencing?
No, that is very costly. So we do the whole exome sequencing, and it very rightly, I mean, the reports also come early, and it's not that expensive. So we come to the diagnosis. It helps in counseling the patient's family members. It also helps in patient satisfaction because they know why they are getting the bronchiectasis so early on in life, you know. So it helps. Yeah, and I just want to make a comment. I mean, bronchiectasis is a very common disease, so we are putting it in the rare lung disease. I mean, I personally see 7 to 8 patients
bronchiectasis.
every day.
This is the PCD and the Carter-Jenner syndrome. Exactly, not PCD. It's
So one
quite
of the
common.
causes of
Yeah, this is Carter-Jenner syndrome, the rare lung disease. Yeah, Dr. James, regarding this.
Yeah, so exome sequencing is much cheaper than whole genome. You'll get about 70% of patients.
What about the clinical genomic analysis? There's an important...
Yeah, so there are various panels. The important thing to know for your clinical panels is how many PCD genes are on there. Because a lot of the commercially available panels are 20, 30 genes, and there's 60 known PCD genes. So depending on the constitution of your panel, you may miss a very large number of diagnoses. A lot of these ciliopathy panels are designed for kidney disease and things like that, so they have a few PCD genes and lots of things that are not clinically relevant as well. So I would just say, please involve a geneticist who knows what they're doing.
Dr. Joanna, is it true?
May I just comment on it? Because it's really fantastic, James, to hear it from the clinician who is involved with the diagnostics. This is a general issue with genetics. So there is no point of doing whole genome sequencing. This is very expensive, this is very lengthy, and also access to proper sequencing is very difficult. And this is exactly the point. Whatever genetic diagnostics, whether it's PCD or any other rare disease, make sure that the lab that you are working with really knows what they do. I mean, it's not only about sequencing per se, because sequencing, it's more, sorry for the comparison, it's like a car. To have 4 wheels and a driving wheel not necessarily means you are driving BMW. So this is exactly true for genetics. So make sure that the lab really has the expertise, and then interpretation as well is tricky one. So for that you need multidisciplinary or at least 2 experts to discuss the case. Thank you.
So
Just
it's very...
if I may have just a very quick message. even with very good genetics, you won't solve 30% of PCD because some of the genes haven't been discovered yet. So if you've got a patient who's got bronchiectasis since childhood, rhinosinusitis, all the features of PCD, and the genetics comes back negative, it's probably still PCD.
But that comes to the fact, as you mentioned, make sure that you know what you have really, what have you tested.
Yes. Who have you
Is
tested?
it true in Europe, most of the or Western part of the world, every baby is getting PCG card test for routine testing at the birth,
Can you
at the
repeat,
time of
please?
birth? Screening test
No,
for...
it's not.
No?
It's not. No, it's not.
Yes.
My question is again on the lines to genetic testing. So how do we interpret the variant of unknown significance that pops up on the whole exome sequence report?
Pardon? Again, madam.
How do we interpret variants of unknown significance that pops up on the report of whole exome sequence?
Dr. James, I think.
So there's a really cool website called Ciliovar that's been funded partly by the European Respiratory Society. It lists all of the variants. You can go in, put in your gene, and it will tell you whether this has been seen before, whether it's pathogenic, what the results of microscopy look like. It's brilliant, and it's created by one of the ERS CRCs.
Thank you. Thank you. So I think the time is short. We can't discuss the next case. So the myositis associated ILD, already in the previous panel discussion already mentioned, if you're suspecting the myositis ILD, you have to send ILD panel along with myositis extended panel, that is important, and MDA5 entity, that is a very rapidly progressing ILD, we have to keep in mind. So the final comment from the...
So we have a significant experience with the myositis and antisynthetase. So we have around 80 patients over last 2 years. So in our experience, any patient, young patient, female patient, and even having a muscle involvement or CKNAC positive, aldolase positive, or maybe on CT having organizing pneumonia, or maybe NSIPOP or fibrotic OP, these patients, all these patients should undergo the myositis testing. MDA5 is not essential unless it is rapidly progressive ILD, because many of these patients, in fact, the majority of patients, they don't have any muscle involvement even on the MRI and PET CT. So, and no skin involvement also. So I would like to emphasize, and even the elderly patient, 60, 65, 70, we have seen subclinical muscle involvement on PET CT and MRI. So, and I've seen I was in Brompton, so I've seen the Asian population, they tend to have more the connective tissue disorder. So somehow, I don't know whether it's a regional thing in Rajasthan or maybe all across India, the myositis, the hidden, the myositis is common.
Thank you.
So we should be doing testing in all the patients.
So thank you to all the panelists and the audience for this great discussion on this rare lung disease. Thank you, panel chairpersons. Thank you so much.
Thank you very much for great moderation. Thank you, panel. So we go on to the next session, and thank you, Dr. Khan from Lucknow.
After making our strides in the fields of airways and ILD, it's time for something else. It's time for infections. Presenting with the next session with a star-studded lineup, session 10 called After the Infection, the Evolving Threat Landscape. And for this session, I'd like to call on stage the subject expert, Professor Chalmers, Chief Editor, European Respiratory Journal, Respiratory Physician, University of Dundee at UK, and Dr. Arun Madan, who happens to be the Professor and Head Department of Pulmonary Medicine, NDMC Medical College, New Delhi.
And for this special session, it gives me great pleasure to welcome my friend, colleague, everybody in the room I'm sure knows him, from Pune, India, Professor Sandeep Salvi. He's widely published across multiple fields, but particularly in the area of tuberculosis. He's made masterful contributions. And he's going to talk to us about this key issue of post-TB lung disease, which generated a huge amount of discussion yesterday. And I think he's going to take us through what is a really important and emerging problem. Sandeep.
Thank you. Thank you very much for those kind words of introduction. Wish you all a very good afternoon. Tuberculosis is one of the greatest success stories in global infectious diseases. 3 decades ago, we needed specially trained TB doctors to tackle the ravages caused by pulmonary tuberculosis. But as we can see here, the tremendous decline in the deaths that are associated with TB all over the world, be it the developing countries or be it the developed countries, has been absolutely amazing. So we all know that the tuberculosis incidence is decreasing, the TB survival is increasing. However, there is this paradox of TB success. Post-TB chronic respiratory morbidity has now been shown to be increasing. So the treatment of tuberculosis doesn't stop after you have had a microbiological cure. Actually, this is the beginning of post-tuberculosis chronic respiratory morbidity. We seem to have eliminated the bacillus, but not the disease. If you look at the PubMed citations for the publications in this field of post-TB lung disease, you can see a sharp and sudden increase over the last 10 to 15 years. Before 2010, scientific literature began to show persistent symptoms after TB cure, but it did not receive as much attention. Between 2010 to 2020, there was a sudden growing research and expert consensus that chronic sequelae of post-TB are quite substantial. From the late 2010 until 2023, that's a couple of years ago, there has been an increasing inclusion of post-tuberculosis lung disease in expert meetings. And over the last couple of years, the World Health Organization, TB operational guidance, and knowledge platforms have explicitly recognized post-TB health outcomes, including lung damage and need for follow-up. This is a brilliant paper published in the Lancet Infectious Diseases a few years ago that actually estimated the number of post-TB lung cases, the number of survivors in post-TB. So in 2020, the estimates were around 155 million TB survivors globally. Today is 2026, so when you extrapolate that to 2026, there are an estimated 190 million TB survivors, at least as of today. India itself would have more than 50 million TB survivors as of today. If you look at the life course of pulmonary tuberculosis, around 5% of them would die because of the tuberculosis infection and disease. Many would survive, lead a near normal life, but a substantial number would also survive and live a life of suffering. So about 5% die and about 190 million TB survivors. The health metric that healthcare policymakers use all over the world is called disability adjusted life years. This is a combination of years of life lost, which is mortality, and years of life lived with disability, which is suffering. So if you look at the DALYs associated with pulmonary tuberculosis as a disease, the global TB DALYs is around 64 million, but even more importantly, if you look at the DALYs associated with post-tuberculosis, it is close to the same figure, around 58 million. The moment you are diagnosed with a pulmonary tuberculosis, you have already lost 3.6 years of your life. And this has been shown by a very beautiful paper published quite a few years ago. So the impact of post-tuberculosis is quite extensive, and it is only now that we have suddenly started waking up to that. When I was a postgraduate student more than 3 decades ago, we were not much aware about post-tuberculosis lung disease. We used to write this as an exam paper, but that was it. We never applied that knowledge in clinical practice. Perhaps the only post-TB lung disease that we were concerned about was post-TB bronchiectasis. Other than that, there was not much appreciation or knowledge available. This is a paper that was published a few years ago from Hyderabad, looking at the radiological features of patients who were treated with pulmonary tuberculosis and declared cured. These are the patients who come to the clinic with respiratory symptoms. And you can see the various radiological manifestations that are commonly encountered in clinical practice. When you do something like lung function measurement, you will find out that a significant number of them have spirometric definition of obstructive airway disease, and another 30% fulfilling the criteria of restrictive lung disease. So that is a substantial number of people who suffer with physiologically deranged lung function test. We have conducted a nationwide study of these post-TB patients by doing pre and post bronchodilator spirometry across 27 centers in India. Most of these, or almost all of these, were from private clinics or hospitals. And the inclusion criteria for this study was patients who were diagnosed and treated for pulmonary tuberculosis, declared as cured, but still come to the clinic with presence of respiratory symptoms. In these patients, we performed pre and post bronchodilator spirometry. Quite a substantially large sample size. And when we looked at these spirometry results, only 11% had normal spirometry, 9% had spirometric features suggestive of asthma, 26% had presence of preserved ratio impaired spirometry, which is probably a harbinger for the development of COPD. And then more importantly, 54% showed spirometric evidence of COPD. Now this is quite a substantial prevalence of post-TB COPD that we have observed. We then looked at the radiological manifestations post-TB and then correlated that with the prevalence of COPD. Look at the red line on the top. That is the COPD. And on the x-axis, we have radiological manifestations. So if one zone was affected, we get a score of 1. 2 zones were affected, we get a score of 2, and so on. So it ranges from 0 to 6. Now, whether you have a normal X-ray or whether you have an extensive post-tuberculosis damage X-ray, the prevalence of COPD remains the same. So what it means is, if your patient has come after a TB treatment with a normal chest X-ray, this person could still have presence of COPD. The Platino study from South America also made a very interesting observation. If you look at the prevalence of COPD and ask these patients, did you ever suffer from pulmonary tuberculosis in the past? Then you can see that the odds for COPD among those who had a history of tuberculosis in males was around 4-fold, whereas in females it was around 2.3-fold. That's a substantially increased odds of having COPD among those who had a past history of tuberculosis. We all know that tuberculosis is a risk factor for developing COPD, and COPD is also a risk factor for developing tuberculosis, and it's quite interesting. Now, these patients of post-tuberculosis COPD, is it a different phenotype of COPD, or are they very similar to smoker or non-smoker COPD? So this is a study that we did in India amongst close to 200 post-TB COPD patients. And on the left-hand side, you can see the clinical manifestations, a significantly large number of them present with shortness of breath, followed by cough, and so on. And when we perform spirometry or oscillometry, more than 95% of them show evidence of small airways obstruction. So this post-TB COPD is significantly associated with small airways obstruction. Then we looked at 3 things. If we treat them with inhaled corticosteroids plus LABA, or if we treat them with LABA-LAMA, or if we treat them with triple drug combination, which one of them get better? There are no randomized controlled trials that have been done as of now for us to know which is the best pharmacotherapy for post-TB COPD. But this was an observational study, longitudinal follow-up. If the physician thought it was right for them to start this patient on any of these 3 combinations, they were followed up in a real-world study. Now, to cut the long story short, LABA-LAMA performs as well as triple drug combination in these patients. And you can see the p-values for oscillometry and spirometry, very, very similar for dual bronchodilators versus inhaled corticosteroids plus the dual bronchodilators. The reason why I'm showing this is, at least we have some evidence to show that dual bronchodilator works as well as triple drug therapy in patients with post-TB COPD. Now, we clearly need randomized controlled trials to get a deeper insight into how should we treat them with appropriate pharmacotherapy. The other post-tuberculosis lung disease that is very common is bronchiectasis, post-tuberculosis bronchiectasis. It's a different phenotype than the other bronchiectasis that we see in clinical practice. In fact, in the big study that we did on bronchiectasis prevalence, EMBARK study, the commonest cause of bronchiectasis in India was post-tuberculosis lung disease. About chronic pulmonary aspergillosis, there is emerging data that patients who suffered with pulmonary tuberculosis in the past have an increased odds of having chronic pulmonary aspergillosis. So this is also something that we should keep at the back of our mind. There has been a lot of work on the risk of developing pulmonary hypertension in patients with post-TB. And here is a study that demonstrated a significant prevalence of pulmonary hypertension in post-TB patients, a total of around 16%. Does tuberculosis increase the risk of having cancers? So if you look at this meta-analysis of 17 studies, the risk of all cancers increases by around 62% in those who had tuberculosis in the past. But more interestingly, the risk of lung cancer in post-TB patients is around 3.2-fold greater than those who did not have underlying presence of pulmonary tuberculosis. And this risk seems to be highest in the first year of follow-up. So if you look at the changing pattern of nomenclature of this, you have seen a patient in a clinic with symptoms suggestive of tuberculosis, you have performed a chest X-ray, you've done sputum microbiology, you have made a diagnosis of pulmonary tuberculosis, you have treated this patient appropriately with anti-TB treatment, at the end of which the patient has got cured, and then you're right on the top of the mountain saying, yes, I have done it. Most national programs of tuberculosis actually end once the microbiological cure is achieved. However, a significant number of them, and I believe about 50% of these, continue to come to a clinic with respiratory symptoms. When you perform spirometry, a significant number of them will have tuberculosis-associated COPD, or called TOPD. So this was the primary nomenclature that was given many years ago. However, with the realization that it is just not COPD, TB is associated with bronchiectasis, associated with pulmonary hypertension, associated with interstitial lung disease, associated with pleural diseases, associated with lung cancer. And therefore, the nomenclature that was changed was to post-tuberculosis lung disease, or PTLD. Now, the World Health Organization, just last year, has now rephased this terminology to TB-associated lung disease. And the reason why it is doing it is it has understood the value of these post-tuberculosis lung diseases, and we do not start looking for them after the end of cure. We should start looking for them right at the beginning of the treatment. You do not treat palliative care at the end of the chemotherapy. We should start doing palliative care once you immediately make the diagnosis. So that is the new terminology that is being introduced called TB-associated lung disease. The St. George's Respiratory Questionnaire is perhaps a useful tool that you can use during the course of the TB treatment to estimate who are at greater risk of having post-tuberculosis lung disease, or even at the greater risk of dying. And this is the last slide that I wanted to highlight. There are so many unanswered questions in this field, and perhaps the European Respiratory Society and the Indian Chest Society could come together to find solutions for this. Perhaps a joint ERS-ICS post-tuberculosis lung disease research grant could be thought about. Perhaps international registry could be developed for this with the leadership of ERS and the Indian Chest Society. We could move forward to ensure that post-tuberculosis lung disease is recognized. So perhaps a joint task force between ERS and ICS, and then pulmonary rehabilitation for TB survivors. ERS has got a very solid base of pulmonary rehabilitation, but post-TB pulmonary rehabilitation is something that is neglected, and the ERS and the ICS could work together for this. And finally, advocacy and policy engagement is where both the societies could come together. Thank you very much.
Thank you very much, Sandeep. So this is the only presentation that doesn't have a panel discussion afterwards. So I think it's a shame to let Sandeep escape without just one question. So do we have a question?
Sir, thank you so much for such an enlightening talk and the real world situation we face in India. I was just surprised about the data that was shown about the incidence of cancers and especially lung cancer in the post-tuberculosis patient and especially in the very first year itself. So is it a cancer associated with post-tuberculosis or these were missed cancer patients who were mislabeled as a tuberculosis? So any inputs on that, sir?
Very good question. It could be either susceptible or early cancer made more enhanced by an underlying tuberculosis infection, or it could be TB associated. TB increases the risk of developing lung cancer. We will not know the answer for that, but you're absolutely right. It could be either of them. The fact that 17 studies have shown that the risk is very high, I think we should keep our eyes open for this possibility in our patients.
Thank you, sir.
Please.
Sir, I am from government. Underlying structural abnormality. Cavity is there, bronchitis is there, so I have started the practice of giving. After the anti-tuberculosis treatment is started to prevent such underlying structural lung disease. So such policy can be implemented or not?
Absolutely. I think we need to advocate with the government that the TB national program doesn't end with TB cure. There should be a program after the tuberculosis is cured. There should be regular screening for all these various conditions that I've shown. Even us, those of you all who are practicing in private clinics, you must also look for specifically this, because this is being greatly neglected in our clinical practice.
Yeah. Thank you. I'm sorry. I said one question. We allowed two. We must let Sandeep go because we need to move to the next session. Thank you.
With that amazing session coming to an end, we have a very special, one of its kind session that's lined up for the next. It's called JAMA session, Just Ask Me Anything, and it's an open forum, so all of you are encouraged to come up to the mics that's been put all around the place and ask the question that you would like to ask, because this is the chance of a lifetime of opportunity to ask the questions to the faculty of ERS and ICS. So for this session, which is a JAMA open forum with a panel of ERS and ICS, I would like to call upon stage the subject experts. Professor Johanna, if I am pronouncing that correctly. Professor Johanna is the Professor of Medicine and Consultant in Respiratory Medicine Head at the Department of Genetics and Clinical Immunology at National Institute of TB and Lung Disease at Poland. She's also the Secretary of European Respiratory Society. Along with that, co-chairing will be Dr. Arun Madan, Professor and Head Department of Pulmonary Medicine, NDMC Medical College, New Delhi. Over to you, sir.
I'd like to invite Professor Radha Munje. She is Professor and Head of the Department at IGM ICH at Nagpur. Dr. Radha Munje, please. Professor Radha Munje, please. I'd like to invite Professor James D. Chalmers from UK, Professor Omar Usmani, again from London, Professor Anant Mohan, HOD Department of Pulmonary Medicine, AIMS, Dr. Parul Vadgama from Surat, my dear friend Dr. Rakesh Chawla from President ICS from Jaipur Hospital, and Dr. Saurabh Mittal from AIMS, New Delhi.
Shall I start? Honorable
timer will start when I tell you to do that. Right. No, I'll take 2 minutes for. No, that's what I said, that I'll take. This is a very interesting and very thoughtful session which has been kept for the first time in ICS ERS. It was not there in the first version. It was there at Hyderabad. So the question is, what is the distance between Delhi, we are in the capital of India, and London or any other European country is the question. And I want all those who are sitting in the last 4 rows to answer that. It can be miles, kilometers, hours, the dollars or the money you need to spend. Any answers? We have to start the session, so be quick and be interactive. Could you hear? Huh? 3,000? 7,000? Oh, that's a Google answer. Yes, 7,500 kilometers, at least 6 hours of flight, at least 25,000 rupees converted to the appropriate dollars or euros. But that distance has been shortened by the attempts of ICS ERS collaboration, and we have had wonderful faculties since yesterday delivering the best on the topics which are needed. So I'll ask all the youngsters who are sitting at the back, please come forward. You are an important part of this session. Please come forward and make this session a lively and useful one. So there will be question and answers for the panelists, but it's an open forum, so even the audience can put in questions and can even prompt the answers also. There is a disclaimer that few questions the audience may feel, but they are not gender biased, age biased, or post biased. They are solely based on the experience and input of the panelists that we have with us. I have no conflict of interest, and the only rule is mobile is on silent, but please all of you come out and speak and make an interactive session. So I think the first question should ideally go to the president with us, that is who is Dr. Chawla. We all know Dr. Chawla has been doing a great work in IP. Sir, all new pulmonologists are very smitten with IP, that is interventional pulmonologist. So what would be your advice to them on pros and cons? Because they feel being an IP is staying on cloud 9.
Thank you, Munje ma'am. I will definitely invite any of the youngsters who is practicing IP. I will like to interact with him. Anyone, please get up. Ravneet, come forward on the mic.
So we define youngsters not by age,
Ravneet,
but by years in the practice.
I want to listen to him and then I will also answer. No, with him, let him also participate.
Yes.
Yes, Ravneet, why did you?
Yeah,
you please introduce yourself.
I think you can hear me loud.
Yeah, you introduce yourself and then tell us why did you choose IP?
Yeah, I'm Dr. Ravneet Grover. I'm from Amritsar, from All Town in Punjab, and I came to Delhi through my postgraduate examination, and got this opportunity to learn, get a glimpse of interventional pulmonology from mentors like Dr. Rajiv Goyal and Dr. Rakesh Chawla himself. Now, what first training that we got from the mentors was, if you want to be a good interventional pulmonologist, first be a good critical care specialist. So I was pushed into the critical care, and there in Jaipur Gulden we had a combined interventional pulmonology and a respiratory critical unit, because once we are doing interventional pulmonology, you cannot wait to have an intensivist where you are into a trouble. So the first lesson what I learned was, be a good intensivist. Before you become an interventional pulmonologist, you have to be team in yourself so that you can manage any complication at that time. And before you become a good interventional pulmonologist, be a good chest physician. You can do the procedures, but you cannot interpret the results. You are not a good interventional pulmonologist. And third lesson that I learned was, you should know what to do, but better you should know where not to do. Thank you. These are 3 lessons I learned in my journey from a pulmonologist to an interventional pulmonologist.
Thank you, Ravneet. Well said. We know the actual practice of pulmonology is 80% respiratory medicine, which is of tuberculosis, COPD, ILD, asthma. 20% is where the adrenaline is secreted, is an IP. I will divide it into not only an IP, it's a basic bronchoscopy, which is diagnostic and therapeutic. Then comes the EBUS, both, which is an advanced therapeutics. Then comes the interventions. So that is 10%, and these 10% comes to the diagnostics, and 10% is a therapeutic, where you have advanced techniques like cryo, cautery, APC, doing ablation, central airway tumors, tracheal stentings, which is an advanced work. So, learning IP, you need not be afraid, but you should have a patience to learn it gradually from basic bronchoscopy to therapeutic to advanced bronchoscopy. So there is a learning curve. Just doing one case, having a good positive result does not make you an interventional pulmonologist, because these days the social media, that is what Didi wanted to highlight. They are on cloud 9, taking out the blood clots with the cryo probe, describing it, taking photo and send it around the world on a WhatsApp. I have done this is. So you should have a patience, you should have a learning curve, and you have to have an humility. You must have a setup where you are able to deal with the complications. Believe it, what happens inside the therapeutic bronchoscopy room, kabhi na kabhi, kisi na kisi ke saath, it happens. And when that adrenaline gets secreted, and after that you have to face the patient's relatives, you should not keep quiet. It hurts them. Tell them the truth, what has happened inside. And if you are able to salvage, and patient went in for a tracheal stenting, you did cautery, you wanted and crafting. Over-crafting is prohibited. You must stop where to stop. Because having an gadgets, having an instrument doesn't mean that you can do it, you must do it. Come out if you faced a complication. Tell the truth to the family in one go, rather than keeping quiet. Family immediately will perceive what you are talking is correct or no. This is all God-given connections to everybody. So be straight, accept, go back home, don't get disturbed, do the auditing of yourself, where things have gone, where you were not prepared, what was required, and come back again with the same zeal. Right? I tell the youngsters, गिरते हैं घुड़सवार ही मैदान जंग में, वो तिफल क्या गिरे घुटनों के बल चले. Right? करना है, सीखना है, चढ़ना है, और गिरना है तो सीखना है. Thank you.
Well said, Dr. Chawla. And my next question goes to Dr. Anant Mohan. There are two questions in this one question, but I would like you to be very crisp about it. One is, you have come from a renowned institute which does not have a pulmonology department, and you are working at an Apex Institute which has a state of art. So what can we do to have uniformity of care in pulmonology all over the country? That is one question. And secondly, we get students pan-India in all government institutes, as well as other private institutes also. So how do you ensure uniformity and everybody gets same opportunity and bring to a standard when they leave the institute?
Okay, ma'am, thank you again bringing out important questions about, firstly, about uniformity of respiratory medicine across the country. So I think it is quite skewed as of now, and we all know that there are some centers which have everything. There are some centers which have the basic things, and then there are several centers who probably don't have even the basics. So there is no one-stop or immediate solution to these problems, but I can say at least from the place where I graduated, it has only an internal medicine department. So, I took whatever I could from there. Now, how to give it back, I just try to talk to my colleagues over there and say, okay, look, at least one or two people have to develop an interest to initiate, to take the first step in developing a new division or a new department of pulmonary medicine, even within the ambit of internal medicine. So one or two people have to be there, and then it is our duty to provide them whatever support in the form of training, or I've been talking to them that come over to our place, spend a few weeks, see the things, get trained and do it, and go and start it back. So infrastructure, training, education, all these things we can offer. So similarly, all other people here who are in respiratory, centers now, if you can try and mentor somebody, your parent college if it doesn't have such a setup. So that is one way to go about
And
it.
the answer to the second question of uniformity at postgraduate level?
So there, of course, yes, we have a pan-India, fellows come from all across, different background, different colleges.
Yes.
Again, like you said, some of them don't even have the basics, but they come through the exam, the entrance exam by sheer hard work and, their
Great.
skill. Yeah. So our job is to ensure that all of them get equal level of training. It's tough, everybody is not initially at the same level, but then we have to make sure that we give them equal opportunities through classes, through their own presentations, through exposure, proper postings, same kind of postings to everybody, make sure everybody gets the same kind of attention. Some people may need more attention, in these things. So I think that is how it works over a period of 3 years to make sure. Some of them have language problems.
Yes.
So all that has to
All
be
in all,
factored.
apart from the clinical care and the teachings, you have to be a mentor and sometimes a
Correct.
friend to all these people. Wonderful. So, Doctor, yes, somebody from the audience? Yes.
So my question is to Professor Chalmers. So, I mean, it's for someone who's just starting the early career after the post-graduation and coming to the respiratory field. How do we drive ourselves towards the research that's going on? I mean, as in our country, the respiratory research per se is not something that's incentivized. So how do you, with the vast amount of knowledge in research that you have, how do you motivate yourself every day to go for research and maybe doing something for the science per se, not just the clinical part?
So the motivation, see, this is an internal drive, right? You see something new, like yesterday evening episode, I tell you. We are all fighting here for streptokinase, for empyema, grade 2A, grade 1. And after that, there is a fight, we do thoracoscopy or no. The whole consensus is that we all use streptokinase, right? But MIST 1, MIST 2 trials have made it obsolete. So we involved Dr. Badawi. Everybody was saying, कुछ करना चाहिए हिंदुस्तान की तरफ से. That सब लोग स्ट्रेप्टोकाइनेज यूज कर रहे हैं, ठीक है कि नहीं है? अगर ठीक है हिंदुस्तान का डाटा तो वेस्ट विल चेंज, और वेस्ट का डाटा ठीक है तो हिंदुस्तान विल चेंज. We are all talking the same. So yesterday night sitting, we decided to have an RCT. So this is a drive. This is what ERS is here to teach us, to drive in us that we have lot of data, but we don't record it. We don't publish it. We don't discuss it.
That's very correct, Dr.
So we
Chawla.
have done yesterday night a group. We are going to do the multicentric trial. So all of you who are interested can address me your name. I will add you. We will send you the protocol. Professor Badawi is going to be with us as a driving force. We will have a generated data on STK, whether we are correct and they should rethink, or we have, it is as good as normal saline, and we accept and then practice what they are teaching us, right? This is how the drive comes. You should have an enthusiasm that you want to learn new things. Age is no limit to learn, right? You see Amitabh Bachchan, 88 years. Kaun banega crorepati? Right?
Dr.
If you
Chawla?
see, he is running.
Dr. Chawla, let me ask something more. Actually, that was the question I was going to ask to James, but I'll ask the tip of the question, which is very important, is ERS is Mecca for pulmonologists. What is your advice for do's and don'ts during the ERS when many of our colleagues come there? And any tips for abstracts, any tips to become a guest speaker there? Because there is such a great audience, people would love to take tips from you. It's not a gate pass, but at least it's for you. It's for you. Yes, Soumya Gandhi.
Asked about research and it's linked to getting involved in the ERS Congress. The first 5 years, it's really hard to find time for research, of course. First 5 years of my career, I had no time for research at all. I just collected data on what I was seeing every day in my daily clinical practice. I guarantee you, whatever you're doing, whether it's pleural disease, whether it's pneumonia, whether it's general pulmonology, emergency department, there will be unanswered questions that you see every day, and you can gather some data in a spreadsheet about that. And you can write an abstract, and you can go to the ERS, and you can meet then people who are also interested in the same areas that you are, and develop collaborations. That's how I started research doing pneumonia, and I went to the ERS Congress in 2006 and met a small group of people who were interested in infections, and that's how we got into bronchiectasis and answering very basic questions about how should we investigate these people, and what does the disease look like in Europe. So get involved, even in very, very simple ways, collecting data in your routine clinical practice, because research is awesome, and you should all want to do it, because it is what drives improvements in our daily clinical practice.
Yes.
And then to your question about how to get involved in the Congress, is submit an abstract. It doesn't have to be rocket science. Come to the Congress and then network with people. And don't be afraid to contact people like me or Ehab or Omar and say, how can I get involved in the CRC that's on the topic that I care about? How can I get involved in the meetings that are happening parallel to this about the topic that I'm interested in? That's how you make connections, and that's how you get the most out of the amazing opportunities that ERS offers.
Thanks for the tips, James.
May I just add to
Just a minute. I'll take one question because we are short of time, and I'll allow the audience to chip in.
May I just add?
Just a
minute. Here. To what James said. Plus, there is early career members assembly. So you are most welcome to join the other young researchers. And I think this is another, on the top of what James mentioned, another wonderful opportunity for you to network with young researchers, young clinicians from all around the world.
Bhumika, just 1 minute. We have Dr. Parul with us, who is a professor. She is not only in teaching and research, but she is also active in IMA. And above that, she has a lot of community work which she has been doing, which nobody knows. So I have a question for you, Parul, which I think most of the people have in their mind is, that was it really hard for you, not because you are a woman, but you are already working. So to overcome the bias at workplace, at home, the expectations that you have, and still you step out into the community, you have built a life about which you are proud of and we are proud of. So answer that question, how did you overcome? And second is very important, I thought of it at the last moment. If our Parul becomes a health minister, I would like our audience to put down their expectations. And Parul, what would you do for the fraternity?
Thanks, madam. See, I would like to answer the second question first, because to me, the chest medicine is passion. If I am given an opportunity, as we all know, we are trying hard to bring our department at a UG level, at a NMC level. First and foremost, that on day one, I will reintroduce my respiratory medicine department at a UG level for teaching. Because we know in India, 40% of the OPDs is a chest OPD. How can we imagine a UG level student not taught respiratory medicine? So first and foremost, on day one, I would just reintroduce my department. Second thing which I would like to sanction, whatever we have discussed since yesterday, oscillometry, we need FeNO, we need bronchoscopy, we need IBUS for advanced and molecular diagnosis. I'm listening too much of molecular level diagnosis. So I would really like to equip all our medical colleges, because I am a professor, and in the medical colleges we give birth to the leading chest physicians of the country. So I would really like to equip all these medical colleges with necessary infrastructure and the molecular level diagnosis, so that we can have more and more evidence-based practice. And moreover, madam, I would really like the department to have, as we have discussed, that research is sometimes a constraint for us. So we should have clinical heads, we should have administrative heads and research heads in the department, so that all work is simultaneously run. A single professor or single head cannot handle clinical practice, administrative practice, and all mesh up and not ending into the, a dreamed result, which is necessity of the day. So I would, make 3 heads in every medical colleges so
Wonderful.
that we get
That
a
should-
good
there should be a
research,
clap.
result-oriented research, which we are lacking many a times.
Yes. And in many states, medical education is termed as medical education and research, whereas the research is always the last thing and is always lacking.
If our students, are taught research at a PG level in a nice way, or I would say in a, with a lot of time and a different head, they will have that type of inclination in the private practice also.
Yes.
It's matter of teaching also and imbibing those research aptitude from the UG and PG level, so that in practice also they don't forget research.
Bhumika, it would be nice if you address your question to Dr. Saurabh or Dr. Usman, so that...
My question is for Dr. James.
Okay. Okay, your choice.
Thank you, sir, for your excellent talk yesterday. It gave boost to treat the patient of bronchiectasis more with the macrolides. And my my curiosity is to know your experience in the development of vaccine against Pseudomonas, especially our bronchiectasis patient.
Vaccine against Pseudomonas.
So vaccine against Pseudomonas. Very interesting question. So there's been attempts to develop vaccination against Pseudomonas in the CF field probably 20 years ago. Unfortunately, all of them have failed. The likelihood is that the targets are wrong, but also that trying to get antibody into biofilm-associated bugs is quite challenging. There are some new programs that are coming through with some of the major pharmaceutical companies that are starting to get interested into this. I showed you an example yesterday of passive vaccination, monoclonal antibody, that is effective. So my hypothesis is that there is a way to make this work. You probably need bispecifics and you probably need novel ways of delivering it. But I think vaccination, having been completely off the table for 20 years, may be coming back.
So we have a question for Dr. Saurabh.
Can I ask a simple question to the audience?
Shall I complete
Yes.
this question?
Yes.
And we
Kindly
have-
do it, yes.
I'll ask Saurabh to be
Simple
quick.
question.
So, Dr. Saurabh, just tell me, when did you think that this specialty is yahi hai right choice baby for you? And the lane that felt right without feeling boxed in? And what made you confident that this path you have chosen is the right one to go ahead? Because in our country, we rarely have a chance to change whatever you have chosen.
I'll tell you what I thought of respiratory medicine when I was in undergraduate. So I did my MBBS from KGMC. So we had Dr. Rajendra Prasad who used to teach us. And the only thing I was feeling bad about respiratory medicine was the foul spelling empyema words. So that was a thing which was kind of against it. But obviously I was always into internal medicine. So I joined internal medicine in AIIMS. And then when I was in AIIMS for medicine, so in AIIMS we used to have a lot of exposure to pulmonology as a primary specialty. I mean, we used to see cardiology, neurology, everything. And we had Dr. Guleria, Dr. Khilani, Dr. Mohan, who were actually our mentors during our medicine training. So that's what kind of, and if you ask me why did I become a pulmonologist, so I think 2 people, Dr. Guleria and Dr. Khilani, who were actually the mentors and who brought me that I used to feel that I have to become like them. The kind of knowledge, passion for teaching, passion for research and patient empathy they had and they have has what actually brought me to the field. And when I joined, I had a lot of questions from my colleagues that you are a topper, why are you going into pulmonology? So in our country, 20 years back, pulmonology was considered a lower branch as compared to cardiology, neurology. But
so you should have said that
Yes.
I'm going to the lungs because I want to protect the heart.
So I kind of took this decision that I want to be a pulmonologist, and I still feel that I'm proud of what I did, and I think I have done what I wanted to do.
Wonderful,
Thank you.
wonderful. That was wonderful. And we have one question for Dr. Usman.
Both the names he has taken, both mentors on his back, we are proud of Saurabh.
Yes.
We are proud of
And even we are proud of Dr. Saurabh. Dr. Osmani, the question is for you. This is the second time that you have come for, this is the second summit we are having, and you were there last time and this time also.
Can I
what
ask
do you
a
take?
question?
Sorry.
Waiting. I compliment Dr. Chawla for organizing a wonderful conference. I'm with Apollo Hospitals India. I represent them. And my question, simple question to the audience, role of biologics. in Europe, United States, and Asia. What is your opinion, Professor Osmani and ERS team?
So Dr. Usmani, if you can answer that question, role of biologics in Europe as compared to what we are doing in India, right?
Because they don't work very well with us. They don't work very well with us.
They don't work very well.
For some reason.
No, that's a very interesting observation because I think we need to be cautious.
Can you just hold on?
We need to be cautious about biologics. We need to be cautious about biologics in COPD, as Professor Rogliani was speaking yesterday. And biologics in asthma, we know only 40% achieve remission, so 60% do not. So we need to really understand that. The role of azithromycin achieves 40% remission. So although we have many biologics, and of course they are developed by the pharmaceutical industry, we need to be very careful in their use in our patients. It's not a panacea for sure. So the fact that they're not working in India interests me greatly, actually, because actually they may not be working in our patients in Europe as well, and we assume they are, and they're being prescribed them a little bit too quickly. I know there are differences between the eosinophil population, the microbiome, the environment that may be modulating the eosinophil. We had a talk at the ERS last year on the environment and the milieu affecting the role of the eosinophil in patients with COPD. So I would really report that data if you have it.
And I had a question for you. So you bring in a lot of inputs, you give us a lot of thoughts, lot of things we learn from you. But what do you take back when you go from here, from such summits?
So the whole ERS was saying it's a bi-directional approach.
Yes.
We come here and we learn a lot. We learn a lot from post-TB lung. We learn a lot from how oscillometry is going. We learn a lot from your experiences in bronchiectasis, in biologics, as you just mentioned, in the variety of fields. The one thing that I would say in the last minute is please give ideas now to Dr. Amita and to Dr. Rakesh in terms of the planning for your next Congress, because this will really help in the planning of the next Congress to your president here, because they will look forward to the ideas, because this is here to serve you, the audience, and your participation.
Yeah. And we are just short of time. Parul, just a small question for you. How do you manage or how do you protect your life outside the work with the health, relationships, families, without having any guilt in your mind?
Very, very practical question. We all are practitioners, and we have always, challenge for work-life balance, and of course, a professional social balance. But at the end of the day, I would say at the morning of the day, we have to be quite decided. See what we want to do today, what we want to do tomorrow, and a well-planned, with a very good clarity of thought, that madam, I want to do this today, this tomorrow, and day after tomorrow. If you have that clarity, with I would not say it has to be always equal balance. You cannot give justice to all the things simultaneously. So at every moment, you have to prioritize. Yes, this is a priority for me today. This is a priority for me tomorrow. And according to the priority, you should give 100% to that thing, whatever you are doing today. And after that, you will not have any guilt. Rather, it will give you more result. And I have observed that a dedication, whether you are in a social, area, or in some relation-making process, PRO-ship, or would you say building the practice with developing connections to all the general practitioners, you should prioritize whatever is needed whenever, so that you don't have that guilt. So whatever we are doing today should be best, with all the dedication, with all the, you should put your heart into that. And of course, every day should be meticulously planned, I think with moments, and it has to be explained to your family and your social group that what you wish and what they expect from you. So I think a good communication with your family and good communication with your society is important, so that they accept you that way,
Wonderful,
the way you are
Dr.
doing.
Parul.
Thank you.
And our time is up, but before we end, does our moderator want to add a line? Dr. Madan and Joanna?
Just as a conclusion, I think that was a wonderful discussion that actually addressed the very pertinent questions, not only regarding the professional and scientific development, but as you very correctly emphasized, there needs to be a balance between professional and family or private life. And having this balance actually affects both our professional achievements, but also our more private part of the life. So congratulations to all that actually try to keep this balance, because it's quite difficult.
Thank you, Joanna.
Ma'am, do
Dr.
I have
Madan?
a permission for a comment?
Yes.
Somebody just asked me yesterday why the gold prices are rising worldwide, and told them because the gold guidelines have included all the respiratory medicine into their basket.
Wonderful.
So I don't think personally, I don't feel it's the right strategy, because that way, that is not allowing us to individualize the treatment. Now it is COPD A, B, C, D, and now in the short time it may be up to the Z. So once we are including everything under the COPD basket, COPD means that we have to put more emphasis on the LABA and put the steroids at the back seat. But
I think you should be talking to Dr. Sandeep over lunch for the answer to this.
My question is to the ERS and the ICS that is sitting together on the panel.
He's the man there who knows about gold angina.
So I feel it is better
And
that we
our
should be
time is
individualizing the
up.
treatment. That's my just a comment that if everything is included in the COPD, that's not the very right approach. Up to the panelists to comment upon that. Yeah, that's manageable. I have my daughter to
सर
get married.
गोल्ड वो खदान से निकले या गोल्ड गाइडलाइन से आए उसकी कीमत कम करना चाहता है वो बट वी आर शॉर्ट ऑफ टाइम एंड टाइम इज मनी सो वी कांट कॉम्प्रोमाइज ऑन दैट मदान सर आपको कुछ बोलना है
Just one line regarding IP. Just don't do a procedure because you know it. Because you know a procedure, please don't do it on the patient. Put all your scientific mind, DD, science and art of doing the things and handling the complications.
Thank you so much and thank you my dear panelists for answering those questions. Thank you. Soumyakanti, the stage is yours.
With one of its kind JAMA session coming to an end, we move into one of the other special sessions that we have programmed for the meeting. This is a kind of session that all of us would hear at the ERS Congress. Professor James, like this time in Amsterdam, he was talking on best of ERS and the best papers. Something in the same lines, this time we have 5 best papers from ERS and 5 best papers from Lung India being discussed. And after that, we have a panel discussion on how you should use these papers in your daily practice. So one of the very well-designed sessions. I would like to call on stage for the best in chest hot of the press session, the subject expert, Dr. M.K. Gupta. Dr. M.K. Gupta is the Managing Director and Chief Consultant, Anch Hospital, Jaipur. Sir, the stage is all yours. So Dr. Gupta had to leave due to some unavoidable circumstances. It will be taken over by none other than our favorite, Dr. Amita Nene, ma'am.
We always save the best for the last, and now we have the best session of our entire summit. And I'm just so happy and proud to let you all know that we are going to talk about the best papers that were in ERJ and also in our own Lung India. So let's start with our guest of honor, none other than Dr. James Chalmers, welcoming you to be on board and tell us about the 5 best papers in ERJ. Dr. Christopher first? Okay. I'm so sorry. Okay, I'm sorry. Okay. So we have our Dr. DJ Christopher, our pride, our favorite, and absolutely the best person to do full justice to the best 5 papers of Lung India.
Thank you, Amita. I'm delighted to be here, and I thank the leadership of both the ICS and the ERS for asking me to participate in this. So I have put together my 5 best Lung India papers. The first one is on interventional pulmonology. So this is an RCT to compare high-flow nasal cannula with standard nasal cannula to prevent desaturation in subjects undergoing EBUS TVNA. This was published from PGI Chandigarh, led by Inderpal Singh. So hypoxemia is common during bronchoscopy under conscious sedation, and the conventional nasal cannula, which is more frequently used, has variations in the FiO2 delivered. HFNC delivers humidified high flow oxygen, and therefore the objective is to compare HFNC with conventional nasal cannula. And the primary outcome was the events of SpO2 less than 90 for more than or equal to 30 seconds. This was an open label randomized control trial of adults at and above 18, sample size of 300, 150 each in each of these arms. Nasal cannula was delivered oxygen from 1 to 10 liters, depending on the oxygen saturation, and HFNC 30 to 60 liters heated, humidified oxygen with adjustable FiO2. And the analysis was on intention to treat basis. The desaturation events were significantly higher in nasal cannula, 42% versus 20% in HFNC. The p-value was highly significant, favoring HFNC. The absolute risk reduction was 23%, and with HFNC, there were higher nadir SpO2, fewer desaturation events, improved patient comforts, and operator satisfaction. Complication rates were similar with both the arms. Interpretation: HFNC significantly reduces hypoxemia and procedural tolerance. The number needed to treat for benefit was 4. Although there's a higher upfront cost, the potential benefit would be good for high volume centers to use this modality. This is, however, a single center study, and no ETCO2 monitoring was done. And so as a way of recommendation, it would not be universal and not be for low risk patients, but for moderate and high risk patients, HFNC could be considered. The group also did a meta-analysis, and this is a forest plot showing that almost all the studies favor HFNC, with the odds, the combined odds being about 5. And so this is what others have experienced too. My second paper is on lung cancer. This is on the clinical spectrum of lung cancer across hospitals under the National Cancer Registry Program in India. So lung cancer is a very important problem in India. Variation in diagnosis and management are extensive within India, and therefore there was a need for large nationwide registry-based analysis. This is what was done using 2 registries from 96 centers, amounting to a total of 45,228 lung cancer patients between 2012 and 2019. The male to female ratio was 3:1, and the group looked at demographics, histology, stage, treatment, and delays. So the age of diagnosis was 50 to 74 in males, 45 to 69 in females, slightly younger. Adenocarcinoma was the most common histology, 39.7, which was 50% higher than squamous cell carcinoma, and 50.7% presented with distal metastasis. You see here on this diagram that males had 14.2% localized disease as against 15.3 in females, loco-regional 34.5 versus 29.1, with distal metastasis 49.2 compared to 59.5 in females, suggesting perhaps that women came later than men for diagnosis. Late diagnosis remains a major challenge. Delays of referrals occurred at every level, but even from diagnosis to reporting to treatment was 7 to 30 days. The treatment options were limited. Chemotherapy alone was the most common treatment modality, irrespective of the stage. The second most common being chemo and RT. Low surgical rates in early disease, and therefore the group concluded that there's need for improved referral and defined diagnostic pathways. The third is on tuberculosis. This is a review article. It looked at newer research transforming treatment from 24 long months to 6 months for MDR and XDR tuberculosis. Dr. Nitin Jain and team. So we all know how important tuberculosis is to India, with 10.6 million cases and 1.3 million deaths globally, and India accounting for 27 to 29% of these. There are approximately 410,000 MDR and rifampicin-resistant TB cases annually. The traditional prolonged treatment was for duration of 18 to 24 months, and that included injectables and therefore was toxic. There was poor adherence and treatment completion. However, a 6-month treatment would be extremely desirable. So this article actually looks at the journey from long duration treatments with injectable regimes in the early 2000s and a radical change after the Bangladesh study that occurred from 97 to 2007, Van Duyn et al., which showed efficacy of treatment duration of 9 to 11 months, and WHO took note of this and shortened the duration of treatment. Subsequent to that, there was introduction of bedaquiline, delaminid, and pretomanid between 2012 and 2019. And in 2020, the much celebrated BPAL-M regime was recommended by WHO, and in 2024, it was introduced in the program in India. So all that you need to take home is that we have, thankfully, a dramatic reduction in treatment duration and more acceptable treatment that's available today. So the next is on asthma. This is a study done by Dr. Sheetu Singh and team titled Risk Factors for Asthma Across India, results from Global Asthma Network, Phase 1 study. So this is a multi-center Indian data from 9 centers. The data collection occurred in 2017-2018. So that there was data on children, adolescents, and adults. The rationale for this is that there's asthma prevalence that is variable in the various Indian populations, and there are environmental, genetic, and cultural factors that again are diverse and different. And so they wanted to look at India-specific triggers. So there were a total of 20,084 children, 25,887 adults, and 81,296, adolescents and 81,296 adults analyzed. And the risk factors were analyzed with multivariate logistic regression. The prevalence of wheeze in children was 3.16, and the prevalence of severe asthma was around 1. However, there was a huge variation, with Chandigarh with 8.54 being the top. And in adolescents, likewise, the prevalence of wheeze was 3.64 and severe asthma 1.38. But again, Jaipur had 6.62 was the highest, followed by Kolkata 6.44. And in adults, 3.3 and 1.16. So this figure seems to be quite comparable in all age groups. But there's a lot of variation, with Jaipur being the highest, 5.84, and Kolkata again being the second highest. They looked at various environmental factors in different age groups. In the 13 to 14 age group, hospitalization in the last 12 months was the most important factor, followed by parental history of asthma, followed by allergic rhinoconjunctivitis. In the same group, severe asthma, the most important factor was hospitalization in the last 12 months. So children hospitalized had a higher risk of subsequent hospitalizations and severe asthma. And parental history of asthma, 2.69, followed by allergic rhinoconjunctivitis. So public health implications: importance of improving indoor air quality, promotion of clean cooking fuels, need for awareness of modifiable risk factors, and support for targeted regional asthma control policies, since India is a diverse country and the prevalence as well as the factors affecting are different. The next one is on COPD, titled Smartphone Delivered Social Media Based Rehabilitation for People with COPD in the Thar Desert, India. It's a feasibility study by Shrikant Dikshit and team. So they looked at, with the background that rehab is an important component of COPD care, they looked at access to rehabilitation, understanding that access to rehabilitation is difficult in remote regions. They worked on a smartphone-based tele-rehabilitation. This is a single-arm feasibility study of 45 individuals. They were given exercise videos delivered via smartphone and social media, and they were assessed with CAT, MMRC, and quality of life with EQ 5D 3L, 6-minute walk distance, and usability scores. So all the scores was significantly higher in those that had tele-rehab. And the acceptability also was high. SUS scores and TAM scores were higher for this group. And the 75% adherence was in 8 weeks. There was a 75% adherence in 8 weeks, and 58% continued after 1 year. Very impressive and almost difficult to believe. Anyway, smartphone tele-rehab is a feasible option for the rural community, and there may be good acceptance even in low literacy settings, and it is a potentially scalable tool. The next one is on vaccines. This is a study that looked at distribution of vaccine-preventable respiratory viral infections in 2023, done from a tertiary care center in the state of Kerala, in a tertiary care center. They used high-tech tools, Expert Express, then BioFire, and so on. They looked at this, you may all recall, was a time when the COVID pandemic was still raging, and we had the last of the spikes with the Omicron variant. So the spike you see here is the Omicron variant. And then the Omicron had a second spike later in the year, somewhere in November, December. And the influenza A is this, and you can see that there's a spike in June, and then there is a subsequent spike in November, December. Influenza B, you see there's a spike in December, this one. And RSV, September to November, so this one here. So the take-home message really is that the timing of vaccine. So this group concludes that perhaps April, May be the optimal time for vaccination in order to prevent influenza. We do not yet have RSV vaccines. And so influenza vaccine perhaps is best given in this time, in this part of the country. This will definitely be different in different areas, but this is a message they wanted to give from their point of view. So I want to save some time, and so thank you very much.
Thank you very much, Dr. DJ. This was a fantastic presentation, and you've taken super papers. And I'm sure I hope you're there for the panel discussion to discuss. Thank you so much. Over to you, Dr. James. Looking forward to listening to you.
Thank you very much, and thank you all for staying until the end, hopefully to give you some stimulating papers from the European Respiratory Journal. Delighted to be able to present 5 really interesting topics and quite diverse topics from our journal. These are my disclosures. Before I jump into the papers, I thought it would be nice just to give you a quick reminder of what the ERJ is and why I think it's such an important contribution to our field. It's the flagship journal of the European Respiratory Society. We have other journals, the European Respiratory Review, ERJ Open Research, Breathe, and also the monographs. And so there's a large amount of publishing and contribution to the literature from the ERS. We publish 12 issues a year. It's a hybrid journal, so it's subscription and open online, open access content. But if you're an ERS member, everything that's on our website is free for you to read and download. And importantly, we don't select based on what's going to get the most citations or what's going to attract the most in terms of reprint income, etc. We publish everything because we want to serve the society, which means we publish clinical research, translational research, and even basic laboratory research. I've been privileged to be part of the leadership of the ERJ now for more than 8 years. Initially with Martin Kolb, and now I share with my deputy chief editor, which is Don Sin. And we're a very high impact journal. There's lots of ways of measuring the contribution of a journal. We're very focused on how many people actually read what we produce, and downloads are huge at the ERJ, and India is one of the top countries in the world that downloads our content. But the impact factor does seem to matter to people in terms of selecting the journal that they're going to submit to, and therefore we're very proud that the ERJ is currently ranked number 2 in the respiratory field. It has an impact factor of 21.2. It's actually, outside of the pandemic, the highest impact factor the journal's ever had. And if you look at the progress of the journal since 2011, there's this, apart from these 2 years where we had the COVID inflation effect related to impact factor, a progressive rise over the years in the impact factor of the ERJ. So reflecting, I think, the increasing strength of the journal in respiratory science. I've chosen 5 topics to cover. I could easily have chosen 5 guidelines, because consistently the thing that is downloaded the most from our website is the guidelines. The ERS is very proud of our guidelines. They make a big impact on clinical practice. I've highlighted just here 4 that have been published in the last few months. Almost every second month in the journal there will be a new guideline or statement from the ERS. So and these are all free, even if you're not a member of the ERS, because we want the broadest possible impact. So go and download these and use them in your day-to-day clinical practice. But on to some original research from the journal. I've picked 5 topics that have been published in the journal in the last 1 year to go through some of these things. So my questions are, can we achieve remission with biologics? We heard Omar allude to that a little bit in the previous session. If we do achieve remission, can you titrate biologics in order to save costs or to get some patients off those biologics? Long COVID, which hasn't had much play in this conference, is still a significant problem for some people. Is rehabilitation effective for long COVID? How safe are long-term macrolide? And then a final comment on e-cigarettes. So let's talk about asthma remission as the first thing. So Omar said in the last session that 40% of people achieve remission with biologics, and there was a comment about perhaps not being as effective in India. This is an important study from a very well-curated database in Denmark, a really good group. They took a cohort of over 400 patients with asthma, 482 patients, started on anti-IL-5 therapy, and they looked at 1 year and then for 5-year follow-up, how many patients achieved remission. And remission was defined, and of course the definition of remission is very controversial because different people use different definitions. They used good lung function, no exacerbations, no use of ICS, and a reduction, a low level of asthma symptoms as the definition of remission. And what did the study actually show? Well, it showed that Omar was correct. Omar said 40%. In the first year, 37% of patients achieve remission. But it also showed that that's not the end of the story, because if you followed those patients up long term, asthma is a relapsing, remitting condition. Over the course of that 5-year period, only 7% actually achieved sustained remission, meaning some patients had a good first year, but then they started exacerbating again, or their symptoms worsened, or they had an up and down course. So the conclusion of this study is, let's not get too carried away with remission in asthma. Biologics are very beneficial, they're very good, but they rarely lead to sustained long-term remission, and we do need to look over the long term for what is a chronic disease. Nevertheless, asthma biologics are clearly very effective. Patients feel better on these drugs. And so the question I get in my clinic is, do I have to stay on this forever? That's a really important question for patients. And that was addressed in this very nice pilot randomized controlled trial called the Optimal study. So they took patients who were stable on anti-IL-5 biologics, any of those three, defined complete clinical response, meaning the patients had done really well, and then they randomized patients to either continue on their normal dose and interval of anti-IL-5 biologic, or to go into the optimal titration regimen, and I'll go through that regimen now. So patients were assessed, and then they got a 50% increase in the interval between their injections. What does that mean? If you're getting a 6-weekly injection, it would go to a 9-weekly injection. Make sense? Then if the patient was doing well, they had an assessment of disease control. If the answer was yes, they got a further increase in the time between those injections. And if they did really well, they came off treatment altogether, having gone through that titration. If they didn't do well, of course, the titration was stopped, and the patient was either left on their biologic or the interval went back to the way it was before. So the question is, did it work? So they randomized just under 40 patients in each arm. The trial was somewhat difficult to enroll. They didn't fully reach the sample size that they'd aimed for, but the results nevertheless were very interesting. So 35 versus 37, and what you see is that the number of exacerbations is slightly higher in the titration arm. What's interesting, they managed to get about 20% of patients off the biologics completely, and then about a third of patients could titrate to reducing the amount of biologic they were taking, but not get off completely, and about 20% couldn't get off at all, couldn't reduce dosing intervals at all. So there's a slight increase in exacerbations, and here's where outcomes in trials are very important. This was a non-inferiority study. The non-inferiority margin was set at 25% increase in exacerbations. That's a little bit generous, given that we're licensing drugs in COPD, for example, based on a 20% reduction in exacerbations. It's difficult to argue that a 25% increase wouldn't be clinically relevant. Nevertheless, with that definition that they used, looking at the Kaplan-Meier curve, there's no significant increase in exacerbations with the titration versus the no titration. And there was no significant worsening of symptoms. Of course, eosinophil counts go up if you use less anti-IL-5 biologics. So this, I think, is a really interesting study. It doesn't conclusively say you can wean. It doesn't conclusively say you can't wean. What I think it probably says is that you need to do everything on a case-by-case basis. Nevertheless, 1 in 5 patients got off their biologic and were stable with no exacerbations. That's an important message. So a really interesting study. Moving on to long COVID, very quickly. Long COVID causes multitude of symptoms, but exercise limitation is a major one. There's been a lot of controversy around rehabilitation, patients and patient organizations reporting things like post-exertional malaise, suggesting rehabilitation may not be safe in these patients. And so this randomized study from the UK randomized patients to either face-to-face rehab, usual care, or remote rehabilitation. The primary outcome was the incremental shuttle walk test, which is widely used in the rehab literature. Here's the flow of patients through the study. You can see approximately 50 to 60 patients in each arm randomized. The characteristics of the patients are shown there. And what it showed was that the face-to-face rehabilitation was beneficial. This is the change in the incremental shuttle walk test. Anything above this line is above the MCID. So the improvement in the face-to-face rehab was clinically relevant. There was an improvement in the remote rehab, but it didn't reach the minimum clinically important difference. And there was no benefit in patients allocated to usual care. So the message is rehabilitation face-to-face is beneficial for long COVID, and it's certainly safe, which answers a question that kept coming up in our practice. I can't possibly give a talk without mentioning bronchiectasis, so I have to have one paper on bronchiectasis, and I really love this study this is from Hong Kong, big database. They've taken patients with bronchiectasis identified from an administrative database, found people treated with long-term macrolide, and matched them using propensity scoring to patients that look identical but didn't get a long-term macrolide. The question that's being addressed here is that macrolides are underused in bronchiectasis, in my opinion. One of the things that drives underuse is people are worried about QT prolongation. There's a black box warning on clarithromycin in the US because of cardiovascular events. So the question was, are these drugs safe when used in a big population? And so they took these patients, matched over 1,000 macrolide users to 2,000 non-macrolide users, and looked at long-term outcomes. And the results are cool. So this is the cardiovascular outcome, which is major adverse cardiac events. That's MI, stroke, etc. There's a 30% reduction in the risk of cardiovascular event. Not only are they safe, they're not increasing the risk, they're actually reducing the risk. Look at the all-cause mortality, 17% significant reduction in all-cause mortality. All of the other endpoints are also reduced, and there's no increased risk of ventricular arrhythmia. So that QT concern appears not to translate into any kind of increased risk. So this is fantastic data, and it makes sense. The message here is that although macrolides do have cardiac side effects, they may prolong the QT, the risk of getting an exacerbation, which carries an increased risk of cardiac events, is worse than any possible side effect of the drug. Prevent exacerbations and you do benefit to the heart is the message. And this is the Kaplan-Meier curve showing that very, very clear benefit. So in the last minute or so, let's talk about e-cigarettes. And this is, I know, a really big issue in the UK, where there's a lot of young people using e-cigarettes across Europe. I believe they're illegal in India, but there is a significant underground utilization of these products in the young people of India as well. So I've got two studies on e-cigarettes, one on the acute effects and one on the chronic effects. So this is a very nice study on the acute effects. The researchers here took 72 people who were using e-cigarettes. They forced them to abstain from e-cigarettes for 12 hours, so everybody's at the same baseline, did pre-baseline FEV1, FVC, spirometry, and then got them to vape liberally for 1 hour, and then repeated their lung function. And what you see is a clear decrement, statistically significant, in FEV1, FVC, and in the other lung function parameters. Simple message, putting toxic chemicals from e-cigarettes into your lungs causes an acute reduction in lung function. Really simple but very important study. What about the chronic effects? This is much harder to study, of course, because patients are complex. They smoke lots of different things, not necessarily just e-cigarettes. But this was a well-conducted study from Canada. They took patients who were using e-cigarettes and got a control population matched who were not using e-cigarettes. As you can see, 118 patients, 51 versus 67. They then classified the e-cigarette users into those that were using, had ever used e-cigarettes, and then those who were habitually using them, meaning every day. And they used lung clearance index to look at ventilatory inhomogeneity. And a higher value on the LCI, lung clearance index, means worse lung function, means more ventilatory inhomogeneity. And the simple message is that all of the measures were worse, particularly in people who were daily using e-cigarettes. The other interesting thing in the study was that when they adjusted for cannabis use and cigarette use, a lot of the effects were attenuated. E-cigarettes were still bad, but the combination of e-cigarettes plus other things that people were smoking was obviously worse. This is an important message for us as clinicians when we're taking smoking histories. So many of the patients in this study were smoking more than one thing. So we need to make sure that we also ask our patients not just about conventional cigarettes, but about e-cigarettes and about cannabis, because patients are putting an increasingly varied amount of things into their lungs. So that's 5 really important topics of the many that we publish in the ERJ. The last thing I want to say, other than that it's a great place to come for really exciting science, is this is a great journal for you to publish in. There's no submission fees, there's no publishing fees. It's one of the few journals where if your paper's accepted, you will not be asked to pay anything unless you want open access. And it's very high impact, not just because of the impact factor, but the other aspects of publishing with the ERJ, which means dissemination of the information through the European Respiratory Society, ERS News, ERS Vision, on the respiratory channel, etc. So this is a society journal, meaning it's your journal. The journal is run for the benefit of the respiratory field and for you. So please do consider the journal as your top choice to publish your best research. Thank you very much.
Thank you so much. It was a fabulous presentation. Thoroughly enjoyed all the 5 papers that you selected. And we are going to send a submission very quickly to ERJ. I think we are having such a wonderful session, full of knowledge, full of excitement. And now we're going to have a wonderful panel. And for that, I'd like to call our moderator, the brilliant, the fabulous, and a very dear friend of mine, Dr. Priya Ramachandran. She heads the Department of Pulmonology at St. John's Hospital, and she is passionate and does fantastic work in pulmonology.
Thank you, Amita, for your kind words, and thank you, ICS and ERS, for this opportunity. Now I call upon the panelists, Professor James Chalmers, Dr. Christopher, Dr. Pilar, Dr. Preeti, Dr. Rohit, and Dr. Ujjwal Parakh. I'm sorry, I came in today morning. I believe you've had a wonderful discussion from yesterday, so I missed a lot of it. So, but still some of my questions might be a repetition of what you've already answered during the course. So, Professor Chalmers, there was a question that we need to start the biologics early. How early is early? And what are the effects of it on a long-term basis?
Yes, so this is an important question. So biologics are very effective, as we've shown. They're very effective for specific subtypes of disease defined by biomarkers. And so I think in somebody who has very significant asthma, lots of exacerbations using a lot of corticosteroids, the benefits of biologics are clear. Steroids are horrible toxic drugs. We want to avoid the use of steroids as much as possible. And so it's always a shame when I see patients who have now been referred for consideration of biologics and they've had several years of repeated courses of oral steroids with all of the side effects of those. So when I'm thinking about what we mean by early, I think it's patients who are high risk, meaning they've got high biomarkers, hot, high eosinophils, high FeNO, having exacerbations. You're much better to get in there and get that disease controlled early than to mess around. So if patients are on high dose ICS, they've tried LAMA, they're high biomarkers, in our practice we would be getting those patients onto biologics as early as we can.
Okay, so Dr. Christopher, what is your take on it?
On biologics?
On biologics, how do you practice?
Well, we strictly follow the guidelines, but you're asking about how early
How often are we able to do it? Guidelines are one side. Practically, how does it translate?
Yeah. Practically, the limiting factor for people who fulfill criteria is the cost. So we really have to, so it's affordable people get a different kind of care and others get ordinary care, and that's because of the way healthcare works in our country. We would love to do a lot more biologic treatments in patients, but we are constrained. On the other hand, how early we can do it obviously will increase the amount of biologics used and also impose constraints in terms of cost. If you get more people in the net, this will start showing more.
And
Priya, sorry, I'll just interrupt. So we have Dr. Preeti Meshram. She's from Mumbai. She heads the JJ Hospital. And she has excellent experience with biologics, though she deals with patients who are really underprivileged. So can you tell us something about how you're managing this?
So good afternoon, everybody. So we are a government setup. So for us, cost
It's not so much because we have patients who somehow get sponsored in terms of medications. But we are very, we follow the guidelines to the T. I mean, we see patients who are really very sick and who really fit the criteria, because I believe, unless you pick up the patients who really need them, the outcomes are not very good. So we have to be very specific, and only once we establish a diagnosis of severe asthma, once we know that it is TH2, then only we go ahead with the biologics, since not very early. It's always,
The remission criteria is one thing. Probably the next Dr. Rohit can answer. The remission criteria says FEV1 more than 80%. Would you ever reach there?
So as per data, it's been done. With that being said, for me, remission means the patient is off systemic steroids for at least an year, is not having exacerbations, the symptoms are well controlled, not requiring rescue inhalers. That is good enough to call it a remission, if you ask me. But that being said, you come across those super responders, who are doing wonderfully well. So my first case in which I used benralizumab was my additional MS, medical superintendent, and this gentleman was having diabetes, he was having hypertension, and every time he got corticosteroids, things would go off. And once I started this on him, he was started on biologicals. He came a few months later and said, I occasionally forget to take my usual inhalers. Is that okay? And I had to tell him, no. I mean, you're doing really well, but that does not mean you stop your inhalers. But that being said, you do come across, those well-selected patients who are going to do very well, and then you come across those patients who are not doing so well on biologicals also.
But the bottom line is everybody needs to use their inhalers properly and regularly.
You cannot
which
go
is
to
the
step
biggest
5 and
challenge
forget step.
for all of us.
Yeah, agreed. You cannot go to step 5 and forget step 1, 2, 3.
Yes, that's the biggest challenge.
Yeah, that's a really important message. Biologics are a very expensive way to deal with non-adherence to inhaled therapy. So that's a very core part of what you do when you assess patients for these kinds of therapies.
So to convince somebody who's doing well, continue your inhaler in spite of symptom control is the toughest thing that we face in clinical practice. So biologics are not the answer to that. So this is also discussed. So how do we study?
I think there's a question at the front.
Yes.
I have a question. Like, why do we often hear more of biologics compared to allergen immunotherapy when we are talking about remission in asthma and long-term remission? Because allergen immunotherapy is much more cheaper, I guess. Dr.
Should we ask Dr.
Christopher and Dr.
Christopher, because
Chalmers.
he's the allergy king of India. Oh, Dr. Preeti.
Yeah,
I think both can answer.
I think when you look at the allergen panels, we have multiple allergens most of the times. And when you talk about immunotherapy, it's usually for 1 or 2. So when we have a whole panel, we have multiple allergens, then biologicals with a TH2 type would be the option.
Dr. Christopher, would you like to answer?
I would just add that, the quality antigens or allergens have not been available in our country. I think we now have oral, sublingual immunotherapy become available in our country now. So that is of international quality. So it is likely that it will be used more. Having said that, allergic rhinitis and other situations have much better success than asthma itself. Yes, allergen immunotherapy is much less used in India, probably in other parts of the world as well, than perhaps they should be.
It was a fantastic question. Thank you.
So now coming to macrolides. So given the Indian perspective, Dr. Chalmers, do you think it would be as effective in post-TB bronchiectasis as it is in non-cystic fibrosis? What's your take on it?
Yeah, that's a really good question. So the 3 randomized trials that there are for long-term macrolide in bronchiectasis were done in Australia, New Zealand, and the Netherlands, all areas with very low rates of TB. So although not reported in the papers, you can kind of assume that none of those patients had classical post-TB bronchiectasis. So I think if anyone's looking for a great research idea, a small trial of macrolide in post-TB bronchiectasis in India would be incredibly informative and incredibly helpful. On the other hand, all of the data for macrolides so far shows the efficacy is independent of the underlying cause, it's independent of the underlying bug, it's independent of the underlying lung function. They work remarkably well across all the subtypes that we currently know of bronchiectasis. We've got no strong reason to believe it wouldn't work in post-TB bronchiectasis based on all of the data that we've got available. So right now, if I had a patient in front of me who's got post-TB bronchiectasis, I would use it. I have a huge clinic. I look after about 1,000 patients. Probably 10 or 15 have post-TB disease. I use macrolides in those patients. I think it works. So that would be my current position. But I do think it would be a great thing to look at from a research perspective in India.
Okay. Dr. Preeti, what do you think? You would have definitely used it. We don't have literature.
So we do have a significant amount of our patients are post-TB bronchiectasis. We have a high prevalence of tuberculosis in India. We're also picking up a lot of NTMs. So NTM and a past history of TB, we actually do have to rule out NTM and TB before we actually start macrolides in India. So upfront, without ruling out tuberculosis or without ruling out NTM, I would really be not sure about starting macrolides, especially in the long term, because NTM, it would be really difficult to treat a NTM which is macrolide resistant. So I think starting upfront would not be very easy unless we rule out the infections.
Dr. Parekh?
Just a comment, we need to really assess our post-TB bronchiectasis patients whether their bronchiectasis is increasing in other areas or not. Or it is only that diseased area or the recovered area of tuberculosis is only the area where the bronchiectasis is there. So that's also important before we really decide whether these kind of therapies are going to be that effective or not, because we are worried about increasing bronchiectasis.
Yeah, symptom control. Now that we are doing CT scans more often, COVID made a difference in our
Bye, Dr. Christopher.
approach.
Thank you so much. Have a safe flight. Yeah. Thank you. Take care. Bye.
So,
can I say something?
Yeah.
We have
After
an embark study
my
data.
observation, after COVID, we've been doing quite a lot of CT scans. Prior to, I think respiratory medicine is for us pre-COVID and post-COVID in a big way. So that changed our perspective of the diseases and people's perspective about us as well.
So just answering Dr. Ujjwal's question, we have the embark study data. So the most common cause of bronchiectasis in India was post-TB bronchiectasis, 30%. And unfortunately, the post-TB bronchiectasis had more exacerbations. The exacerbations were worse. They had more hospitalization.
And they're much younger as well.
Yeah, and younger, and hemoptysis was a major problem.
Major problem. So this is very different from the Western bronchiectasis that we read. So we need to develop our own literature for that.
It would be great, we should do this, all of us together, multi-center.
We need to do a multi-centric study, and what we see is the diseases that North faces is very different from what is seen in South. So that's another big North-South divide happening. So, Dr. Ujjwal, what do you think, Dr. Lung India study on EBUS and use of HFNC. Do you think it will change our practice, change your practice in the next? What are the challenges? How do you think it is going to help you?
See, I think our use of HFNC has increased after the COVID. So we used it a lot at that time, and that understanding has gone up in becoming more familiar with the instrument and using it more often. And of late, we are using HFNC in our bronchoscopy suite, especially in patients in whom we consider that they are having borderline hypoxemia, or they are having they're going to be having a prolonged procedure. So I think adding HFNC is a good idea in your bronchoscopy suite whenever you are thinking of having a prolonged procedure. But there is always a caveat, because this is just going to take care of the oxygenation. So it is not taking care of the ventilation. So we have to be very, very cautious before using it, especially in patients who have having COPD, who have a history of retaining CO2, and in patients who are having obesity, hypoventilation. In those patients, we have to be a little more cautious about using this, because we may be able to maintain CO2 levels, but their SpO2 levels during the procedure, but if we are not monitoring EtCO2, then that might be going up. So seeing these patients' respiratory rate during the procedure, seeing their effort of breathing, and monitoring EtCO2 is very, very important when we are putting these patients on HFNC.
So since all of you are from the government background, the monetary part of it doesn't come into play. But in that paper, they had said the cost difference was around, I think, 2,500, 3,000 rupees between the two procedures. So only oxygen versus HFNC. So, but if you ask me, if you open the kit for HFNC, that costs 30,000, single use. So,
Yes. So
it increases the cost of the procedure phenomenally.
So definitely, whatever we are using, we have to use that judiciously. We should be absolutely sure that it is indicated. So it goes without saying.
So that was the very big issue that was there. If we could manage oxygen with something else rather than being pushed into, unless we are pushed into HFNC. So I'll skip the TB question because it was all a complete review. We're all very familiar with it. The lung cancer.
Yeah. So that was a
sorry.
really interesting paper when they got all the data from the national registries
Yeah.
and talked about lung cancer. The thing is, from two perspectives. One is from lung cancer screening and one is from the management point. For lung cancer screening, we often say we have the lung cancer screening trial and can we have a similar screening trial in India? And one of the arguments has always been the amount of nodules that we'll find in a TB endemic country is there. That aside, look at the criteria. The criteria is 55 and smoking index. But once we went through the registry data, we find that a lot of females are having it at the age of 45 and, are non-smokers. So if I start lung cancer screening criteria for India, probably I'll have to
miss 50%.
revisit all of them. And the other thing from the point of treatment, what was surprising for me was a lot of patients were operable, but did not get the surgery done. So I think, it's not just the delay in diagnosis, which is obviously there, which, often we find that patients are misdiagnosed as TB before they come to us. The other part is, even after the diagnosis, we need to really build up our cardiovascular thoracic surgeons. Their team has to
Is
start
it
doing
that, or is it that the patient was inoperable, like a bad COPD?
That's definitely there. But
coexistent diseases.
So in my practice, I've rarely come across a person being denied surgery because he was inoperable. It's because, after optimization, most of them are fit for surgeries. Yes, you come across those patients where you can offer them radiotherapy also as you burn off the tumor and do your bit of the work. That being said, I think the cardiovascular referral system is something that needs to be built up. We have a lot of cardiovascular surgeons. We have few thoracic surgeons.
Thoracic surgeons.
Yeah.
So now I think they are branching off into three different:
I hope
vascular,
so.
cardiac, and thoracic. And the other thing that was before 2019. So the scenario has changed quite a lot with VATS and all that coming into the picture, improvement in anesthetic management.
One thing that you'll have to see is this is from regional centers, which are quite apex centers for those states. If you go into the ground, the grassroots level, things are still not as rosy as we see them on our practice.
But unfortunately, I think all of us will agree, we hardly ever see anybody who's operable. Number of patients
we do get cases
that we see is still pretty low.
That's where screening will actually come in, but I think we have to have our own criteria also.
But one thing which we are seeing is the sputum negative TB being treated has come down quite a lot now.
Yeah.
After COVID.
That's there, and the other is the judicious use of bronchoscopy. Every time sputum negative, at least your bronchoscopy, and even then it's negative. Follow your patients.
diagnosis.
Follow your patients. Don't wait for 6 months to say, oh, this was not TB.
Sure. Any other
Just-
questions from the audience?
Just a comment about the diagnosis of tuberculosis. Well, a lot of countries have not been able to afford a proper screening program, right? So what the way forward to it would be an opportunistic screening, where a person comes and he's being investigated, and then if we consider that they are high risk or there is a possibility, we raise an alarm and ask him to get this test again. Or maybe he's getting investigated for something abnormal is seen on an X-ray or a CT scan and has been reported and he's investigated further. So I think we need to develop this understanding also that opportunistic screening can also give the similar kind of results in diagnosing these patients early.
Okay. the last questions are on e-cigarettes. So, do you
Dr.
think,
Pilla hasn't answered.
Dr. Ortega, it could be a cause of ILD? Where do you think chemical injury happening to the lung, the interstitium, from early stages, you are seeing a spirometry variation over a period of time?
Very good question, and the quick answer is yes. I think it's for sure. I think it's electronic cigarettes with or without nicotine, but they contain over 100 different toxins. I said toxins because they contain components that they don't belong to the airways or to the lung. They can cause acute lung injury and also potentially chronic lung injury. The only problem is that we are still not having enough long-term data to be able to compare. But we have, I think, it's very interesting studies like the one that James presented. And in terms of clinical cases, we have clinical cases that how electronic cigarettes and the vaping, that can be the cause or the trigger to develop the disease, particularly in young patients. And sometimes I think they are admitted and they become intubated, and of course sometimes could be purely due to the electronic cigarette components, or after that post, of course, admission and post-intubation, or all together, and they have a lot of sequels, and of course the lung function is not the same, the overall lung capacity is not the same, and that I think will be completely different scenarios. So I say it's a great, I think it's a huge problem. It's a huge problem, and I think we see patients with interstitial lung diseases that if they are not active cigarette smokers, but they are vaping, how the disease is progressing, and it's still progressing faster compared to the patients that they are not smokers for any type of smoking. So yes, it's a problem. What we need is a international collaboration, and also with different type of cohort of patients to try to demonstrate the long-term, I think, injury and all the consequence that e-cigarettes can cause in the lungs.
Because e-cigarettes use starts pretty early, I believe. They start in the school and it's pretty socially acceptable. So the side effects may come much earlier. The interstitial injury might be much earlier.
So Dr. Priya, I completely agree with what Dr. Pilla said. But over and above, it also gives rise to hypersensitive pneumonitis reaction, the BIP.
Yes.
And we also causes acute lung injury. And we've had young kids, college-going kids, they got admitted with ARDS after vaping. So it's quite horrendous, and the hypersensitive reaction is very well known.
And unfortunately, I think just now I realized that I've hardly ever asked anybody about vaping. It's a habit to ask about smoking, but not vaping.
Yeah, you're very right.
So we have to ask the second question about vaping to everybody. Yes.
Just a comment on this. It's very ironical that cigarette is allowed in this country and vaping is banned.
You're very right.
So that's really something which is supposed to be less injurious to the health is actually banned than something which is more injurious.
We don't know the injury levels of this one, at least for now.
So that's really ironical.
Probably we can argue over it, saying that if you legalize it, at least you will know that where you are sourcing it and what it contains, and all those things will be there for us to revise.
So therefore, in government's data, the use of e-cigarette is zero.
Zero.
In their data, it is zero because it's banned in India. But we know that it is being used, and therefore studying these effects in India would be difficult.
Yeah.
Because we cannot recruit these patients, we cannot study what they are doing because it's banned in India.
Precisely.
So for us, e-cigarette is not an issue.
Yeah, precisely.
It's
So
not
we
an
had
issue in India.
Oh no, any college you visit, there'll be shops around it.
So we had an undergrad, actually we had undergrad students who wanted to study, the effect of e-cigarettes in colleges across the city in Mumbai. But the EC couldn't give them approval because e-cigarettes are banned in India. So, the prevalence and what are the effects. It was a simple questionnaire-based study, but still,
Just now we've started one. I don't know what's going to happen to that.
Just to put it very simply, anything which produces fumes or toxic vapors or fumes is injurious to lungs. So what is the reason to study it? I don't know. Is there a reason to study it separately than just studying smoking?
See, it contains a lot of hydrocarbons which are very different from probably
we
cigarettes.
know that. We know that with our understanding in other diseases where these are used and from industry where used. So studying them separately, I don't know whether it's a really useful thing or
Professor
not,
Chalmers
because
can
all those
highlight
things
that.
are being studied separately already.
Yeah, I take the point. I mean, you could just say, you could take the view that we don't need to know much more. We can just say to patients, lungs are designed to take fresh air in, and that's the only thing that should go in. I sympathize very much with that view. On the other hand, there are a number of debates going on. So in Europe, these are not banned, and there are definitely large schools of thought that are saying to patients who smoke conventional cigarettes, why don't you switch to vaping because it's maybe safer. There, the safety is incredibly important because we may be recommending something that in 20 years we'll say is just as bad. So those questions are actually, I think, incredibly important. So we can, at the moment, we can say e-cigarettes look from lung function, from in vitro data, from cell culture data, like they induce changes of early COPD. We don't at the moment know how bad they are. We know they're bad. I think it probably is still important to know how bad they are so that we can properly counsel patients. But I also think what you said is also what I say to my patients. Just don't put anything in your lungs. Yeah?
So pollution is as bad.
Yeah.
Fresh
air and that's
answering your
it.
question about tobacco industry is just too powerful. So government gets most of their money through tobacco. So they will never ban cigarettes. That's
No, you don't need to ban it. You legalize even e-cigarettes. That's what I'm saying. At least you can study the effects and the side effects of it.
Yeah.
Now everything is on this podium has no value.
No, the e-cigarette people are still not that strong. So they don't want to introduce them, whereas they can't do away without tobacco industry. I believe that must be the same in your country also, right?
Yeah, just a quick question on criminalization. So I take the point, you ban it, people are doing it anyway, and you want to study it. The Canadian experience is really interesting. They've legalized cannabis, and the rates of cannabis smoking have gone through the roof, and now they're facing a huge issue with COPD induced by cannabis smoking. So making things legal kind of sends the message that this is okay, and does result in people doing more of it. So you've got to be careful. You know, maybe India's taken the right approach, which is at least sending a clear message: this is bad, don't do it.
Probably we all agree to this that legalizing this is not a solution. It's actually creating more problems because there might be other things associated with this, which will all come in front. So legalizing is not the answer.
We've had... Yes.
Politics and the government of India. So it will never happen. Keep on discussing.
So
Thank you.
we've had a wonderful session. Thank you so much. Priya, you were brilliant. Each of our panelists were just awesome. Thank you so much. You know, you all made it a beautiful panel. And we have really ended on a crescendo. A huge round of applause for them.
So we came to the end of the 2 days academic extravaganza that was happening, and we are all really thankful to the ERS faculty for traveling across the ocean and coming to India for imparting their part of the knowledge to us. We are thankful to the ICS faculty for sitting patiently over 2 days and listening to all our talks and helping everyone with their doubts. We're thankful to the delegates for coming in on a Saturday, Sunday weekend and listening to the academic talks that were happening. So as we proceed to the end of the session, we would like to call upon stage Professor Johanna, Professor Dr. Rakesh Chawla and Dr. Amita Nene ma'am for handing over the certificates of the oral presentation and the e-poster presentations that happened over the weekend.
So we are going towards the end of the entire ICS ERS summit, and I would just like to say that it's been wonderful 4 days of academics. We are so grateful to ERS and our brilliant, accomplished, amazing faculty for taking out so much of time for us. You know, I'm sure how tired they must be, but they have been just amazing on stage. So again, a huge round of cheers for our most amazing faculty. Hip hip hooray, hip hip hooray, hip hip hooray. A big thank you to ICS and all our delegates, and I would like to take this opportunity to thank our sponsors, because without them this would not have been possible at all. So a huge round of applause for our platinum sponsor Cipla, who have spent their efforts for months together to make sure that we could run the show so grandly. I would also like to thank Sedna, Juventus, Schiller, Pfizer and Abbott for being our partners and for being by our side strongly and solidarily. Thank you. Yes, sure.
Not to forget, my friends, my ICS, the whole program was before we took over, Rajesh Surankar and Rajadhar. 3 cheers for them. They were behind to get your whole team here. Professor Joanna, Professor Omar Usmani, Professor James D. Chalmers, Professor Ehtab Bedawi, Professor Paola Rogliani, Dr. Pilar Ravira Ortega. We are all thankful to all of you to be here, and more illumination, more clarity we got after the meeting was immense. It opened so much things to us. We are thankful. We are thankful to you, ma'am. We are thankful to the whole team from Coroforon and looking forward for 3.0 2027. And ma'am Isabel, I forgot. I forgot because given it was Raja who wrote all this, he forgot to write your name. Thank you.
Isabel and Steve.
Yeah, Isabel and Steve, yes. We are thankful to both.
In making this happen.
Yes, thank you. And Raja told me Steve is the most important. Don't forget to meet him. Thank you. Thank you, sir.
Prize distribution, yes.
Prize distribution.
So before we come to the most important part, I would like, on behalf of the ERS delegation, I would like to express my thank yous. We are truly grateful for this opportunity. I think it was a fantastic meeting. We learned a lot, and we are looking forward to the ERS Indian Summit 3.0 next year. Thank you very much for having us.
Thank you.
So please come to the middle. I'll call them. Yeah. So with that, we would like to call up the oral presentation winners first on stage. For the second prize, I'd like to call on stage Dr. Vivek Kumar. Dr. Vivek Kumar presented on clinical spectrum and radiological patterns in high altitude illness, a case series from the Himalayan region. Dr. Vivek Kumar for the second place in oral presentations. I'd request Yona ma'am to hand over the prize to Dr. Vivek Kumar. So for the first prize in the oral presentations in ERS India Summit 2.0, I would like to call on stage Dr. Sakshi Bist. Dr. Sakshi Bist presented on spectrum of bacterial and fungal infections in sputum smear positive pulmonary tuberculosis patient, and she hails from PGIMS Rohtak. She is a postgraduate trainee there. So a loud round of applause for Dr. Sakshi Bist. Up next for our e-poster presentation winners, I would like to call on stage the third place goes to the Cipla medical team, Dr. Kalpesh Panchal. He is not here, so anyone from the Cipla medical team, please come forward and collect your prize. The second place in oral poster presentation in ERS India Summit 2.0 goes to Dr. Ioniza Maitri from Medacity Medanta. Dr. Ioniza Maitri, she presented on IgG4 related disease with severe laryngeal, tracheal and bronchial involvement, a case report on diagnosis and airway management. And the first prize in our e-poster presentation goes to Dr. Apurva Singh. She presented on sex-specific differences in obstructive sleep apnea. Dr. Apurva Singh for the first prize in e-poster presentation in ERS India Summit 2.0. With that, we come to the end of ERS India Summit 2.0. Thank you everyone. Please join in us for lunch.